welcome to everybody who's come this evening. I think we've got an interesting evening. I hope you're going to enjoy it.
I remember another patient who we both looked after who, was in a relationship with a chap, getting serious, thinking about starting a family. And I remember her bringing him to clinic, him getting tested, them coming back to get the results. He was trait. This was one of our patients who had sickle cell disease, and she dumped him in the room.
Yes, she did.
Dumped him in the room in front of
us.
I remember.
And I said, Mummy, I'd never let you get a vaccine that is not safe. So I'll be the first one there, and then once I've had it, you can have it. And I remember this text message coming back to me while I was at work, well, you'll be the first to die. But every touch point, be talking to women about the importance about having the vaccine. And if you don't have information, say that to somebody. I don't have the information. Can I pass it on to the person that can?
Some women are saying that they're actually having a really positive breastfeeding experience because their situation of having to stay at home and not having lots of visitors around and not feeling they have to rush about everywhere means they've actually got the excuse almost to sit on the sofa and just breastfeed their baby.
So Black and brown women and birthing people are not treated with equity, leading to unacceptable levels of morbidity and mortality. They then become marginalised communities that become mistrusting of maternity services, and they might be reluctant to engage because their initial experience has been negative. We then label them as difficult and unwilling to engage, and the cycle of substandard care continues.
It's really difficult to describe really what makes continuity happen, but there is some real magic in the depth of relationship that you have with a woman and her family, and it's really beyond articulation. We know it works. It definitely works for our women and our families, and if you always put them in the very centre of what you do and how you work, that is when the magic happens.
Are you a midwife, maternity worker, or having a baby? Then we've got something for you.
To stay informed, exchange ideas and receive support, come and join our growing online community at allformaternity.com.
All for Maternity is an online platform offering areas to support your learning, sharing and caring needs. In our learning zone, we provide dynamic and informative e-learn modules, access to regular webinars and online workshops that address current maternity care issues, perfect for your professional development.
Our sharing zone provides repositories of information, bringing you evidence to inform your everyday practice and care. Access to support in the form of blogs, forums, podcasts and peer mentoring networks will be included in our caring zone.
We have so much to offer. Subscribing to All for Maternity will give you access to the Practicing Midwife Journal free of charge.
As the first midwifery publishers of the Practicing Midwife, we are delighted to have an opportunity to sustain, curate and nurture this important midwifery journal.
For us, the Practicing Midwife represents you, students, midwives and maternity carers.
As mother and daughter midwives, we've always wanted the opportunity to work together. We share the same philosophy that mothers and babies need the best possible maternity care. All for Maternity helps us to realise this dream.
Through All for Maternity, we will offer opportunities and encouragement to others, providing a springboard for personal growth and positive exposure.
Extending our support globally is important to us. Your membership will support you whilst helping others. For every subscription from a high-income country, one will be gifted to a maternity carer in a low-income country. Joining All for Maternity will give you access to all this and more.
So if you're ready to learn, share and care with us,
we look forward to connecting with you at allformaternity.com.
Midwife working in 2030 is going to have to be adaptable, flexible, knowledgeable.
A lot more skills around kind of negotiating and advocacy for women.
It's multidisciplinary, it's working with students, doctors, partners.
In 2030, I hope very much that women, when they come into maternity services, receive a named midwife who is present for as much of that full journey as possible.
One of the benefits, I think, of a platform like this is that if you are busy clinically, or if you can't watch or listen or engage real time, you can do this at other times. So that is fabulous for such a time as this. So delighted to be with you all, albeit virtually on the screen. My name is Jacqueline Dunkley-Bent. I'm the Chief Midwifery Officer for the NHS in England.
So this is what's called a hybrid event. There are people in the room, there are people watching in groups around the country, and there are people still watching in their pyjamas at home. Good morning, Sue, how are you?
Good morning, I'm fine, Neil, thank you very much. It's fantastic to be here.
My argument is that the solution is health optimization. Prevention is far better than cure.
And I think there is a real risk that services that are lost or reduced during the time of COVID are not restored.
And I hope that you can take valuable insights from today. And if you're listening tonight, or if you're listening next week or next month, take valuable insights from the speakers from today and share the word, share the positive messages with your colleagues, because in these dark times, in these challenging times, everybody needs a green shoot and a pearl of wisdom. Thank you very much, and we are in this together. We stand united together.
Welcome everyone to this Student Midwife Experience Festival, and to everybody that's watching from the Educating Midwives conference, which is running in parallel. My name's Neil Stewart. I'm the Editorial Director at the Maternity and Midwifery Forum, and this is one of our live festivals that we are running. You'll be pleased to know that we have over 1,100 people have registered for this. I'd like to welcome everyone who's watching from the Arab Emirates, Austria, Switzerland, Greece, Indonesia, India, Italy, Malta, Paraguay, Reunion, Slovenia, Turkey, the USA, and all the other places that have started watching this international material. And that's one of the great things about this technology. So this morning's session is a joint session where we have both a student audience online and watching in watch parties. So a big shout out for all of you that are in seminar rooms and lecture theatres, especially the ones in Salford, who I know have got cakes and buns and other things that I'm sure will be banned by the end of the year as bad for your health, but nonetheless, enjoy them when you can. The idea behind this festival was that we needed to give a chance for student midwives to get together, their societies to get together, and really to reboot after this period of the pandemic, when hopefully, as we hoped at the time, things would be getting back to normal. We're not quite there yet, but there's lots to learn. And also to give people a chance to reflect on the disruption and how we've coped with so much learning having to move online. What are the positive things that can come out of it? What are the things that we want to carry on with? But what are the problems that have got to be tackled? And to have a good day of networking and fun. And in the gaps in the agenda, we hope that those of you that are meeting in your student societies will take the time to meet your officers, plan your schedules, not just eat the buns, but have a good time. For those of you who are doing this as part of adding to your portfolio or as part of your revalidation, you can get the certificates afterwards. We'll put some information about that in the chat, etc. And if you are have access to the chat, say hello, let us know where the groups are coming from. And for those of you who want to post pictures of your groups and of people viewing, if you can send that into the hashtag and spread it around on Twitter. And we'll try and make today as much fun as we possibly can. So one of our ambitions was really to try and look up from the pandemic and look forward. It's true that for most students, you're trying to look forward to what their career might be. And of course, it's a challenge for lecturers and academics to plan and to deliver that. So in our first joint session this morning, we have two contributions, one from the NMC with Jackie Williams and Verena Wallace, taking people through the future midwife standards, and then a presentation from the wonderful Fran McConville, who's coming to us from Geneva, who will bring an international perspective, and I'll say a little bit more about Fran when we come to her presentation. So I'd just like to start off by doing a little poll. So if we could run poll 3 and get that up in front of people. So just to test how it works. What are best things you have liked about midwifery education over the past year? And we've given you a selection of words, but you can put any word in as long as it's not naughty. But you want to try and find out what are the positive things in a world that seems to spend all its time moaning. So that poll is open now, and we'll leave that open for a few minutes, and you'll be able to see that if you're watching online. So please take part, and it'll teach you how to use the Slido system that's operating, and we'll just do that as a test of opinion and see what surprises we get. So I'll leave that running while we go to our first presentation. So the first presentation is on future midwife standards. And to do this presentation, we have Dr. Jackie Williams, who is the Senior Midwifery Advisor on Education, and Verena Wallace, MBE, congratulations, Senior Midwifery Advisor on Policy at the Nursing and Midwifery Council. They both have extensive careers, and we'll be posting their biogs and things. And when you come back to review it all, you'll be able to see the kind of career that you can plan for yourself. So, Jackie Williams and Verena, the screen is yours.
Thank you, Neil.
Thank you very much, Neil. Good morning, everybody. It's lovely to see you all or hear you. And my name, as Neil has said, is Verena Wallace. I'm one of the senior midwifery advisors at the NMC with a particular background in policy. And I'll just ask Jackie if she would mind introducing herself, and then I'll go into the presentation.
Good morning, everybody. Absolutely delighted to be here. And it's just absolutely amazing that we are speaking to so many people online. And I hope you have a fabulous day. And I hope you find what we're going to talk about useful. And I'll come back to you later once Verena has presented the first few slides.
Thank you, Jackie. We tend to operate as a bit of a double act. So I'll go first and then Jackie will take over and do the rest of the presentation. But what I'd like to do first, if I could have the next slide, please, is just to take you through a little bit about the development of the new standards and the language of the new standards. And the work for this started in 2017 and was very ably led by Professor Mary Renfrew of the University of Dundee and Professor Gwendolyn Bradshaw of Bradford. And they pulled together a thought leadership group, which included students, educationalists, researchers, midwives, and over the 2 years, they looked at the evidence, pulled together the policies, the suggestions, the thinking, and put it all together into a paper, and then draft standards that were seen by the NMC Council and went through the governance processes of Council. There was a very big consultation period, and then all the findings from the consultation were pulled together and put into the final standards. The standards were published in 2019 in November and launched in early 2020. And it's worth saying that there was a decade in between the previous standards and these new standards. And some of the key things that have changed are in this slide, and I'll just take you quickly through some of them. It's worth emphasising that the key point that we were very keen on was that these standards would be evidence-based and would be future-proofed. And for those of you that are being educated in midwifery in the United Kingdom, these standards will form the basis of your curriculum for probably the next decade. So it's very important that they were flexible enough to be used to develop and expand curricula within the UK, and also to take on board anything new that comes out of the research and the evidence as we go forward. So within our new standards, we have 6 interconnected domains, and it's very important that they shouldn't be sort of read separately. They need to be considered in the context of all the domains. And there are 17 sort of golden threads that run throughout the proficiencies. And these cover things like evidence-based care and the importance of staying up to date with current knowledge, enabling and advocating for the views, preferences, and decisions of women, their partners and families. And that's about putting the women and their families at the centre of the care. And it's about providing continuity of care and carer. And again, using the evidence that's been around for a very long time about the benefits of continuity of care and carer, and optimising the normal processes of reproduction in early life, and the importance of understanding and working to mitigate health and social inequalities, interdisciplinary and multi-agency working, absolutely key to the work of a midwife in the 21st century. And we based the standards on the framework for maternal and newborn health, the Lancet series on midwifery, and Jackie will refer more to that later in the presentation. The role of the midwife is clearly stated. And for those of you that have copies of the standard or access them online, I would suggest that there's a lot to be said for reading the sort of introduction to the standards, where we talk about the future midwife, the role and scope of the midwife in the 21st century. And that's to provide skilled, knowledgeable, respectful and compassionate care for all women, their newborn infants and their families, And it emphasises about midwives working across the spectrum from pre-pregnancy, pregnancy, labour, birth, postpartum, and the early weeks of newborn infant's life. And that you'll find will lead into what Fran's talking about and the sort of global aspect of the midwife's role. So within this, we're also basing the standards on human rights, ethics, and cultural competence, continuity of care and carer, as I've said, interdisciplinary working. And within this, given, as you would expect, the sort of 10-year gap, there's also new skills within these standards. And the one that we do talk about is the full systematic examination of the newborn. But it also includes a lot more about public health and the midwife's role within that, and around improved knowledge of medicines management, as that is often something that comes up as something that we need to improve. So next slide, please. A key point about these standards, and that one that Mary Renfrew has often referred to, is that they have we have the opportunity within, while using these standards, around transforming care. And within this, there are sort of three key points to it. And this is where the standards come in and develop and pull these things right through. The focusing on the needs, views, preferences, and decisions of the woman and the needs of the newborn infant is absolutely key to these new standards. This is at the core, and all the standards sit around it. And this is about how we educate midwives and how midwives also use these standards to consider their work and consider how they develop their careers as they move forward. Next slide, please. It's about supporting the physical, psychological, social, cultural, and spiritual safety. And it's a very broad definition of safety, but it's absolutely key, and is built on the feedback that we got from women, from midwives, and as I said, from students, educators, and researchers. That it's more, that midwifery is about more than just the physical. It's about these other aspects of care, the psychological care, the social care, cultural, and the spiritual safety, and making sure that we provide the best evidence-based care throughout somebody's journey into new parenthood. Next slide, please. It's understanding the impact that pregnancy, labour and birth, postpartum, infant feeding, and the early weeks of life have on longer term health and well-being. And this is something that we know that our role is absolutely crucial. If we get this right, we set a firm foundation for the rest of somebody's life. So it's absolutely imperative that this is sort of woven through the standards. So I'll hand over to Jackie, who's going to take you through the next bit of the presentation.
Thank you, Verena. Next slide, please. So what we're talking about with midwives and key stakeholders, and of course delighted to talk to students today who will be our new midwives on our register, is about challenging the language of midwifery practice and what our standards say about this. Now, our standards do not talk about clinical risk. It does talk about some aspects of risk and risk management, but not clinical risk. So it's not categorising women as low or high risk. But because they're based on the framework for quality of maternity, maternal newborn health, we're talking about the role of the midwife in the care of all women and newborn infants, providing universal midwifery care for all. And then for women who, for whatever reason, perhaps they enter the maternity journey, or they develop complications, or they have a range of complex needs, whether that be physical or mental health or social. What is the role of the midwife in giving this additional care for women and newborn infants and complications? And of course, it's really important for you as students that through your experiences that you're gaining, that you actually hear this language being talked about as we sort of shift this focus. Next slide, please. So there are 4 Future Nurse, Future Midwife Oversight Assurance Boards, and we work very closely with them. And part of their role is to gain assurance that not just the programmes are being adopted and developed using these new standards, which is of course our requirement by September 2021, but all midwives are adopting these standards and in their own practice, as well as supporting you as students. And we go to a lot of stakeholder, local trust, local health board meetings, regional meetings. And of course, now we're working in this online space. It's much easier to continue to do that. And if you think that that would be helpful where you're working, do let us know, and we can come and do meetings around the UK. Now, as Verena says, when we had the consultation, we were delighted to gain over 1,000 responses from women, their partners and families. And we were really keen to try and close that loop, to give them the feedback, to tell them what we had done about these standards. And we did do that in part in the online space. But what we have done is that we have developed an animation, and the link is there, so you will have it when you have these slides. And we want all women, wherever they are, plus their families, to see this animation, because it importantly talks about the role of the midwife and how they will work with their midwives, being very much at the centre of care. And behind it, it talks very much like almost a sub-message talking about the new standards. And then, of course, if they've got interest, they can then follow that up. And as I say, we hope that women are beginning to see this in the postnatal wards, antenatal clinics, wherever, free to use. So do make sure your midwives know that they can use this. And one of the pieces of work that we're also doing to make sure that midwives really understand the significance of these proficiencies for their own practice is look at revalidation. Now, revalidation, of course, is based largely on the code. We do encourage that during appraisals, midwives can actually look at those standards to see where their development is needed. We've also got heads of midwifery doing gap analysis, so they're developing their own staff in order to get ready for supporting students. But revalidation will be something else that perhaps in future this will be strengthened in terms of the place of the proficiencies in that process. Next slide, please. So what do these standards mean for you? Well, obviously, midwives who are supporting you need to know these new proficiencies. We now have national ongoing records of achievement, one for England and Northern Ireland. Wales have their own, as does Scotland. And that is really, really helpful for supervisors, because they can be only then using one document rather than different documents from different institutions. So they will absolutely need to know these proficiencies to be able to support you. But also, there's many on the call today who are on current midwifery programmes, and I want to reassure you that at the point of registration, you will be absolutely ready to practice as an autonomous midwife. The programmes have far exceeded our standards, which, as Verena said, woefully out of date. So many programmes have already adopted many of the things that are within these new standards. But inevitably, there might need to be some additional things, particularly around the skills that some students might need in that early time and their preceptorship period. But you will be absolutely proficient and ready to join our register at the end of your programmes. The role and the scope of your practice is very, very clearly defined, and this is going to be very helpful as you think about your own development going forward through your career. And of course, our new standards of supervision and assessment for students means that you can be supervised by other healthcare professionals. And of course, they need to be prepared to do that, because that is something that is quite new. And as we say, we believe that the standards have a part to play in the development of the maternity services. And Verena and I, for example, have mapped the Ockenden actions, and they hold up extremely well. They're not necessarily the only answer, but they absolutely, importantly, have a place and a role to play. Next slide, please. So when you get these slides, you might like to have a look at these questions. We've got these questions for maternity services that we're encouraging them to look at their own workforce. But these you could use yourself, just to ask yourself some key questions to see whether you're ready to adopt those new standards. The next slide, please, gives you a legend to see whether you think there is little opportunity to meet this proficiency, or whether you have frequent proficiency. And of course, this will be a great conversation piece for your practice supervisor and indeed with your lecturers. Next slide, please. So the key question that we are asking, and the really key work that Verena and I are doing, is how do we know that every midwife has adopted the new standards of proficiency in their scope of practice? And as you can imagine, we can talk to people, we can support them, and we have to work with others to do this, which in fact we are doing. Next slide, please. So I just really want to thank you. And I particularly want to thank you for all that you have done and your important part that you have played during your programme, but importantly, as a result of the pandemic. The experience you have gained, although perhaps has been challenging at times, will see you through the rest of your career. And you've gained experiences and opportunities that perhaps you never would. And we really want to thank you as the regulator and look forward to you joining our register. And our contact details are there. I'm very happy to follow up with anybody who wants to have further meetings in their own area or have particular questions. Thank you for listening.
Okay, Jackie, thank you very much. Very interesting to see all of this being continue to be rolled out. So much was suspended and held back during the pandemic. We'll hear later on today from Jackie Dunkley-Bent about how moving things forward. I was very interested in the challenge that student midwives might ask about what experience they're getting of continuity of carer. In a midwifery hour recently, we heard from Professor Jenny Gamble of what they've been doing in Australia, where student midwives do actually practice continuity of carer, and it's been remarkably revealing. So if any of you want to catch up with that later on. So we're going to come back to Jackie and Verena a little bit later for questions. So if you can remember to put your questions in the chat, we've got a few of them coming through that are very pertinent on some of these issues about maintaining standards and the teaching of them during the pandemic. And also, if we could close poll number 3. So if you haven't voted, it's too late now. And we'll move on to our next speaker, our next contribution, which is from Fran McConville, who is the midwifery advisor to the World Health Organization. I have to admit that I'm a bit of a Fran fan. I think I first heard her speak about two and a half years ago at a big midwifery birth conference in the Lake District. And the work that she has been doing in the WHO with her colleagues, which helped initiate the year of the nurse and the midwife, but we know it was really the year of the midwife, was absolutely extraordinary. And there are a few times in my long career when I'm really gobsmacked by some of the statistics that are put up on a PowerPoint presentation. But I think 3 or 4 times Fran McConville knocked me off my chair. And it's obvious that she and her colleagues have managed to do that with health ministers around the world. So I'm very much looking forward to Fran's comments. I hope all of you that have any ambition to work internationally will take this in. But it is a remarkable track record of changing the world that I think is at the feet of Fran and her colleagues. So with that mild introduction, Fran, the screen is yours.
Oh, well, Neil, thank you so much. That was very kind of you. But I just want to say hi to everybody. I'm sitting here in the fake WHO cafe with the flags. So greeting from all of us at WHO, and a special greeting from the Director General, Tedros, who you will have seen on the television and in the news. He has nothing but extreme respect for midwives absolutely everywhere. And he really understands your value and how hard you work and just how incredibly important you are. And I feel that midwives don't always realize that they do save lives and that they are loved and treasured so much. And we don't often have the chance to say that, given the circumstances that you're working in. So it's a real privilege to be able to actually talk to students, because you are the future. It's not us sitting here in WHO, it's you who will take this forward. And really massive greetings to all of you in countries from all around the world, because that is so exciting, and really pleased to be able to have you here. So we're going to show a very short film from WaterAid. Some of you may have seen it before, please share it. But I just want, before I go into a roller coaster of information and challenges about global midwifery, take a deep breath. Imagine being in a really low income, low resource country with a woman who is extremely poor, and you really don't have the resources or the education or the support that you need. And this film now, thanks Catherine, if you could put that up, is going to focus on the really essential issue of water during childbirth. So please enjoy this for a couple of minutes.
Okay, Fran, that was great. We're just getting Fran's slides and things up now at the moment. A very striking contrast, that video, between two kinds of experiences of delivering midwifery around the world. And I think a reminder for everybody as to what the really big challenges are. We have lots of our problems here in the UK, but the difference that Fran and our colleagues are making around the world is absolutely extraordinary, and the big advances. It's also a good reminder that a lot of the basics around cleanliness and health and other things are still the basics everywhere, even if, as we'll hear later in the day, some of the science and technology is moving up the chain. So back over to you, Fran, for your presentation. The screen is yours.
Thank you so much, Neil. And as you said, the technology is with us, but not absolutely working perfectly. So I'm very sorry for that pause. That film always just reminds me every time that it is the injustices of inequality that are driving us in this work. It is not right that in 2021, this situation exists. And I know many of you online will experience that yourself and understand it. So that was the film. Please do watch it, share it. It's really seriously important. I just wanted to start with by saying, you know, this is the inequality that we're facing. And this is the Lancet Maternal Health Series in 2016, that globally we have far too much going on. You look at the left-hand side, and I always hope that that was a much needed cesarean section. But in some states in India, for example, we're getting 73% cesarean section rates. That is not right, and it is dangerous. And on the other hand, here's a woman somewhere in Southeast Asia, possibly Nepal or Northern India, Bangladesh maybe. She's not getting any care at all. So we have a situation that I never thought that we would get into 30 years ago, because we've been trying so hard to improve care and access to care. But actually the quality of care is so appalling that it's now a bigger barrier to reducing mortality than insufficient access to care. So if we look at this slide, this is from the Lancet Global Health Series, incredible. If you look at the first arrow, if you look at the blue part of that neonatal death graph, what it shows is that just over half of all neonatal deaths are now taking place in a facility. So what's the point of coming into a facility if the care is so poor that your baby's going to die in the facility? So we haven't really addressed that issue at all. And if you look at the bottom red where it says maternal disease, which I object to because pregnancy is not a disease, but that's how they classified it. It's the same situation, that women are coming into facilities but dying there because of the poor quality of care. And it's a real choice. Do I want to go into a facility where I might die? Why don't I just stay at home? So, you know, we really have to analyze carefully what kind of progress that we have been making. So this is a huge global challenge for us. I'm very glad that both Verona and Jackie mentioned the Lancet series of midwifery and that quality maternal newborn care framework, because we took from that in WHO, we developed this picture I'm about to show, that actually quality midwifery education and care improves over 50 health-related outcomes. And yet we don't see that that's being applied where there is this poor quality of care. So this is a summary of what we found in the paper one of the Lancet. We put midwifery in the middle. It helps women survive, thrive, transform communities, societies. Mortality is reduced, maternal, neonatal, stillbirth, infant. I'm not going to read through all of this, but this is in a document I'm about to share. But harm to women and their newborns is reduced maternal morbidity, incredibly important. Reduced PPH, eclampsia, reduced newborn preterm birth, low birth weight, hypothermia, hugely reduced by midwives. Improved psychosocial outcomes, less postnatal depression, less anxiety in labour, much better satisfaction with care, and therefore this important issue that Jackie pointed out, the better immediate mother-baby reaction. Overall reduction of intervention, that is cost saving. Apart from anything else, it reduces infections, so more spontaneous birth, less augmentation, improved public health, breastfeeding, the first and most important public health initiative, reduced smoking, etc., increased referrals for complications. So we have this data, we have to really use it now as policy with our ministries of health, the 194 flags that are behind me, to make sure everyone understands and sees this. So what we did this year, coming out of the year of the nurse midwife, we are continuing to move forward. I like Neil saying it's mostly about the midwife. There was a lot on midwifery. It was brilliant. People did so well. But we developed the third State of the World's Midwifery Report, which was launched on International Day of the Midwife this year. And this is the Palais des Nations in Geneva, where the 194 member states, which means your Ministry of Health from your country and their entourage, if you like, they bring their ministers, their government chief nurse and midwifery officers, we hope. But usually they're in teams of 10 to 20. So you can imagine how many people are here, plus all the donors, the Gates Foundation and the Global Fund, etc. And we all come together to talk about what are the health priorities for the future. We haven't been able to meet for 2 years. We really hope we'll be able to meet. They've happened online, but it's not the same. Standing and talking to those ministers and people is really eye-opening and world-changing. And they set the global agenda for next year, and midwifery has been very, very high on that agenda. Now, what came out of the State of the World's Midwifery Report was two big things. We've been talking about we don't have enough midwives, we need to train more midwives, train. That was quantity, we don't have enough. But we weren't talking quality. So there's been a real shift towards the quality, which I'm really pleased to see. 4 big headlines. I'm going to take you through them in a little bit more detail, but education and training, leadership in governments, workforce planning, management, regulation, the things that Jackie and Rowan have just talked about, and a really positive environment to work in. And then really, I'm delighted to see this midwife-led improvements. We didn't have to fight hard for that. There's a real welcome for that now in many, many countries. So go into the State of the World's Midwifery Report. So it's a must. You'll see all the evidence, you'll see all the findings, you'll see all the data that was collected. It's really brilliant. It's on the UNFPA and the WHO website. The headline is you cannot meet 90% of the need of women and newborns. Sexual and reproductive health is not just childbirth, if you're less than 10% of the workforce. So this is what the data showed. If you look at the bottom of those graphs, the darkest blue is how many midwives we've got. It's pathetic. I mean, it's just, why is maternal mortality so high? It's just obvious. You just look at this graph. On the left, it's the 6 regions of the WHO: Africa, Americans, the Eastern Mediterranean, Europe, Southeast Asia, and Western Pacific. And you can see far less midwives than anyone else. And then on the right, it's by income. So only 8% of this workforce are midwives. And we really don't know how much time the others, the nurses and the doctors, are spending on midwifery care. So we have a crisis if we want to improve our midwifery care. So I put this slide up because it kind of makes me think, why am I putting this slide up? Why are we even asking this question in 2021? Why do we have to explain why we have to invest in midwives? But we do. And that actually doesn't say something about ministries of health and what's going on in other countries. It says something about us. That at last now we have the evidence, but it took the Lancet series to take us forward, and now we've got much more. But we have got to get much better at advocacy based on evidence and not just on passion, right? There are reasons why we need to do this that are good for ministries of health, good for ministries of finance, good for women, good for newborns, that are good for society. And we need to get much better in our advocacy and how we measure that. So this is a very important paper for all students to know and read. It is the latest and most important paper on midwifery that we developed for the State of the World's Midwifery Report. It's an update to the Lancet series in many ways. It's about the potential impact of midwives. So these are modelled estimates. This is not evidence in preventing and reducing maternal neonatal mortality. And we mustn't forget the stillbirths. They're a very important measure of what is going wrong. Andrea Nove led on this, and these are the authors. And please note, it was UNFPA plus WHO plus the ICM plus Burnett Institute and Novometrics. We're really working together much better and more than we ever have done before. It's a joy now to work with all our partners. So what we did was identified 31 midwife-delivered interventions that directly affected mortality and nutrition based on the global strategy for women, children, adolescent health. That's the WHO strategy, and can be entirely delivered by a midwife according to the ICM standards. We used a tool called the LIST tool, Life Save tool. It's a very technical, numerical tool, so I won't go into detail on that, but we repeated it for modest scale up, substantial scale up, universal coverage, and we had to take into account attrition. This is one of the most important slides of 2021, and it's showing how many deaths can be averted if everything is there in place. We have midwives. On the left, you'll see universal health coverage. And Jackie, it was great to hear talk about we want universal coverage in the UK of all women. We could save 4.3 million lives a year by 2035 if that was in place as it is in the UK. You can look at the details yourself. If ministers only go for a 25% increase, which is challenging in countries, most of which do not have a card of midwives, most countries just don't have the card of midwives that we have in the UK, you could still save 2.2 million lives a year by 2035. And even if you go, I'm just going to go for 10%, we're starting from zero, you could save 1.3 million lives a year of maternal, newborn and stillbirth. So I'm going to leave that for you to look at, but please do look at this paper. It's really important. We found that there are 4 high impact interventions that save most lives. And this is where we really have to focus in policy, education, our faculty, training, changing the system. So contraceptives, if midwives could give out oral contraceptives, injectables, long-lasting family planning, we could avert half of all deaths. I came from Somalia before I was in WHO, and access to family planning was less than 1%. Is it surprising that so many women and newborns are dying in labour? It is crazy that that's what we have. Hypertensive disorder management to prevent stillbirths, antenatal corticosteroids, etc., to reduce newborn deaths. And very good to see the new newborn examination. And hypertension screening management, parenteral uterotronics. Most midwives, nurses in most countries are not able to give intramuscular injections. How on earth can they prevent postpartum hemorrhage? They can't even give oxytocin. And that's to help reduce maternal death. So we have a lot to do to make sure those high impact interventions are part of the scope of practice. Training is there and they're regulated. It adds confidence, this paper, to the Lancet series. Many people questioned it. Oh, that was a one-off. That's just midwives. No, it wasn't. That was seriously good research. And now we have even more confidence, more detail, and more context. So that all went into the State of the World's Midwifery Report. I'm going to take you through now the 4 challenges, if you like. And I really want you to have your thinking hats on. You're the students, you're the future. I'm looking to you to see how we take this forward. We've got to invest, they're all invest in health workforce planning. There's a huge amount on this. I just want to highlight this slide. Not one out of the 194 countries submitted all of the data. We are so short of data on midwifery and what's going on. The countries that did submit much of the data didn't know the difference, and they couldn't distinguish in their data systems between a professional midwife, an associate, a nurse, a midwife, or a nurse midwife. We don't have those systems, and we don't know who's doing clinical practice, who's in research, and who's in education. And there's no data on how much time nurses and others, doctors, provide to this area. So we need to get much better at that. This is a huge issue. I don't know how to answer this. It's in your hands as the future. But we know most midwives, 93% of women, most nurses are women, and half of doctors who work in this area are women. We need leadership opportunities. We need decent work, free from discrimination and harassment, and the gender pay gap has got to come to an end. And so we're talking about gender transformative policies and measures. Now that is huge. It's just such a big topic, but we have to start thinking and raise our voices to what we want. What does that mean for us? It's not what a gender transformative policy means to some guy sitting in some UN agency somewhere. Us as midwives, what do we want to change in terms of gender transformative policies where we work? This is the effective regulation slide. I call it ineffective. If you look at the regulation again that Jackie was talking about, only 1 in 3 countries globally require relicensing. So you could have trained 30-something years ago and never had to relicense. So you are out of date, out of control, and out of knowledge depth. And so we've got to do something to make sure we have continuing professional development and systems to enable continuing professional development. I'll let you look at these graphs more. So number 2, education and training, absolutely critical. And as students, this is so important for you. If you just look at this, 49%, half of all countries have educators who are midwives, which means half of all countries don't have any midwives who are educating midwives. So who's educating them if they're not midwives? And what are they educating them in? 6% of countries have no educators at all that are midwives. So they've been educated by other health professionals. So, we have a huge challenge here to really get back to good quality education and to help midwives. So many times it's like, they don't know how to do this. They are not able to do this. Doctors say, we can't let midwives do that. Guess what? They were never educated to do that, or they couldn't have access to clinical sites, or they get to clinical sites and there's no preceptorship, etc., etc. So what did we do? This all fed into the SOMI report. In 2019, led by member states, this was Sweden with Malawi, India, UK, just trying to think of the other countries. We had a whole event apparently, according to the cleaners, the best event that we ever had at the World Health Assembly on launching this framework for action for strengthening quality midwifery education. And I'm really pleased again to say we, WHO led on this, but we did it with UNFPA, with UNICEF, and with the International Confederation of Midwives. This is a jointly owned document, and we are jointly implementing it globally. Very briefly, as you meet today, 810 women are dying in childbirth. Most of them will be at home and without any pain relief whatsoever. 2.4 million newborns die every year, and every 16 seconds there has been a stillbirth globally. These are estimates. And this is something that just makes me angry, actually. But 1 in 5 women in 2021 are giving birth without any help whatsoever. What does that say about the state of our planet and how much we care for the environment in which women are providing the next generations for our future? And as I mentioned, educators just don't have those competencies. They don't have materials. And half of all education institutes have no water and no toilets. How could you go to work there? And half of all facilities don't either. So we're looking at really tough, challenging scenarios. However, when I look at this photograph, which is Bangladesh, my heart feels great. I was there in the mid-80s and then again in the early 90s. It was awful. You look here, here's a midwife who knows what she's doing. She's got a companion at birth. The woman is being well cared for. She's allowed to walk. It's clean. Huge progress is being made in countries like Bangladesh. So, huge appreciation to all the midwives who are breaking these boundaries and changing things. Never forget, because we tend to in countries where we're quite okay, that 60% of maternal deaths are taking place in fragile and conflict-affected settings. You think of Syria, Yemen, all the countries that are in conflicts at the moment, it is desperate, and 5% of newborn mortality. And this is a photograph from Somalia. And, even there, they have raised midwifery. It's become a great profession. They're doing a master's online course. So even in the most difficult circumstances, we can do something. And midwives are always there. The doctors cannot always be there. So Somalia, amazing. So we decided to stop just talking about this. And again, to stop just saying we need a better curriculum. Let's train more midwives. Let's have more curriculum. And we developed a 7-step action plan. We put women and newborns in the center. We didn't put the midwife or the system or the government. Women and newborns, and all of our partners, we said, we've got to have leadership. Before we move to the curricula, let's have senior midwifery leadership and let's have policies that support education. Let's get the data and evidence, not just on maternal deaths and stillbirths, etc. But we don't really know what's going on about midwifery. Let's build public engagement and advocacy. Let's get doctors on our side. They really are, but they don't know how to do that. Let's get parliamentarians. Let's get women in their communities with us, as they have done in New Zealand, for example. And then let's prepare our educational settings. Let's make sure they have water, sanitation, that the practice settings are good, that they have clinical mentors. Let's make sure our faculty, who haven't had any updates for 30 years, know what they're doing. And then let's look at the standards in countries. And I'm sharing those UK NMC standards with everybody. Let's use standards like that to lift our targets. And then let's develop curricula. In Malawi, they need stuff on PMTCT for malaria, TB. Those are the big issues there. More die from malaria, TB, and HIV than anything else. So we have to adapt our curricula, to what we need. Then let's educate. And most importantly, sorry, I'm going the wrong way. We have never monitored, evaluated, or reviewed our midwifery programs. We cannot budget. We have just said we need more, but we haven't said, well, how much would that cost? What would the economic gain be? How long will it take? What will our objectives be? So we have to do all of this together, act, monitor, and review. And that cycle, I'm not going to go through this in detail. You will see this. It's to be published. This is the first ever global, with UNFPA, UNICEF, ICM, results framework for strengthening midwifery education. You'll see the 7 steps down the left. You'll see activities, output, short-term outcomes, long-term outcomes. If you just look at the top right, if we can strengthen leadership and policy, we're looking to increased investment in strengthening international standard midwifery education globally. So at last now, we can start to say, we don't have that, where are we? Let's measure it, let's improve it. And we have programmatic measures. So I'll leave you to look in detail at those. When it's published, I'll let you know. COVID is still a problem, and I take my hat off to every single one of you who have worked so hard through this and gone way over your ordinary length of day to help women and babies. But we have now started to move into 5 countries to implement the 7 steps. the countries. It seems a bit of an odd group, but they were chosen by the regional offices, and the criteria that the ministry are interested, we have the capacity to move, and that UNICEF, UNFPA, and ICM are able to support us here. So we're just starting with leadership policy, getting that data and evidence, and on the monitoring, because those are huge issues, and we've got a lot of discussions going on. I just want to share with you some of the really exciting things that have happened just in the last few months. I haven't been able to travel yet. I'm hoping next year I'll actually be able to go and support them and work with them. But Pakistan has completely blown me away. No midwives for decades, 80% obstetrician, the 20 other percent don't get anything. So you have a traditional birth attendant or nobody at home, or you have to have money and find an obstetrician. You can imagine what that's like in the rural parts of Pakistan. So within weeks of us starting, the Ministry of Health, supported by WHO, held a multi-stakeholder meeting and said, right, we're going to have a national strategy for midwifery for Pakistan. It's like, what? This is amazing. We're now going to have a cadre of midwives in Pakistan, led by ministry. Private sectors, for the first time, are really coming aboard, recognizing how important it is. It's about 50-50 public-private, but we're looking for resources from private. They're so interested. I'm really pleased to say, instead of an expensive consultancy company, it's the Midwifery Association of Pakistan that are doing this work for WHO. We're funding them. And some of you will know Dr. Rafat Jan from Pakistan, extraordinary professor at Aga Khan and a hugely influential ministry. She's going to be working with us on that. And they have work plans and incredible work in such a short time by such a few people. Sierra Leone, the other country, they're moving to develop a leadership assessment tool, because guess what? We don't know how to assess midwifery leadership. We've been talking about it. So we're getting a group of experts together. We're thinking about what this would look like. We're co-designing this tool across the 5 countries, and it will be shared globally and used, we hope, UNFPA, ICM, and our other partners. Also, the Chief Nursing Midwifery Officer of Sierra Leone said, I don't want another situational analysis on midwifery. I want an online tool that I can update every year on what is going on in midwifery. So lots of exciting things happening in Sierra Leone. India, many of you will have heard quite a lot of what's happening there. They introduced the midwifery cadre 3 years ago, a huge launch by the Prime Minister at the partnership, big global thing. But the challenges in India are huge also. We've had the COVID, as you can imagine, you knew what happened in India. Everything came to a stop. They had to focus on that. But India has about 25 states. It's huge. Each state is about the population of the UK. So there's a focus on 6 states, very strong Ministry of Health leadership, but a lot going on. So there have been delays. It's really picking up again now after COVID, although that's still an issue, of course. Of course, India has been led by obstetrician for decades, and women expect it and obstetricians expect it. To change this to a midwifery-led model, it's tough, but it's happening, and we're building the confidence of obstetricians in these states, so good stuff. Again, in a country like India or Nigeria, the government can put out a strategy, states don't have to follow it. So we're having to really look again. The Indian Nursing Council have accepted the new scope of work just for midwives, which is huge progress, but we don't know that all the states we're working in with. So lots of issues going, and it's, as you can see, a lot of public-private sector in India as well. So now just on to the third one, and I'm going to keep charging through all of this. How do we look at midwife-led? I loved hearing Jackie and Verena talking about midwife, continuity of care, continuity of carer. I hope all of you have seen this Cochrane database systematic review from Jane Sandel, led by midwife as well as Horace Sultani. And this has been absolutely groundbreaking and is changing huge amount of thinking, certainly in WHO, but amongst many partners. And as you saw, it was one of the 4 recommendations. And this is the evidence that showed it. If you look at the evidence at the bottom, this arrow that goes to 24% less likely to experience a preterm birth. Now, the challenge for me is if we could have a vaccine that would prevent 24% of preterm birth. The Global Alliance for Vaccines Initiative, the Bill and Melinda Gates Fund, this, hopefully the UK government would throw money at that vaccine to save 1 in 4 babies from stillbirth. But what we have is midwifery, much more complex, relational, based in the system. So we're working on how do we now move this forward? This came from high income countries. You can see much greater satisfaction from women. So the first thing we did is we got this recommendation into WHO guidelines. I hope you know how to find these and where to find them, but please do look at them. They've become much more user-friendly and women-friendly. So we have recommendations on antenatal care for positive pregnancy experience, intrapartum care for positive childbirth experience, I'm really pleased to say that a new postnatal guideline will come out next year for positive postnatal experience for mother and baby. And we had Sue Down led a huge piece of work with WHO to make sure we had this recommendation on midwife-led care within those guidelines. So it is there. This is the recommendation in which a known midwife or small group of known midwives supports a woman throughout childbirth, postnatal. But see in red, it's in settings with well-functioning midwifery programs. Now, we haven't defined that. And the big challenge for us in WHO now is to move forward on this. We want our DG to stand up in a couple of years at the World Health Assembly and say, ministers, without a doubt, this is where we need to be going. But we don't have the evidence from low and middle income countries where they don't have what we would call in the UK a well-functioning program, for example. Not just low and middle income countries, large parts of the US and the Americas and wealthy states in the Middle Eastern region don't have this. So it is a context-specific recommendation. We have developed a theory of change as to what are the mechanisms behind these fantastic results. We don't really understand why or how it works. We're going out to consultation on that over the next couple of months, and then we will be publishing a theory of change of all the assumptions. You have to have the politics right, society right, the education right, the whole thing has to be there. And so a lot of work on that, and we're doing a review of who's doing what. There's some very interesting work in other countries now outside of the Cochrane review coming up, and we hope to have another Cochrane review on the evidence, but also on implementation. So watch that space. That's going to be huge over the next while. I'm just getting to the last one now on leadership. Oh, sorry. Okay, I'm going way over time. I'm going to go through this so fast. Please look at the midwives' voices, midwives' reality. This was 2,500 midwives responded. We had to stop the survey, but really it's about gender inequality. I won't go through this slide, but you can see the sociocultural, economic and professional barriers for midwives, the gender penalty. 37% midwives feel unsafe. This is a really great paper about the tip of the iceberg. What's going on. There's so much violence against female health workers. We have to look underneath. It is about power. You as students now talk about power, gender hierarchies of power. Don't be shy. We've got to move this forward. It's out in the open, no more hiding it. When we look at midwives and leadership, everything we see online is about birth, not about research, education, and management. We have a whole document on government chief nursing midwifery officers. We're finding they are isolated, unable to do what they're meant to do. Fantastic. Jackie's going to speak to you later. She's an absolute star and they all look up to her. And this is Georgia Carter's in Bolivia as well. But you can see half of them are invisible, don't have a laptop, aren't there at meetings, not seen as part of government. So these are the recommendations. And one I want you to look at is that it's an essential element of your education and training. We weren't trained in my generation in leadership. You're all leaders as students and your voice must be heard. So really pleased to see that that's part of the new NMC standards as well. Absolutely fantastic. This is a new WHO community of practice. We are connecting people, leaders from Sierra Leone to Malawi to India, to let them talk to each other and say, how do I do this PowerPoint? I don't know how to do a budget. Do you know the latest evidence? What can I say to my minister? Support each other. It's the only way forward. We've got the new global strategic directions, again, education, leadership, service delivery, and jobs coming up. I'm very close to the end. I'm really pleased to say in WHO that the contribution of midwives to global commitments is increasingly recognised, and universal health coverage is the big hot topic now. We've got to reach the most vulnerable and the ones who've been left behind. And midwives are there all the way through in primary health care. And this year is actually the year of the health and care worker. So again, more focus. I won't go through this slide in detail, but something that's been missing, again, I was so pleased to hear Jackie and Verena talk about it, is human rights. There are 4 human rights treaties in existence for sexual, reproductive, maternal, newborn and child health. The Convention of the Rights of the Child, Convention on Eliminations of All Forms of Discrimination, the International Covenants on Civil and Political Rights, and Economic, Social and Cultural Rights. All midwives and all women need to know their rights to prevent the mistreatment of women in so many places. So I won't go through them. It means that education needs to include this, but we are developing an essential respectful care module, and we talk through all of these rights in the form of women. What does it feel like for them? What was their experience? What would you do about it? How can you uphold your rights and their rights? So that's coming soon, so watch that space. Can't finish without mentioning COVID and just always huge respect for everything midwives have done this year. But the SOMI said the COVID-19 crisis has exacerbated the global shortage of 900,000 midwives, with the health needs of women and newborns being overshadowed, midwifery services being disrupted, and midwives being deployed to other services. That has to stop. We started a piece of work which has to be published soon on how we can support education during COVID. We took the 7 steps. Mary Renfrew led on this with me, and it's me, I'm guilty of not getting this published yet. But if you look at the bottom, it's about collaboration leadership. It's about equity, making sure all midwives have access to education during COVID. It's about their safety and the safety of women and newborns. And most of all, it's about a focus on students and students' voices in their education during the COVID. So we've been listening to you, and you'll see a lot of that incorporated. My last slide here is please get this app. WHO updates this about 2 to 3 times a week. It's completely free, and everything you need to know about COVID and maternal newborn health, sexual reproductive health is on that app. And I'm going to stop there and thank you for listening to this roller coaster of information. I hope you've got loads of challenges in your head, and that you can think about your education as you go forward and really taking on these challenges to help us overcome this injustice and make sure that women aren't being left the way they are without care and being mistreated, and that there's so much positive about midwifery that we have to get out there. So thanks to all of you and good luck. I'll be thinking of you.
Thank you very much, Fran. Well, if you can stay with us for a few minutes, sure. That was fantastic. I warned everybody that it would be a roller coaster. So can we just open the next poll question, which is, how likely are you to work abroad at some time in your career? Probably Fran has slightly biased the outcome of that, since if you weren't thinking about the challenges in the world before, you will be thinking about them now. An absolutely tremendous presentation. 50% of deaths in acute settings. It's a very sharp reminder for people that 4.3 million could be saved if we had midwives for everyone. Very interesting point about data and about trying to recognize who are midwives. And I always find people shocked when they realize that lots of you, when you qualify, you won't be able to practice in many of the states in the United States where they don't recognize midwifery. They have nurse midwives and obstetrician-led structures. But 24% potential reduction in preterm births. These are the kind of world-changing statistics that Fran and she mentioned Mary Renfrew and others have been working so hard to build up and win the arguments. So I'm now joined by an illustrious panel from both the education side and the student side. So I'm joined by Jane Marshall, who's a Professor of Midwifery and Lead Education from the University of Leicester, and a visiting professor at a variety of other places, and Nikki Clark from the University of Hull, along with Prableen Mann and Wendy Almeida Valera, who are 2 students who are going to join us and ask some of the questions. So welcome to you all. Can I ask you, first of all, Jane, can you just give us a 1-minute reflection on what you've just heard from both Jackie Williams and from Fran?
Yes, thank you, and good morning, everybody. I think my reflection is how similar what we're seeing in midwifery education in the UK is transformed globally as well, and some of the issues that we have are obviously more stark in contrast globally. And personally, I do feel that we should be collaborating more and sharing, because we all have standards to address, so that women and their families and babies can get the optimum care, and obviously reduce all those stark statistics that Fran's just showed to us all. And we have to actually look forward to reading, from an education perspective, Strengthening Midwifery Education when that's published, because I'm sure we can all learn from the reports that is published.
And Prableen, what's your reflection on what you've heard? How does that change your plans in life or shock you?
So global health is actually something I've always been interested in. So I think Fran's presentation today was just amazing. And I've actually worked with the Bangladesh Twinning Project as part of the RCM, and I'm currently still a volunteer with them. So for me, it's made me more interested into the topic, and actually watching that WaterAid video, obviously it's really heartbreaking, and it's not something that you see every single day when you're studying at university, and it's not something that's always been brought up. So I think it's quite good that it has been shared today amongst student midwives, just so we can see the reality, outside of the UK, and hopefully make a difference in the future.
And Nikki Clark, what's your thoughts? And then I've got a question for you. So your thoughts first.
Okay, thank you. Well, my thoughts are, obviously, what fantastic presentations from everybody. Being involved with the development of the new standards, it's just knowing the hard work that took to actually get them to the point that they are now, and to actually roll them out across the country, 4 countries UK wide, and the impact that this will have on the midwifery profession going forward. Obviously, we've been anticipating these standards and working very hard to upskill our students on the 2009 standards to ensure that they are not disadvantaged going forward, and incorporating many of the aspects that we knowing from what was happening worldwide, and obviously in UK, that these were included. And I'm thinking of leadership, I'm thinking of examination newborn, I'm thinking of continuity of care, I'm thinking of medicines management, being mindful of that. We know it's a challenge to get all the proficiencies in the programme, but we are obviously set for it, and we will push forward, and we feel that the partnership with Practice has been one of the biggest, I think, spin-offs from, unfortunately, the COVID crisis, but working with the standards to get these implemented with Practice completely on board.
And a quick question for you as somebody working in sort of education management. In the university work that we do, universities are predicting that the second highest earning segment after business schools and MBAs in future is likely to be health and social care. So lots of universities are opening up new medical schools. They're investing in postgraduate management courses and various other expansions. But do you think midwifery is up there competing for those resources and for those time and for those courses, especially given what we can now do online and in distance learning? And what's your impression? And this is really something that the educators can pick up later. How's the leadership and the fight for resources going on in universities for midwifery?
In midwifery, we have to fight very hard to hear our voice heard, because to be honest, previously I have been in education some time, and we have been sometimes subsumed with the larger programs, and I'm thinking of nursing, and obviously if you are twinned with a medical school as well, then often resources are directed to those areas. So you have to be very, very strong in your conviction, you have to be robust in your rationale, and you have to ensure that that what you are proposing will have impact. And I think that is the one thing where we are showing, if you like, our value, because we are evidencing impact. And there is impact to be had. We have a long way to go, but we're working there. But we do have challenges. And Jane will endorse this, I believe.
Yes, I mean, certainly the programme at Leicester, where the 2 students are actually representing, we were actually asked to set up a programme with leadership at the 4. So this actually came from the workforce, from the local NHS trust, so already embedding the standards. So again, we do have sessions with our business school, but still we have to compete with resources within the university. But it was actually something that the local workforce came to the university to actually help them prepare for the next generation of midwives and nurses, because there is a sister programme, Nursing with Leadership, at Leicester.
So Wendy, what jumped out at you from the presentations you've heard this morning?
For me personally, it's really encouraging to see the focus and the efforts made to innovate midwifery, and especially knowing, as Jane mentioned, leadership is at the heart of our curriculum here in Leicester, and I feel really supported that we have all the tools and more that we need to like achieve these goals and uphold these proficiencies and these standards. I feel really encouraged that as a student and me and my peers, we can like influence the future of midwifery. So yeah, that was really inspiring for me.
Okay. All right, let's go to some of the questions. And I have to say that quite a few of them are pointed straight back at Jackie and Verena for the NMC. So we've got, and I may paraphrase some of the questions a bit, but we've got particularly some questions about people worried about their placements and the quality of them and what can they do about them. Also, one question asking, worried about adding learning about more skills to what is a very packed curriculum already. So Jackie, you must be hearing quite a lot of this on the grapevine. How are you advising students and lecturers and the service to try and make sure they get the balance right?
Yeah, I mean, our standards are absolutely committed to working in partnership between the placements and the who obviously are providing practice as well as the AEI. So they need to work together throughout, not just in the development of the curriculum, but also in the delivery of it. I think students need to ensure that they keep that dialogue going, that if they have those concerns, they must raise them. There's lots of mechanisms to do that. Interestingly, I was talking at a conference on Saturday and people were mentioning the National Student Survey, but in a way that's a bit too late, although that's a very important survey, it's a bit too late for somebody on programmes. So they need to raise this with their academics, they need to complete their evaluation. We've got, particularly for England at the moment, we've got a net survey that students are being invited to do it. So it's a bit about not really accepting that if it's a case of what they are concerned, it's talking to others who will be able to see what is actually happening and to see whether there needs to be any adjustment or something needs to be done. So I suppose the message from that point of view is don't keep quiet, because it is your programme. You need to meet these proficiencies. I want to reassure you, you will meet these proficiencies. This is part of the AEIs as they've developed their programmes. We're actually committed to doing evaluation of that going forward, because there was a lot of discussion at the time about the length of programme. But I think for the individual student, it's making sure they have those dialogues with all of the people who are responsible for their education.
And Verena, you might be able to answer this question, but to sort of signal that midwifery is quite a caring profession. Quite a lot of the students have been asking questions, worried about their lecturers and their supervisors and how they're coping with the stress of trying to deliver in an environment that's been so impacted by COVID. What kind of things or what kind of advice and policy have you been putting out, or cases have you been dealing with to support the educators and supervisors and the pressure that they are coming under trying to deliver standards in disrupted environments?
Well, I think it's a very good question, and as you say, illustrates the kindness of students, really. What we've been doing is we were involved with some recovery standards to try and be flexible as COVID was sort of hitting. And going back to the original point about the standards, I did say that we intended them to be flexible and future proofed to an extent. And I suppose that's been illustrated by the ability of AEIs and students and practice educators to keep going through the pressures and challenges of COVID and how it's affected everybody. And it's an absolute credit to everybody that we're still at the point of, by 2022, all of the AEIs in the UK will be using these new standards as the basis of their curriculums going forward. But it's absolutely understood that it's been extremely difficult and really, really challenging. Everybody suddenly had to start doing stuff online. And for some universities, that was easy peasy. Wee buns, they'd been doing it for ages. But for others, it certainly wasn't. And it was a real change of delivery of the programme. And I think there's been adjustments, and there's had to be understanding and respect along the way of the people are doing their best, and their intentions are to support the students going forward. And again, from the NMC point of view, we link in. Jackie works with Nikki and the lead midwives for education across the 4 countries of the UK, with pulling together their concerns, what we can do to help, thinking about working things through. And throughout this, the 4 boards at country level who have been charged with embracing the standards and getting it out there and getting it implemented and working with practice and so on, have been absolutely, fantastic. And they've done a huge amount of work throughout this. So not perfect, but it's the relationships and working together and pushing on have been key.
Okay, now a question for Fran, really. This is from Shoshana. Is there work being done? Well, there is obviously work being done to lobby wealthy governments about inequalities in maternity care, both in the UK and overseas. Now, Fran, you've been at the centre of pulling together a lot of the data. And although, you did highlight some remarkable progress in Pakistan and other places, but there are also hidden inequalities in wealthy countries in the way that people are treated. So just for our students, and also really for the academics and others, if they were thinking about campaigning, what are the buttons that you want them to press? Over to you.
What a fantastic and complicated question. Because I think there are inequalities in wealthy societies, as you said, Neil. So, it doesn't matter whether we're in India or in the UK, you have fabulously wealthy people and extremely poor people. It is much harder for poorer women to access quality services, particularly because so many of them are in the rural areas, but don't forget so many also live in the urban areas. And then you get wealthy women who, due to society or culture, for example, find it almost impossible to access a medical abortion. So, we are all equal in childbirth. And so it is about recognizing that, it's not just about wealthy countries having greater access. Within that, there are many, many different levels. However, we know that most of the deaths are taking place in the lowest income countries. So I have to say that the donors are hugely supportive and very proactive. The UK, through DFID, were fantastic and have been giving lots of support. What happens in WHO is all member states give some money, some give additional money. So the UK had been really good, the Swedish, the Canadians, we have endless conversations with the bilaterals, with the Germans and the Japanese, but the private sector are really coming on board now. And so people like the Gates Foundation, Merck for Mothers Foundation, many others are also saying this has got to change. If we want to reach our SDG targets and improve this, we need to do that. I think to the question of campaigning, my real ask to you as students is to use the evidence. We've had a lot of waving flags and midwives matter, and that has really raised the visibility, but we have to show the evidence, and we have to do what was just being discussed. We have to document the change that's taking place, and the economics of it are also really important. One thing that I didn't have time to mention on leadership is what we found is that the midwives who have either done something before they come into midwifery or qualify as midwives practice and then go and do something very different. It might be a degree in economics or something, travel or work in a different, they come back into midwifery and they look at it differently and they understand how other people need them to communicate with. So, it is an issue for you as you go forward in your careers to think, are you going to be allowed a bit of space to go and do something different that might be helpful when you come in? So I hope, Neil, that started to answer that.
All right, we're running out of time. I'm going to give the last 2 words to Wendy and Prableen. So, Wendy, what's your promise to yourself for the future? Go on. Unmute.
My promise on myself for the future is to continue being strong, to uphold all the proficiencies. Personally, I like to highlight the proficiency on cultural competence and helping my peers and I to reflect on our unconscious bias, to help against discrimination in the NHS, not only towards patients and their families, but also towards workers within the NHS themselves.
Great.
So to continue fighting against discrimination.
Okay, go on. Last word to you, Prableen. We'll have you back later today, but go on.
So yeah, I think the promise to myself is, I think like Fran was saying, to almost evolve yourself as you go through. So not looking at midwifery as this tunnel vision, trying to explore and actually branch out as well. So global health, looking, obviously part of our course is core and leadership. So actually venturing out and looking into that a bit more and seeing how we can actually help everyone globally and within the UK as well. So I think hopefully that is something that I would love to do.
Okay. So thank all our speakers very much. Can I ask Catherine to close poll number 9 and to open poll number 7, which is the one about your online experience, and that'll be open over the break. When you go into the break, there's a NMC Meet the Expert talk, and I think Jackie and others will be available to take any specifics that you've got. You then go off into your separate areas. There are 2 parallel streams. One is the student midwifery experience, which will be back at 11:45. And similarly, for those educating midwives who are going to delve into how on earth you pick up all the wonderful things that Fran has laid out and make sure that you're doing them. But, and if you can keep on checking the chat and things for information and sending us your pictures, that would be really great. But on behalf of everybody, I'd really like to thank our speakers, Jackie and Verena, and particularly to Fran McConville for making the time from Geneva for an absolutely fantastic. Do you do signed photographs, Fran? I can never remember. I'll have to build my fan club up. Okay, that's us finished for this session. See you back here at 11:45 or in your other sessions, and go and watch the Meet the Expert for the NMC. Thanks very much.
Midwife working in 2030 is going to have to be adaptable, flexible, knowledgeable.
A lot more skills around kind of negotiating and advocacy for women.
It's multidisciplinary, it's working with students, doctors, partners.
In 2030, I hope very much that women, when they come into maternity services, receive a named midwife who is present for as much of that full journey as possible.
think it really demonstrated to me how important education but regulation went hand in hand. And of course, we're so fortunate in this country to have strong regulation for midwives, and we've had for over 100 years, and we have our own part of the register. Should we say something a little bit about that? Because that could be sort of helpful for people to get the two things in context.
I think it was fascinating because I think regulation is one of these things that maybe people don't think about all that often, but that was a really startling point that Fran made, that it's possible in large sort of parts, in large chunks of the world, to get on the register, and then that's it. You never have to revalidate. You never have to show any evidence that you've learned anything, or that you've read anything, or that you've moved on in your practice. And I mean, the one clear thing that we were, absolutely knitting through the standards was, and that came out in Fran's talk as well, was the need to use evidence.
Yeah, yeah.
That's been a very strong feature of sort of maternity services and the development of the research base, and obviously midwifery research and so on and so forth. But it's extraordinary that you could still have places where basically you get on and that's it. You never, because you wouldn't dream of doing that with any other sort of walk. You're always learning, and that's part of what's coming across in the standards, of course, which is it's lifelong learning, it's ongoing, it's about being up to date with current practice, because we all know it changes. All somebody has to do is have maternity leave come back, and something will have changed. There's something new that's come up.
But I think as well, it's important to say for people who are perhaps not so familiar with this, because obviously we have revalidation and students will learn about that, the importance that every 3 years you have to demonstrate that. But I think as well, it's about how our standards, if you like, benchmark the expected practice to join the register, and indeed going forward will also could be reviewed, particularly if somebody was referred to us in terms of a concern. And what we want to do is also to get midwives to use the standards in that revalidation appraisal process to identify where they need even particular professional development, which may need to be supported by their line manager or the maternity service itself.
Yes, so, I think it's a point very well made about linking it into appraisals and supervision, whatever the system is in the particular country or area that you're working in. But it's about pinning your updates and your appraisals, your revalidation, whatever the system is, to your standards, and in our standards of proficiency for midwives. And I think that's going to be really emphasised going forward, is about the need to not just think about, in our context, the code, but also to think about the standards of proficiency. And it links back to what you were saying about gap analysis, because about maybe, if you're head of midwifery, director of midwifery, looking at your workforce and thinking, right, these are the new standards. The students are going to be coming out and they're expecting to be learning at this sort of level. Are we sure that we're sort of in the position to be able to work with them in practice at this sort of level? And
so, Bruno, I'll just say we haven't had any questions yet, so please do send your question through on WhatsApp. We'd love to hear your views about what we're saying. Otherwise, we'll keep talking. as we can.
An Irish girl streak that can keep me
and
going.
I think also we must remind people about, we've got the code, which of course we will be looking at, and we will be working with lots of external people around that as we need to update that over the coming years. But I think we've also got another guidance document, haven't we, that people mustn't forget, which is practicing as a midwife in the UK. And that's a really, really helpful document if you're not familiar with it, because it sort of shows the legislation and also shows there is some also useful things around medicines. So in a way, we've got 3 documents, but the practicing as midwife is more of a guidance. It's not a standard. The standards are things we absolutely expect midwives on our register to practice against, and obviously this is the benchmark for our education institutions.
Yes, in a way, practicing as a midwife in the UK, for those who are familiar with the old midwives rules and standards, that document, Practicing as a Midwife in the UK, sort of pulls together, you know, the NMC's work and where we sit with midwives and regulation in the UK. So it's very useful as a sort of overview. And it does, while we would always say go back to the original legislation, it does contain, you know, the information around midwives' exemptions. And again, that's one of those things that does change and does get updated. And we're currently working with NHSEI and the other 3 countries of the UK to look at the midwives' exemptions, because practice moves on and there's some medicines in there that are no longer used in practice, other medicines are. So it's about refreshing those, and whenever that happens, which isn't a short process, the Practicing as a Midwife in the UK will be sort of appropriately updated, but it does go back to always look at the original.
So Verena, we've got lots of questions coming in, so we're going to have to get to our questions, with our answers quite short. So 2 are around education, which I can refer to and bring Verena in. But we'll just take the first one from Jess, because I think this really fits really well with our conversation about standards and code. And what Jess has asked is, have the NMC taken a stance on the March for Midwives? And Jess, I have to say that we are very, very aware of this, and our comms are really working hard, and there will be some statements put out, and Verena and I are actually inputting to that. But a lot of it, Verena, isn't it, if you wanted to make a comment, is around the code, isn't it? And what being involved in something like that could mean. So not to preempt our statement, but did you want to just sort of just say a few things about that in terms of standards?
Yes, well, it's about thinking about what you're doing in your spare time, because the assumption is that this is not something that you'll be doing if you're supposed to be at work. But the view would always be that you do maintain your adherence to the code, whatever you're doing. And I would refer you back to, you know, the 4 pillars in the code, which you know, are around prioritising people, practicing effectively, preserving safety and promoting professionalism and trust. So wherever you're thinking of in the context of vigils and so on, it's about remembering to have a wee look at your code and think about the promoting professionalism and trust, and thinking about that particular space and event. Because we often, we've put out press statements in the past about industrial action and so on, but this is slightly different. So it's about thinking about how you are representing yourself as a midwife, and thinking about the code and thinking about it in your spare time.
Yeah. So I think we will be putting that statement out very, very very soon, don't you think? So I think do make sure you have a look at that so you can make a decision about whether that's the right thing to be involved in.
Yeah, we would be out on social media, so be coming out on Twitter and things, which is where we usually launch sort of press statements and so on, as well as on our website.
But thanks, Jess, for the question, because I think it does worry a lot of midwives. We're getting a lot of queries. We are responding to them. So this is why we do need to put something out to help midwives and students, you know, to make their decision about that. A couple of things which are more specifically around education. And I don't know who's actually asked this question, but it's around about the concerns about that when you're in practice, you're not supernumerary. And you're being used perhaps to do tasks, I'm reading into this now, that potentially would not be meeting your proficiencies. Now, of course, you can't be supernumerary to a midwife, but I'm sort of guessing from the question that possibly you're doing other sort of roles. And I think if you have got concerns about this, and I think importantly that you are, because of having to do certain activities that is affecting your experience and your ability to get your proficiencies, absolutely talk to your supervisors and importantly talk to your tutors within your university. Don't let it go on. I mean, everybody needs to sometimes help others and make beds and clean rooms and all the rest of it, but that obviously is a very different thing to do that to support the work of the team, as opposed to something where you should be gaining experience. So I think have a conversation and just see whether this is something that needs to be perhaps taken up in your particular placement area. But thank you for the question, because really, really important that you know that that is not what we'd be expecting you to do. So Verena, we've had a question about practice supervisors and practice assessors. Perhaps the system's not very popular. So if I start and I'll bring you in, and interestingly, just so you know, we are having some webinars about this whole topic. So do sign up for the webinars, or if you're not able to, do listen to them after the event, because they will be recorded. But I think we were very clear about the reason for identifying two distinct roles, because of the need for that when you are supporting a student and importantly assessing them, that that midwife is being able to be objective in that space, and where that person took those roles as a complete package, if you like, in the previous system, that was not always helpful. So in the worst case scenario, there was concerns where perhaps you didn't maybe get on with that individual, and whether that would have affected their approach, or maybe that the relationship was a little bit too close. So I think we're very clear about the importance of having those roles as separate. We've tried to be helpful when it was absolutely necessary during the pandemic, but obviously those things are now being withdrawn, and we continue to work with midwifery to ensure they understand. I don't know if you wanted to make any further comment, Verena, on that. Right, 2 minutes. Yeah.
Just very briefly, I think the other key thing that maybe hasn't been possibly as up there as it might be is the fact that the supervisors can be from other professionals that are on the register. So it's about learning from others that you're working with in the sort of maternity space, as it were. And I think that's really, really important, because you know, all of us learn from other professionals that we work with, and this is one way for the students to actually benefit from that as well. And certainly, you know, thinking back to being in clinical practice, you're learning from the physios, you're learning from the anaesthetists, you're learning from the obstetricians, and this is a sort of studentifying of that experience, and that benefiting from others' knowledge within the maternity space.
I'm really conscious we're running out of time, Verena, so there was just a couple of questions that I just really wanted to address. I mean, I think there's been one around people maybe not wanting to work full time when we qualify, and how that would be for, you know, the state of things, and also one around preceptorship. So if I just comment on both, and then maybe Verena could just do some final points. I think it's absolutely important that people actually are supported to work in the way they want to do. And we recognise absolutely that not everybody can work full time. And I think working continuity of care teams where you have buddies can be really, really helpful. But I think it's about the system able to support people to work in the ways that they will. But obviously you still need to meet our revalidation requirements in terms of the numbers. In terms of adaptation of preceptorship, we put through some guidelines last year about preceptorship programs, very much on a model more about working with individuals. And I think what's important, and this is a really key point that this individual has said, is about the deficits in pandemic supervision. I think what's really important to remember that you will not join our register unless you absolutely have met our proficiencies, so that the supervision might have been different, and needed to be adapted, but you still must meet those proficiencies to join the register. I don't know if you wanted to make some questions. We've got lots more questions, but I'm thinking because we're running out of time, we will respond, Catherine, and try to get back to those individuals. If that's, I'll find out how to do that. Any comments about, any comments about what I've said about working and preceptorship?
I think it's absolutely it's maybe that there's a case of a little bit of a time lag between sort of management and service and people's wishes, because it's absolutely not set in concrete that you have to work full time after you've got onto the register, and we've got to be realistic about people's working patterns and their lives, and the demographics for midwives are slightly different to nurses. So there's sometimes people are coming in and it's not their first career, it's maybe a second, they have family commitments and responsibilities and so on. And we've got to be realistic and work around that and think about it flexibly, because we're still getting the benefit of their knowledge and their experience and their wish to be a midwife and to work with women. So that's the key point, and very important that we flex around that. And principles of preceptorship, I think very interesting if you're starting a new job to just ask about what the preceptorship arrangements are, because it is very important. It's that very important transition from being a student to being on the register and a professional, an autonomous professional. So absolutely vital.
Thank you to Jackie and Verena. Now there are other questions, and we'll follow them up in the
I'm
in
responding.
the chat.
Yeah, I'm responding to them via the WhatsApp. I think that's the best way of doing it.
Very good. Okay, thank you both.
Pleasure.
Pleasure.
Bye.
Bye-bye.
Welcome back. This is now the Student Midwife Experience Festival. We've sent all the lecturers and others off onto their own anxiety-ridden excursions about how on earth they cope with teaching all new students. Now, no doubt you've all had a cup of tea, a drink of water, or some of those buns and donuts that Salford and others are meant to have been putting in. We've closed poll number 7, and we've just opened poll number 1. Have you experienced assessment problems due to the number of midwifery qualified teaching staff on your placement? So that's a slightly harder question about assessment problems and things. And so that poll is now open, and we will share the results of these later in the day. So this is now students only, and I'm very, very pleased to introduce Nicola Rajan Brown is a student midwife at the University of Salford, who's going to be your chair for this session. And I know also that the Salford students, who are getting a disproportionate amount of shout outs, have got themselves very well organised. And we will be very interested in the evaluation later on, if people around the country can fill that in, just to see how this has worked, because we can do this quite a few times through the course of the year. Had a fantastic session this morning, and I'm sure you're going to have a fantastic session now. So over to you, Nicola, you're in charge.
Hello everybody, it's wonderful to be with you all this morning. We've had some wonderful speakers and I'm really excited to get on with talking about student experiences. I think being student midwife is such a unique experience, and it's great to be able to link up with other students and to be able to connect with them about that unique experience. It's something very special that we get to do, and we must thank everyone at MMF who's given us this opportunity to link together as students as this special first student experience festival that we have. So let's dive right in. We've got 3 wonderful student speakers here with us this morning, Charlotte, Samantha and Alana, who are all going to be talking about their experiences of being student midwives. So we're starting off with Charlotte. Charlotte is a newly qualified midwife who is now working in Gateshead at Queen Elizabeth Hospital, having recently qualified from Northumbria University. And she is going to be speaking to us about surviving, but are they thriving? An exploration of the experiences of newly qualified midwives during the preceptorship period. Please do pop your questions in the box underneath the live stream, and we will be responding to those at the end. So Charlotte, over to you.
Hi everyone. Hello, hi. I think Catherine's just going to get my presentation up, just obviously I couldn't share it there, and hopefully that's coming up on the screen there. That's okay. So obviously, just as Nicola said, so I'm Charlotte, and I'm here just to present a very brief summary of my undergraduate dissertation that I wrote and submitted kind of earlier this year, the title of which was, as Nicola said, was Surviving But Are They Thriving? An exploration of the experience of newly qualified midwives during the preceptorship period. Okay, next slide please. So just as kind of just a brief little introduction of me and my background. So I recently graduated from Northumbria University in Newcastle this summer with a first class honours degree. I'm a newly qualified midwife and I've been working full time at one of the trusts that I actually trained at. I started working about 7 weeks ago and I've started to complete some of my preceptorship competencies. There's obviously many things I'm really passionate about promoting and improving in midwifery, but I think something that has become very relevant and prominent recently is about bettering the experiences and well-being of midwives to improve the overall care that we can provide to those who access maternity services. Therefore, my dissertation actually focused on the transition from being a third-year student to newly qualified in the experiences of newly qualified during their preceptorship period. At the point of writing this, I was a student who was approaching qualification employment. Therefore, this was a significant area of midwifery practice that I wanted to critique from a personal, professional and organisational perspective. What I'm mainly going to be focusing on is what the literature and research states about newly qualified midwives, their experiences and the systemic structural issues that contribute to that. Next slide, please. So what actually is preceptorship? I've actually had a number of student midwives approach me whilst on shift for the last few weeks, ask me what the preceptorship period actually is, what does it include and what does it mean for being newly qualified. So the preceptorship period is the time frame from being newly qualified on entering the register as a band 5 to achieving the expected progression to a band 6 midwife. It allows you to consolidate your skills and confidence, but also practice skills that you might not have been able to experience as a third year. So including like your cannulation skills, your perineal suturing, theatre scrubbing, and intravenous medications. It's really important not to confuse your preceptorship with being supernumerary. Being supernumerary means you're not counting staffing numbers, and this is only for a short period of time. Depending on trust, this appears to differ massively in length when you're qualified, from a couple of weeks to a couple of months. But once your supernumerary is over, your preceptorship like kind of continues within a time frame you're comfortable with. People tend to say it's usually between like 12 and 18 months, up to 2 years before you get your band 6. The RCM fully support the need and requirement for a mandatory and regulated preceptorship package. And the NMC, as Jackie said before, have some great information available in their principles of preceptorship, as discussed by obviously Jackie and Verena, but it does actually remain a voluntary model that is dependent on local engagement, and this is implemented on a local basis. Therefore, this allows for lots of differences between each trust, basically on trust basis. For example, looking at my cohort alone who have just graduated, we're all having different opportunities and different offerings of preceptorship, and therefore very different experiences on terms of the level of support that we've been receiving. Next slide, please. So kind of looking at my findings from my dissertation, I used a literature review and conducted a thematic analysis based off the research, and I kind of identified 3 different recurring themes within the literature available. So the first theme was opportunity exposure, the second theme was perceptions and experiences, and the third theme was competence and confidence. So with the following slides, I've kind of summarised what some of the researchers found within each theme. Next slide, please. So the first theme being opportunity exposure. So here's some of the statistics and information that I found kind of under this theme. You know, one study found that 23% of their participants hadn't actually been allocated a preceptor. You know, another one reported that a midwife told that she hadn't been allowed to actually attend a staff induction, and this has been due to staffing levels in their unit at the time. You know, some of the research actually identified confusion between your preceptorship and your induction period into a new trust, and many actually thought these were interchangeable experiences when they're absolutely not. You know, supernumerary allocations are not always honoured due to other areas being understaffed, and some report that there was no time to actually be able to complete your preceptorship related paperwork as well whilst on shift. And this is all interesting points, because despite being supernumerary and not counting staffing levels in this point, this is kind of experiences that some newly qualified midwives have been having. Next slide, please. So kind of my second theme that I identified was perceptions and experiences. So one study reported that only one midwife had actually had supernumerary time in all clinical areas. The rest kind of said that it was very inexact and very unstructured. You know, a study in 2011 by Hughes and Fraser found that one midwife didn't have any supernumerary time at all and was regularly used in the numbers for staffing. Another study, you know, describes the relationship between midwives as being a life raft, recognising that kind of separation between juniority and seniority of a them and us, and knowing your place in the system. And you know, in 2019, Norris found a midwife actually instructing her junior newly qualified midwife, her preceptor, to actually just suck it up and then sink and swim. These kind of findings and the language I found while doing my dissertation and my research was very interesting. I found the language used by midwives very interesting when talking about their newly qualified experience and their preceptorship. You know, kind of looking at the terms like sink or swim or fairy tale midwifery, being into the wilderness, needing a life raft. And these are all things that as students you've all, you know, probably heard in your career in terms of talking about that transition from student to qualified, and how people talk about that kind of with those negative connotations. Next slide, please. So the third theme I identified within my research was looking at competence and confidence levels. So a lot of the research kind of focused on like that university level of training that you have, and how maybe that doesn't like adequately prepare you for you know, the realities of working, you know, as a full-time or part-time midwife, you know, in employment. And that kind of move of your identity from being a student midwife to a newly qualified midwife, it is daunting, you know, and, you know, some people report, you know, being stressed and, you know, being very concerned that now it is, you know, your autonomous practice, you know, under your pin, it's your name, and what you're doing is kind of, it's down to you and your autonomy really as a practitioner. But lots of the research also suggests that it's not actually gaps in knowledge that kind of are contributing to the issue. It was skills such as like time management and multitasking that are really difficult to consolidate as a student midwife, and something that you do definitely learn, I think, once you start kind of practicing as a midwife. So next slide, please. So I've kind of got a little summary here about my own experience as a student midwife that I'm sure that many of you here can relate to. So, you know, occasionally being moved from one area of your unit to another despite your placement allocation, and usually this is due to staffing levels where, you know, maybe there's more students than can be allocated in terms of staffing, whether you're on like labour ward or the postnatal ward or on the assessment unit. This was thankfully a rare occurrence for me, but I know some of my peers did have different experiences of this, where, you know, they were on their birthing experience placement and couldn't actually achieve their competencies in that area because they'd had to move due to staffing levels. Finding the time on placement to complete your paperwork and documentation, you know, all things are absolutely required in terms of your numbers and your proficiencies to qualify, but actually finding the time and the opportunity to do that on shift, you know, is really difficult. As a guest, I'm sure you all know and have experienced yourselves. I think as well that something that I found really important was I was always given the opportunity to express whatever felt out of remit of my practice. I think this is particularly important during third year when you're working under like indirect supervision, and kind of feeling able to and feeling comfortable enough to be able to speak up if you feel like you're doing something, like I said, is out of your remit, that you don't feel comfortable in doing, that you don't feel like is within your level of practice as a student midwife. And having that opportunity is, you know, really, it's absolutely paramount. It's so important to your practice and to your learning, really. And something else as well that I kind of experienced as a student that I've already touched upon is hearing the negative language that's used around being a qualified midwife, especially newly qualified, in that, you know, that first year of practice. I found it really confusing and quite intimidating and almost daunting at times, especially on the run up to qualifying, hearing how other people talked about their experiences and what they found about it. And I found that quite hard to hear, I think, on that run up to qualifying. Next slide, please. So kind of looking at my own experience since I've qualified. So obviously, like I said, I've been working for the past 7 weeks now. I've had some absolutely great support from practice development midwife in my trust, you know, senior midwives and you know, the support from my peers, other girls that I qualified with and have since started working alongside. You know, the practice development midwife, she's been very supportive and has had an open door policy that myself and the other newly qualifieds have, you know, felt very comfortable using if we felt like we've had any issues that we needed to talk about. You know, as mentioned in my first slide, I've been given a named preceptor who is a senior Band 7 labour ward coordinator, but I've also been made aware of who my line manager is, who my professional midwifery advocate is, who my appraiser is, and these are all really important roles that should be identified to a new starter, whether you have been in the trust as a student or whether you're there as a completely new moved into the area. And you know, these are things that need to be identified to you when you start work, really. I've also been given the opportunity to extend my supernumerary time from 8 weeks to 12 weeks in clinical practice. You know, we were given the opportunity to actually negotiate where we felt like we needed it. So for me, I asked for an extra 4 weeks on labour wards. I felt like this is where I kind of needed the practice and where I need that little bit extra support. And I've been able to negotiate that successfully and be able to have that kind of opportunity for a little bit extra support where I needed to. I've also tried to talk about being newly qualified to students that I've come across on placement quite positively, and that's because it is a positive thing to, you know, you've worked hard to gain your qualification and you should be able to, you know, celebrate that. You know, it is important to kind of be realistic about the realities of working as a midwife, but it's also important to not be off-putting and be like negative in how you address yourself and how you address the profession. Again, things that I'm sure lots of students have kind of heard in their time on placement. As we've said today, students are the future of this profession, and it's so important not to dampen your spirit before your career has even like kicked off and begun. And I think I have definitely appreciated and recognised my role as a role model as a newly qualified midwife to students on placement. And that I'm here doing this job because I love being a midwife, as most other people in this profession also do. And we shouldn't kind of dampen your spirits by talking negatively about being qualified. I think working where I trained has also been massively beneficial. I already had lots of positive relationships with colleagues that have since strengthened since I qualified. I know this doesn't necessarily apply to newly qualifieds who seek employment elsewhere. For example, one of my best friends in my cohort chose to move to a completely different area of England as a newly qualified midwife, but she should still have that opportunity to meet her essential colleagues before starting, such as including, her manager and her preceptor and her ward coordinator before starting to work the floor. I think building those relationships when you qualify is super important to establish right from the beginning of your employment and of your career. And kind of I still think that a little bit myself that it has been shown in the research as well that many kind of start and don't recognise your own personal autonomy. I know for me as well, I feel like I've been very much in student mode and very much deferring to my seniors and asking questions that I've not necessarily needed to ask because, I'm okay to go and do that now. And, as Jackie Williams said earlier, we're absolutely ready to practice and to be on the register upon qualification. That's how you get your qualification as a midwife. And it's important to not only recognise that, but embrace that. And I think that I've definitely had to reflect and improve upon this the past couple of weeks. And overall, I've had kind of my ups and downs in newly qualified so far, but I think that's really natural. It is a massive learning curve, that transition from student to qualified, and it's a big transition to make. But personally, I have had, an overall positive experience so far. Next slide, please. So kind of going back to obviously the research and the evidence side of it with my dissertation, what I conclude are my suggestions going forward about newly qualifieds in the preceptorship period have been based entirely from the literature and the research available, in hoping that every newly qualified midwife can have the best possible start in their career. These are conclusion suggestions that I made while writing my dissertation, and looking at it now from a now qualified midwife perspective, I still absolutely agree with this summary. Most of the research was autonomous in its findings and have been reporting similar findings and suggestions going forward for years. So looking at kind of the conclusion suggestions that came to was that there needs to be changes to organisational and personal approaches to being a newly qualified midwife in practice. I think that this should absolutely be reframed, and I think that if newly qualifieds went into their preceptorship feeling better supported, more positive about what's to come, it would be a massive cultural shift that is super important, that if we want to support newly qualified midwives and want to give them the best start in their career. As I'm sure we're all aware, staffing remains a chronic issue in maternity services. Retention and retirement rates are affecting the number of midwives that we have in the UK. And I know that this is something that has begun to be addressed by increasing student numbers across the country, but this change is going to take time. You need the clinical midwives in place to enable that practical training. And although patient safety is the most paramount issue amongst establishing safe staffing levels, and I think followed by issues such as burnout and stress, but these problems all do kind of culminate and all do link together. And I think that increased staffing levels would obviously allow for the protection of supernumerary time and a skill mix on shift, allowing supernumerary midwives and newly qualified midwives to feel confident in asking and seeking support when necessary, and therefore thriving rather than struggling within their newly qualified status. I think on a local level, one of my suggestions is independent auditing of trusts, looking at their own preceptorship packages. This would enable kind of appropriate and relevant adjustments to be made to suit the services on a local level, but also to allow for the building of a template that could contribute to, I think, a national programme. If individualised, you could look at transferring your student portfolio to being newly qualified, taking that with you when you qualify, kind of presenting that, taking the feedback you received at the end of your third year and applying it to your practice. Like for example, where I talked about where I've been able to opt for further supernumerary hours. I think it's super important to have that individualisation and knowing where you feel like you need that little bit of extra support and that, that boost to your confidence. And I think that's absolutely fine and a great thing to be able to speak up and say. I think that, if preceptorships were regulated and mandatory, very similar to the education standards of pre-registration, so at university, how that's all very regulated by the NMC. I think if that same approach was adopted by the NMC, then all newly qualified would receive the same universal level of support that the research shows, and that I personally believe is so important at the very beginning of our midwifery careers. So I think that's kind of it. A very brief, very quick summary of kind of my dissertation and the findings for preceptorship and newly qualified midwives. So thank you very much. I hope that you've all found that summary very interesting, and the evidence and findings as well. Thank you.
Thank you so much, Charlotte, for such an insightful discussion about preceptorship. It's really interesting to see how your findings in your final year of your studentship have kind of really come to fruition, and how you've been able to reflect on how that's really been the case for you in your first 7 weeks. So thank you so much for being so honest about your experiences. The word that kind of really came to me was embrace, and how we have to embrace our preceptorships and our studentships, and I think that's a word that we can all take on board. So thank you for going some way to changing the culture by sharing your experiences with us today. If you've got any questions for Charlotte about preceptorship and about what she's discussed today, please do pop them in the box, and we will come to those at the end of this set of talks. Next, we're going to be moving on to Sam Perry. Sam is a first-year student midwife at the University of Southampton, who is very busy. Alongside her studentship, she is the social secretary of her midwifery society, a volunteer with St John's Ambulance Service, and a student member of her breastfeeding support team, alongside having a young daughter. Charlotte today is going to be talking to us about midwife-mentor relationships and how you can help the next generation of midwives excel in placement. Sam, over to you.
Thank you very much. I would also love to thank Charlotte as well. Really great to hear about preceptorships. I feel, a lot of us do hear the word and not really find out much about it in advance. So it's really interesting to hear your perspective, and there's some points overlapping with my talk that will be coming across. That it's really nice to see the changes you're making for the future generation. So I'm Sam Perry. I'm a second-year student midwife at the University of Southampton, and I want to speak about student midwife and mentor relationships and how all of us can help the next generation of midwives to excel in placement. So building relationships with the people we work alongside is a key skill that we have to learn very quickly when we're studying midwifery or any other healthcare subject for that matter. The corona cohort, as we've somewhat become known, is still having to adapt to this skill while overcoming barriers to personable connection, such as PPE and social distancing in times of COVID. Many universities and NHS trusts obviously have the documentation in place already advising supervisors of nursing midwifery students how they should conduct themselves, the big do and do nots, and NMC standards tell practice supervisors how they should support safe and effective learning. But what can be done to nurture and inspire and encourage? While preparing this talk, my lecturers were helping and advising me, and they obviously told me about the fact that the NMC changes happened in around 2018 onwards to how students are mentored and assessed. I've never experienced the old form of mentorship, so I can't personally reflect on that, but I really do find the terminology change in itself interesting, and the imagery that those words bring to me. So I wanted to touch on that a little bit. So the terminology, to me, supervisor is someone who does just that, they supervise. Dictionary definitions speak of someone being in charge of another person, and to me that doesn't inspire collaborative learning. The word mentor, however, it speaks of another person who's guiding you, a wise and trusted teacher. Who would you rather have teaching you? This person who is guiding you along your journey, or someone who's telling you what to do. To some, this change obviously may just be a word, but for me, it speaks of a whole different ethos and a different way of being. Understandably, at the moment, there are barriers, which Charlotte touched on as well, about potentially changing the ability to be people's best selves while mentoring. Staffing levels are challenging at the moment, with over half the UK maternity services are understaffed, vacancies have been doubling, birth ratios are up with over 33 births a year, I think now, to every registered midwife in the UK, and that's more than the RCM recommended safe level of 28 per midwife. Morale is being hit hard with all of this combined to adapting to the new ways of working under COVID. So to support the future midwifery workforce and enable students to succeed into the much needed position of registered midwife, I really think steps should be taken to ensure that the best guidance from practitioners is being provided, especially in these difficult times. Practitioners are in a key position where they are able to leave lasting impacts on students. This is both personal, professional, and I've experienced both. And I've experienced them both in a positive and negative way. Now, this isn't me coming to vent about my experiences as a student midwife, more the lessons I've taken from these experiences, which I then intend to use to shape my own best practice as a future mentor for student midwives. So what do students most appreciate? What aspects of being a supervisor give students the confidence to excel while on shift with them? How can midwives help these students to achieve their utmost potential while in their supervision? And what turns a supervisor into a super mentor? I should probably put a trademark on that. So things I'd avoid. I'll start with the negatives. There thankfully are less negatives than positives. Referring to students as the student. Unfortunately, many of us have been that person afraid to speak up because they don't feel acknowledged or appreciated, or just recognized. As mentioned before, there are really tough times at the moment, but venting has a time and a place, and around the future of midwifery probably shouldn't be it. We're not unaware of the staffing problems in maternity services. We see it online every day. We see it in journals constantly, but if it's going to get better, we need to encourage and inspire instead of scaring. Just like Charlotte said, we need to encourage. And correcting without conversing. This one I found difficult to describe. But it's something I've come across a little bit here and there. It can be difficult to find the line on as well. But my main point is that when giving constructive feedback to students, allow them to explain where their rationale came from, have a discussion around perceptions and why they think that way, then explain why you think it in a similar way and see if they understand, make sure they understand. And you never know, you might identify a gap in learning that needs attention, potentially even at the academic level. And what will I keep? So in my toolkit, when someone knows my name and uses it, I feel supported. I feel seen, I feel motivated on shift. It helps me feel cared for. And more importantly, in an emergency, it allows for clear, accurate communication. So introduce your student to everyone by name. It's great practice and it will make them feel seen. Asking for the goals for the shift. So this one, what are a few things they'd like to focus on for today while they're with you? The first time one of my mentors asked me this, and it was straight after handover, it blew my mind and made me feel instantly at ease. I just thought, oh my God, this person's an amazing teacher. I think I managed to stammer out something about CTG interpretation and vaginal examination being areas that I felt I hadn't worked on much. And then from that, advocate for your student. The same midwife later in that day asked the woman we were with if she would mind me performing a VE after she had, and explained that she would have me understand my understanding first, then she would explain what she had felt. This made me feel like I had been listened to and the midwife was able to hand over appropriately while teaching me. Explain the rationale. So something as simple as reminding your student the reasons why you have chosen to ask a woman to move to another position, what happens anatomically and why. This really helps that theoretical knowledge we get in the classroom come across and become steadfast in our brains as to why we do these things. And finally, being kind. There is always room for more kindness in the world. Students are terrified as well about everything at the moment. It's not just staff who are stressed. Staffing COVID, we can't see practitioners' faces to see if they're smiling at us. So be kind. We all know how to do it. We do it with the women we work with every single day. So do it with your students too. I think my big 5 is knowing your student name and using it. It encourages safe, personable practice, and communication is encouraged from it. For the goals, you can make a big difference in just one shift. Yes, the mentorship process has changed. People may only be with you at one shift at a time, but That change in mentorship doesn't stop mentors helping us achieve our goals, especially those short-term ones. After all, progression through a series of successes helps us stay motivated and validated. So explaining rationale, bridging the gap between practice and evidence-based practice, and showing us how it works with that rationale. Stress, we're all stressed, we're here to support each other, so just be kind. And students are the future of midwifery. So be the change you want to see and inspire future midwives. And I'm really glad to see people like Charlotte doing that already. I'd like to thank my cohort for their continuing support, and Midwifery Society and lectureship team for help support me around the talks as well. And thank you guys for listening. I do have a poll that we'd like to put out about your experiences, because I'd really love to hear what experiences you've been having around your midwifery studentships. And if you want to contact me at all, my contact details are there. Thank you.
Thank you so much, Sam, for another fantastic presentation there. I really liked your discussion around the change of language. As somebody who has kind of been under both systems, it's something I've really struggled to change, and it's great to kind of delve deeper into the meaning of the language and kind of what it means and the impact that it has on how we understand the process of supervision. And I also think it's such a relevant thing for us to be thinking about as we move towards integrating learning about mentorship into the midwifery programme. And it made me think about something Sheena Byram says about being a midwife to midwives. And I think we can all do that, kind of take all that practice and all those skills that we use when we are a midwife and use that when we're working with our colleagues and working with other students. So thank you for that. There's been loads of questions coming through for Charlotte. Please do get involved in the poll that Sam has organised for us. And if you've got any questions for Sam or any comments about mentorship and student supervision, please do pop them in the comment box below, and we will come to them after we've had our final talk in this session, which is from Alana Potts, who is a second-year student midwife at the University of Leicester. Alana is particularly passionate about changing the future of midwifery and investing in the student experience. And she's going to be talking to us about the experiences of student midwives during COVID-19, a review of the available literature. So Alana, over to you.
Hi. First of all, thank you for having me on here. And also I want to say a big shout out to the girls at the University of Leicester, because I know they're watching, and I know I'm probably going to get lots of messages soon, just being really supportive. And also thank you to Wendy and Prableen from my course earlier for being so amazing. Yes, as mentioned earlier, my name's Alana. I'm a second year student midwife. I've been working in Leicester for the past year and a half with COVID in particular. You can see at the bottom of the screen here that you have my Instagram handle, which is Midwifery in Love, and the other Instagram handle is MSci Midwifery with Leadership, as I am part of the Masters programme at Leicester. Can I have the next slide, please? Thank you. So a little bit about me very quickly. I'm a second year student midwife, as mentioned earlier. Our motto at the University of Leicester is to be citizens of change, which is something that we strive to do every single day when we're on placement. I also have a previous degree in medical science. This is my second degree. And I was also a previously trained doula. I used to work in Sheffield, and I really enjoyed working as a doula and supporting women and birthing people throughout their birthing journeys. I'm really passionate about birthing person-centred care, and I strive every single time I'm on placements to try and involve the birthing person in every part of their care as it is person-centred. Next slide, please. So as you can see here, these lovely ladies are all the members of our MSci programme, years 1 to 4. We recently had our new first years coming and we met them, and they're all so sweet and lovely. So I chose this topic mostly because of the fact that I myself was a COVID student. I was a member of the COVID cohort. I started at the end of 2020, and before that I was working as a doula and as a carer. So I have first-hand experience, especially with the struggles that we have at the moment with PPE and mentors and all the stresses of being a student while having COVID and trying to get to placement and ourselves not being very well sometimes. So I'd like to discuss this a little bit further. Next slide, please. So one of my main points that I found as for myself and also with my research was that there's lots of effects of COVID-19. So as we all know, we've all had to change the way that we work, whether we've worked in an office or we've worked in a hospital. PPE has been a major barrier for a lot of people. And we found that birthing people have had much less clinical contact, which has meant that there's been a lot less opportunity for students to practice hands-on skills, particularly in the first start of their programme. In my experience, I started on community for my first placement, and majority of the community contacts were actually phone calls. So it was quite difficult for a lot of students to have that hand-on-hand contact and experience the joys of midwifery from the get-go. We obviously had some contact with the birthing people that our mentors were looking after, but it wasn't as much as it used to be. So a lot of people struggled with that. Mental health is also a major concern. My university kept telling us about the importance of peer support and talking to each other. So we started a WhatsApp group. But obviously a WhatsApp group isn't the same as being next to people all the time and talking to them and having that shoulder to cry on and that person to discuss your worries and your woes and your joys with. Obviously we do try to celebrate each other's successes and support each other through our shortcomings and anything that we're quite concerned about, but it's just not the same when you can't have a cup of tea with somebody and you're just looking at a screen. Another one is safety concerns. So a lot of students, particularly myself, are quite concerned about the levels of COVID. I know that Leicester is fluctuating sometimes dependent on the area that we're working in as to whether it's safe or not to go into rooms for COVID. We don't go into COVID rooms, so we're on that safety line. But some students in other areas have been concerned that they might contract COVID as a part of their studies. And a lot of students, as a result of COVID, have actually felt sidelined. So because of COVID, again, they haven't been able to do as much as they used to be able to do. So instead of being hands-on and discussing with the birthing people and palpating and doing those auscultations and all the nice little things and listening to the baby's heartbeat and discussing it with the parents, they kind of feel sometimes that they're sort of put to the side a little bit. I had not too many experiences of that when I was in my first year, but I know that some people in my cohort have. And they discussed a sort of a disconnect between being a student professional and just being a shadow. And sometimes it's quite difficult to distinguish the two. I know for a lot of midwives, they do struggle to encourage students to get hands-on, particularly if they're not sure of the student's confidence level. So yeah, that was one of the major problems. Next slide, please. Another thing that I identified was course requirements and online learning. I know for myself, online learning was quite difficult to adapt to because I had the experience previously of being in a university and being with my cohort. One of my pieces of research actually said that late changes to course requirements led to anxiety regarding course completion, which is something that I saw a lot on placement. Particularly when I was in labour ward, which was my final placement, sorry, my second to final placement when I was in my first year, a lot of final year students were clambering over each other to try and get those 40 births. And a lot of them were working until late after their shift had finished and being told to go home because they were so worried they wouldn't be able to get their course requirements. And some of them in particular were having to not so much take births from other people, but they felt so guilty for having to request the opportunity to assist somebody with their birth, which could have been for a first or second year student midwife. And that kind of lack of downtime and that lack of you time and time to relax meant really stressed students, which has now evidently led to a cohort of exhausted, newly qualified midwives. I know it's not the same for everybody, but a lot of people have been really struggling with their mental health as a result of having that late stage difficulty and stressing about whether or not COVID's going to impact their preceptorship period. Students have also been pulled from clinical placement. At the start of last year, a lot of students were pulled from their placements and told that they couldn't continue with their placement as a result of COVID. And a lot of them had to make up that time in the summer when they should have been relaxing. So that's created a lot of stress and poor mental well-being. And the transition to online learning, I know for myself, it was quite difficult, but I imagine for the second and third year student midwives who've been in the classroom and with their peers, It must have been quite difficult, because all of a sudden you have to learn this new skill and learn this new way of learning and take it all in your own hands, and it's quite stressful because you feel like you can't balance it all. Next slide, please. So the final thing that I found is staff culture. So while a lot of people are quite negative sometimes about the stresses to do with midwifery, most people are actually quite positive. However, there was a massive worry about staff morale, especially in the middle of COVID when it first hit. 90% of staff leaders actually worried that staff morale would go down further because of the lack of peer support and the increased workload, as well as the difficulty with not knowing whether or not students are going to be there or not. So all of a sudden you had this wave of spare hands just going off because they weren't allowed to continue with their placement. And a lot of managers in the NHS trusts really didn't approve of students being exposed to COVID-19 as a result of their course. So that led to a lot of students across the country just being pulled from their placement. The occupational exposure to COVID-19 was a massive concern for a lot of students, myself in particular. I didn't really understand what the PPE in hospital meant because I'd been doing it separately in care homes and with people who were birthing in their own homes. So it felt quite nice to know that there was mutual risk exposure, which is what I also found in my research, that you knew that it wasn't just you, everyone else there had the same kind of risk or chance of getting COVID. But as long as you did the PPE and you encouraged it with patients as well, you had this comfort level, which kind of increased the level of support you felt you had. And a lot of students said they felt really valued for their current skill set and support, because obviously we are learning, but there are a lot of things that we can contribute. And a lot of students solidify their learning through practice. And as a result of this, they then have this skill set that can be used by qualified practitioners. And qualified practitioners in particular really said that a lot of students felt like they were a helping hand or a safety blanket because of the fact that they had this extra skill set that was both new and challenging and interesting, but was also really, really supportive, and it encouraged the people in our care as well to feel well supported. Next slide, please. So my final thoughts from all of my research and my personal experiences are that it's important to support students to thrive, which is very similar to what Charlotte and Sam both said. The importance of getting students to thrive rather than just get on with it. It means that when they become newly qualified midwives and when they are out there and helping people, you know that their mental health is going to be good, and you know that they're going to be working as hard as they can because they're so passionate about their work. Another thing we can do is support each other. So like this whole, this peer support in these groups, and having that knowledge that there's other people out there who have got your back and they're going to look after you and you're not on your own. If we focus less on numbers, so instead of students being like, oh, I have to get 40 births and I have to get, 30 practice episodes and this many additional care needs, instead of focusing on that, think of it as, I have to get this kind of experience, and speaking to your mentor about the fact that you want to have more experiences in this practice area, or you need to have more experiences in this practice area, it really makes a difference. And if we enjoy the privilege that we have at the moment with being supernumerary, and also with having these experiences with pregnant birthing people and their beautiful little babies and their partners, it's the biggest privilege in the world for me, and I'm so passionate about it. And I know that if I need support, which is my next point, I can reach out to it. My practice learning team in particular are really good. And if I have any concerns, they'll respond to me within hours, sometimes even minutes, if they're on shift. So the final thing that I'd like to leave you with, I found this when I was researching my papers, is a poem that a student midwife had written about being part of the COVID cohort. And please forgive me, I'm not very good at poetry, but it is basically, we were given a choice, one that was tough, to work as a midwife because there's not enough. Some were unable, as they're at risk already. Others can't commit because childcare is unsteady. It doesn't mean these students didn't want to assist. It's because their mums first, or their doctor put them on a list. When hugs are no more and I can't hold your hands, know that we are each other's biggest fans. For when we're worn out and the virus is over, we can all get together and share a hangover. Thank you very much for listening. I've been Alana Potts, student midwife.
Thank you so much, Alana. I think everyone listening to this can really resonate with what you said about experiences of being a student midwife during the COVID cohorts. We've had a lot of messages through and comments about how much people are resonating with everything that you three speakers have said, and I think it's really lovely to see how your presentations all link together, and how, you know, this community that I was talking about at the beginning when I was introducing you, this unique experience, you can really see that across all of your talks today, and how much they all link together. And Alana, I just wanted to kind of pull something out of your talk, which I found particularly interesting, was this idea of touch, and how touch is so central to what we do as midwives, and how that's something that's been kind of taken away. And especially if you started your training during that lockdown period, rather than kind of before or after, you've really missed out on developing that kind of element of touch in a time where we've not been able to kind of touch as much as we would usually do. So thank you all three for such wonderful talks. It's been lovely to hear from you. And we're going to move on to some questions now that we've had in, and some comments. Let me find it. So to start off, we've had a few questions for Charlotte about preceptorship, kind of around the idea of how we go and find the preceptorship course and preceptorship area that would be kind of beneficial for you. I don't know if you've got kind of some personal experience about how you decided which area or which trust you were going to do your preceptorship in.
Absolutely, yeah. I mean, as I kind of said before, so as part of my training as a student midwife, actually I work between 4 different NHS trusts, one of which obviously that I have obviously sought employment in and have began to work in as a midwife. For me, it was kind of deciding where I felt like I was most comfortable, where I felt like I wanted to, actually practice, and where I felt was, best in terms of for, not just for me, but where, I don't want to say where needed me, but where I felt like I could add something to the culture and add something to their maternity services, really. And in terms of what offers in preceptorship, I mean, that was kind of what I was like discussing with my dissertation, is that every trust is unique in the sense of their preceptorship package and what they choose to offer. So I think that this might actually change slightly with the new education standards, so just bear with me. But for example, with my cohort, things like suturing, cannulation, IVs, like things like that, we all learned the theory about, and we did a practical session in university, but your experience of actually doing it in practice, it wasn't necessary to qualify. You needed to have had the theoretical and the clinical, like using the dummies and stuff, but to actually suture in practice, you didn't have had to have done that to qualify. And things like obviously cannulation, I think, has now been introduced, I think, to 3rd year. I'm not 100% sure whether that has been or not. But those kind of skill sets that I get to now kind of do a little bit more in terms of the practical side, and getting signed off of being able to do them really and being competent with them. But each trust, like I said, offers different things. So I'd recommend that when you go for interview, when you start applying for jobs, asking them what can they offer you in terms of their preceptorship, because I think it is really important to make sure you have got the right support that you need, and what's right for you. And different people need different things, and that's completely okay, but definitely asking them when you apply for a job, what can you offer me in terms of the right level of support, and what am I going to learn over the next couple of years of my career.
And I think that goes back to what you were saying in your talk about using your voice, raising your voice, and kind of not being scared to put yourself out there and kind of say, this is the support I want, this is the support I need, and being very clear about that from the get-go, which is definitely something we need to be learning to do as students as well, when we're out in our placement areas.
Yeah, and it's something that it does take time. It took them until literally my last couple of weeks of being a 3rd year, I think, to feel comfortable enough, confident enough to be like, look, this is what I need to do for my own learning, and you know, and I would like that to be facilitated. And it is about kind of speaking up for what you need, you know. Like I said, I've been very lucky in terms of the support I've had with my prepship, and the fact that I've been able to extend my supernumerary time. You know, that is something that is really great, that, you know, labour ward is the area that I feel like I need it in the most. So my trust have said, okay, yeah, that's great, we'll facilitate that, we'll do that for you. So, you know, that has been I think really good. In terms of identifying where you feel like you need that support, obviously I'm looking at the comments and a lot of things about kind of like your numbers and your competencies. You know, I was one of the third years that massively struggled. I think that when I started third year, I think I started with 14 births, and then before Christmas I think I got to 18, so I was still like, hadn't even reached like halfway mark. But, you know, I qualified on 34 and I had my 20 extra assisted delivery, so that was absolutely fine. And it is all about, you know, all the other experiences that you get. And, you know, like being a midwife is not just about catching babies. As I'm sure, obviously, we all know, you know, so many other experiences and so much like wide variety in terms of your clinical knowledge that is so important for qualifying. But just obviously highlighting, so for me, where, you know, like I said, where I need that little bit of export and labour ward is perhaps because I didn't get as much experience there as some of my other peers did, but that is okay, and I've identified that, and my trusts know that, and that's absolutely fine to kind of speak up and say.
And I think this links in with what Sam was saying about, you know, how our supervisors can support us. How do you think, Sam, that supervisors can support students in identifying, being able to vocalise and identify the areas that they need to develop in?
Yeah, absolutely. I think one of the biggest things really is just opening that channel of communication. You know, we're thinking about so much when, you know, people are both learning and mentoring. When those supervisors start that day, if they take that second to say kind of, is there anything you have in mind? Even if that person then stalls and goes, oh, I don't know. Ask them to come back to it later. Give them an hour or two to process and think, actually, what do I really want to have a go at today? And just let them know that that's okay to let them know at any point. So yeah, opening that channel of communication is the biggest thing, I think.
And you've all highlighted that today. I think the importance of reflection and reflecting back. You've all kind of taken pieces of research and things that you've kind of experienced in practice and reflected back on them and how that impacts on your experience. And we all know how important that is as a student midwife. So I think you've all kind of highlighted that in your talks today. Here's a question that I think it would be good for all of you to answer, actually. So the person has asked that it feels like we've been speaking about the issues that NQMs are experiencing, and that students are experiencing the same things in terms of the difficulties of accessing support and having the time to get things signed off, for example. How important do you think these issues are addressed quickly? Charlotte, can I start with you first as an NQM, and then we'll come to
absolutely
my point of view?
I mean, I think that it's something that it needs to be addressed. Like, it's simple as that. You know, what I kind of found with my research, my dissertation, was that, you know, the research goes back to 2011, 2012, saying exactly the same thing about preceptorship, you know, that it should be a mandatory thing, we should be better supporting our midwives. And unfortunately, you know, as we've talked about, you know, in terms of like staffing issues, and, you know, obviously the pandemic hasn't helped, but, you know, staffing issues was a problem before COVID as well. And I think it's important to remember that and not just place the blame on everything to do with COVID, because unfortunately it's not. But I think kind of, you know, recognizing that, you know, when something needs to give and something needs to change. I think, you know, things are starting to be recognized, you know, like as a lot of, I know it was mentioned before about like the March with Midwives, you know, vigils that's taking place this weekend. You know, there has been, I think that we are moving towards a very big movement in terms of some changes in maternity care, which hopefully will be, you know, very positive changes. And things like, you know, the standards for education, the fact that they've just recently been updated, you know, all these changes are hopefully moving in the right direction, really, for students and for midwives. But I think that it's time now for us all to kind of find our voices, really, and to kind of speak up and not be afraid to speak up, and not be afraid to, you know, discuss, you know, just as much about the positives, but also about, you know, where we need help, where we need support, where we need guidance, because it is okay to ask for help. And I think it's really important to remember that.
Alana, can I come to you next? What are your views, especially as somebody who's come into the programme during COVID?
Yeah, I agree completely with what Charlotte said. So I have been looking into midwifery for however many years, I think about 4 or 5 years before I actually started the course. and the concerns of staffing were always a problem. But when I started and I actually realised how difficult it was for me to actually find time to get people to sign my proficiencies, and to ask people, you know, if it's okay to take 10 minutes with me at the end of the shift, but then they'd always be doing documentation, or there'd be an emergency, or there'd be some difficulty with staff changeover, or other students who need assistance. So I think a lot of the thing is confidence to actually speak up and say, actually, please, you know, you promised me, I don't want to be petty here, but you did promise me at the end of the shift, you give me 5 minutes. I just need a couple of things signed off. And if you highlight them yourself like I do, I'm post-it queen. So I have post-it notes everywhere. my poor Maura is just covered in post-it notes. And my poor lecturer, every time she goes to look through it, she's like, oh my God, it's like craft library. It's important to have that kind of organisation, and to understand that obviously we are in control of our own learning and our own experiences that we have when we're on placement, but having that confidence to sort of tell people, actually kind of put your foot down a little bit and say, no, I really need this signing off, because, you know, I need to get this sorted and I'm not working with you again until whenever. So yeah, confidence and understanding, particularly with the moment with staffing levels, that it's not okay. The level of staffing that we have, it's not acceptable. And I think people need to be a bit more understanding the fact that we are only students, of course, but we are as well individuals. So if people just brush us off and say, you know, I can't do that today, I'm not interested, what's the effect that's going to have on your student, and how's that going to affect their overall experience of that placement as a whole?
Sam, how do you think we can be more innovative in our approach to making change in this area of support for students?
Yeah, I think, you know, absolutely, you're saying about, Alana, about advocating for yourself, you know, and that's the way I would describe it, you know, advocating for your own team, and for yourself to be, you know, we advocate for women all day, you know, advocate for ourselves for that time. But in terms of being more innovative, I think it filters down to the training, and, you know, it's expectations set by the trusts that we work with. You know, if people are to be these mentors and these supervisors, and it is any practitioner we could work with, the expectation needs to be on them as well about what we need from them, not just while we're working with them throughout the shift, but in, you know, yeah, the nitty-gritty of the paperwork. You know, we talk about what we need with the women, you know, we work with our women all day long, but there's the nitty-gritty of the paperwork there as well. You know, it's something that has to be done, not something that should be optional. It's, you know, and again, it's something that quite often, I think we've all probably felt it, of being an inconvenience, kind of going, oh, please, can you sign my book? You know, it's it is, you know, it's really hard to be there. So I think, again, it goes all back to training, and you know, making sure that it's a core part of what people understand they do as that person.
I think with kind of the new standards coming, where mentorship is well, supervision is kind of within the program. Yeah, I know my language, I struggle with
I know. I do the same.
No.
Part of the problem, isn't it, moving the language over? But yeah, definitely kind of thinking about that as we move forward into the new curriculum, with that kind of involved in it, that will hopefully make a difference in moving forward. And like we talk about, you know, we're the future, we are. Mm-hmm. We are the supervisors of the future, Charlotte. We're kind of nearly there already. Kind of, you know, as you kind of get further into your NQM year. So, you know, like you've all been saying, it's about taking on these kind of values that we kind of see, and the things that we don't want to take on, and taking that forward into our practice so that we can improve things for students once we're qualified. So it's definitely important to be considering these.
I think a lot of it's to do with approachability as well. Like for me, you know, the fact that I'm still very, very fresh in the profession, but it means that I've actually had students approach me on placement, ask me questions because they find me approachable. And I think that, like I said, I think there's a very big movement going on midwifery. And I think if current students and ones like myself who've just qualified can remember this and bring this into our own practice, and like I said, we will see that cultural change. It's about remembering, you know, we've all been a student. We've all needed things signing off. We've all been that person stood there with a pad like, please, please just do it. And it's about, you know, kind of, I think that mutual respect and that kind of relationship that you have with your supervisor and with your colleagues. I think for me, actually, there was a supervisor I worked with for the first time back April, May time. And this is probably such a minor thing, but a massive thing in terms of language, where, you know, she introduced me to the woman we're going to look at, and she's like, oh, this is my colleague, Charlotte, instead of introducing me as the student. And for me, that was such a massive, like, empowering moment that she probably didn't even think twice about saying. But for me, it felt like we had kind of that mutual respect for each other, but it also meant that I felt, you know, more comfortable approaching her to, you know, for signing off different proficiencies or asking for feedback. And so I think it's definitely a two-way thing. And I think that midwives, you know, we should be doing that and should be, you know, helping our students and making them feel as comfortable as possible to be able to seek that support and help.
Definitely, and we've had a couple of comments about students feeling like they've been undervalued, especially kind of being taken out of placement and during this COVID-19 period, as well as kind of during the difficulties that all maternity units are facing at the minute with kind of having to juggle staff and demand for care and things like that. What are your thoughts around how we can address students feeling undervalued? Alana, I'll come to you first.
Well, one of the things that I suggested when I was on placement last was having possibly like a student forum or a student board for comments. So our placement areas, they give us a feedback sheet, but obviously that feedback sheet might go anywhere. It might go nowhere. We have no idea. It might just go to the ward manager, who might just see it as another sheet of paper and just put it to one side, and the comments never get taken seriously. So for student experience, I'd probably say having societies in every university that does midwifery. We've recently got a university society for midwifery, and it's amazing. The girls who run it are absolutely fantastic. They're all third years, so they all know how it feels to be a student. Having that sort of mentorship program. So in our university as well, the second years mentor the first years, and the third years mentor the second years, and the fourth years mentor the third years. So we have that sort of, like, I think one of our lecturers refers to it as babies, sisters, parents and grannies. She refers to it as that kind of like structure. So we ask anybody for any help, and we have a group, WhatsApp group, that we can discuss our feelings with. But I think the major important thing is that we need to tell midwives and also lecturers as a whole sometimes, because I know sometimes it can be a bit of a disconnect, particularly if they work as well as being a lecturer, that speaking to students as people and not as students and not as a number or as like a lower in the hierarchy is quite important. Because a lot of students do feel that they are unsupported and they're not heard, because they're worried that it's going to get lost in the ether of all that is midwifery hierarchy. And having that approachability, like you said, Charlotte, of knowing your band 7, knowing your ward manager, that's really important. Because if you know who you can go to, even just for a chat, when you feel like you need a bit of extra support, it makes a world of difference. And you feel like there's always someone who's got your back. And there's always someone who's going to fight for you if, say, for instance, something goes wrong, or if you feel like you're being bullied, God forbid, or if you feel like there's something that's going awry for you and you feel like you need a bit of extra help in one area. I think that's really important.
And again, it goes back to what we were saying before about being a midwife to student midwives.
Yeah.
All the things you're saying reflect kind of everything we discuss as the things that we need to be doing with the families that we're caring for. And if we just took that skill set and, you know, applied it to kind of supporting students, it would kind of mop up a lot of these issues that we're talking about. Sam, can I come to you for your thoughts?
Yeah, absolutely. I think, Alana, you really did cover it really well. I mean, it's all about that support for each other. I 100% agree about the Midwifery Society. Our university Midwifery Society was created about 5 years ago, I think. And I think at that point, it was one of the first ones that kind of brought out, because we have such small cohorts quite often in these universities. You know, before we didn't see the point, but actually we're in such a unique position. You know, so many other subjects don't quite understand what we go through. Even, you know, other healthcare subjects, we are best to support each other, but you do need to have that channel of feedback. So within our university, we do have a student representative from each year who feeds back, I think it's quarterly, to the academic team, who liaise the major points across to the trust. So this is something that works really well. Our little cohort WhatsApp chat, you know, it comes around every so often, and the person's like, right, okay, what are the things? So what's bugging you? What's getting on you? Let's feed it back to the trust and let's get that applied. So it really is important to have those channels of communication in an official form. As you say, when you have just a web form or a piece of paper to fill out, you don't know where it's going to end up or how seriously it's going to be taken. But when you've got a person advocating for you, who cares about it, then that really makes a difference.
Absolutely, and we should definitely be using midwifery societies, and this is your chance. If one of you is watching and your university's not got a midwifery society, here's your chance. Go and set one up, or find your local midwifery society at your university and get involved with them, because they are great forces of nature which can be kind of definitely used to support you, as well as that kind of interface of support. We had a question about resilience. Let me just find it. Sorry, I've got a very long list of questions here. I saw it pop up. What's your thoughts on students being told to be more resilient, especially when experiencing negativity on placement rather than universities dealing with the issues? Charlotte, I'll come to you first.
Well, you can probably tell from my face. I heard that word a lot. So obviously, I mean, I think especially given the COVID situation, it's that our word's being thrown around so much that it's actually become meaningless. You know, that's my personal opinion on the word resilient. You know, it is such an important skill, and we do need to, you know, this is a profession where you do need to be resilient in the sense of, you know, like, you are going to see things and you are going to do things that, you know, are difficult, are challenging. You know, you are going to have, you know, days where you do come back from a shift and think, what am I doing? Especially when when you are a student. But you know, it's all worth it. You know, like I said, like, people go into this career and this profession, this vocation, because they love this job. Like I said, I absolutely love being a midwife. You know, yes, I had, you know, very much ups and downs while I was training, and I had to be resilient. But like, you go into this job because you love what you do. You love providing maternity care. You know, you love being a midwife. That is why we're doing this at the end of the day, you know, to improve things for people who access maternity services and, you know, to make it better. I think that, like I said, it's been a word that's definitely been thrown around far too much, that now it's become redundant in its use. And it's such a shame, because it is such an important kind of attribute to have as a student midwife, and you know, once you qualified, it is so important. I think that what it is that it's about kind of now, you know, all kind of, like I said, like using community support. So like I said, you know, like today, where it's really nice to hear from other people, you know, who, you know, have experienced the same thing. You know, thousands of student midwives across the UK who are all experiencing the same thing, you know, reaching out, getting that support, you know, going through it together, you know, knowing that you're not alone in how you're feeling, you know, whether that's, you know, on your lowest of your lows or your highest of your highs, you know, there is someone, you know, who is going through the exact same thing as you, and, you know, the same stresses, the same pressures. And like I said, like, being a student midwife, it is quite a unique thing, you know, like as you said, you know, other people in other courses that just don't quite get what it's about. So kind of definitely finding your community, definitely finding your friends, you know, making those links, and just kind of getting through quite a turbulent time together. And I know that sounds really patronising, but it's what you have to do, and it's what you do. So
No, and I think we all value, don't we, Alana? Did you want to expand?
Oh, sorry, I was just saying it's so true. But for me, like, I pulled a phrase when you said the word resilience, because some people use that word as a substitute for support. So you'll say to a midwife, oh, I'm really struggling today. Can I have a bit of advice? Can I talk to you for a minute? And sometimes they'll go, you need to be more resilient. And you just think to yourself, you're taken aback a little bit, and you're like, I thought I was. I just asked for a bit of help. And a lot of places as well, because you said, like Charlotte, a lot of people don't understand what we do. A lot of people don't understand the importance of what we do, particularly in the birthing people's minds and in the minds of other students, like being a midwife to other midwives. The word resilience, sometimes it makes my bones chill, because of the fact that I have had a lot of friends who are on both this course and other midwifery courses basically say that the word resilience is sort of used as a band-aid, and it's being used as a throwaway term, like you said, Charlotte, and the word doesn't have any meaning anymore. It used to be this whole thing of, we're strong, we're together, we're a community, we can do this, we're amazing. But now it's a thing of, things are tough, suck it up. And that is not how it should be.
Sam, what do you think we can do about the R word? How do you think we can move?
I think keeping it as the R word. That's a good one. I like
Ban it.
that. Yeah, ban it. I'm with the girls completely. Yeah, ladies, the word resilience is far too throwaway nowadays. You know, we're past being resilient. We've been told to be resilient for too long. You know, there's only so long you can be resilient before you go, actually, why are we having to be resilient for this long? Actually, maybe I don't need to be resilient. Maybe something needs to change. You know, because if it's a continual problem, then it's not just something you do in the moment. So I think really taking those opportunities rather than telling someone to be resilient, trying to understand why they're struggling. And then, you know, offering support if you can. And if you can't offer that support, you're not in the place to offer that support, then, you know, just say, actually, I really don't know how I can help you with that. You know, speak to this person might be able to help you, rather than just saying, as come up, you know, just suck it up and deal with it.
Thank you. We're in the last few minutes before we end this session now. So there's been quite a few questions about placement. So I thought I'd end asking each of you for your one top placement tip, or one top tip for surviving a shift. So Charlotte, if we start with you.
Top tip for surviving a shift. Take a water bottle with you, have snacks in your pocket, and breathe. Just
yeah. What are your top tips, Sam?
I think the biggest and best one I ever had, which I didn't listen to and regretted it, was don't bring dinner food on a night shift. Yeah, your first ever night shift, don't bring a big old bowl of pasta for the 3 a.m. break. You will get acid reflux. You will regret it. Your body does not know what it's doing at 4 a.m. Bring a cereal bar and have a nap.
Yeah, I'm one for cereal on night shifts. What about you, Alana?
So my lecturer told me the best piece of advice, because she's been a midwife for a few years, and I do this every shift regardless of where I'm going, and my partner looks at me like I'm insane, but it's take a spare pair of pants and a spare pair of socks, because you never know when life was going to happen. And I agree with that completely. So I take my little water bottle, and I take a sneaky bar of Oreo chocolate, because you need yourself a treat.
Fantastic tips. Thank you all. I hope that's been helpful for all of those who asked about placement tips. Thank you all for some amazing talks and some great insights. It's wonderful to see students linking with each other. It is such a new experience, and to be able to share those experiences together and to be able to relate to each other is something so special. So thank you for being involved in sharing to over 1,000 students today your experiences, and I know that they've resonated with a lot of people. So thank you so much. Now we have a lunch break, and during that time I think we will be having the opportunity to link in with some Cochrane resources. Is that right, Neil?
Yes, there'll be stuff available. We're just closing the last of the polls, and as I say, you can get Cochrane resources material. You'll be able to see the connections on the webpage and in the chat, and we'll be back again at 2 o'clock. I think that's all the announcements I have to make, other than to say a big thank you to Nicole for chairing that session. Very interesting. We galloped through some great presentations. I'm sure it'll give a lot of people confidence to raise questions and tackle issues that they've been facing. So that's all from me, and we'll see you back here at 2 o'clock for Jackie Dunkley Bank.
One of the benefits, I think, of a platform like this is that if you are busy clinically, or if you can't watch or listen or engage real time, you can do this at other times. So that is fabulous for such a time as this. So delighted to be with you all, albeit virtually on the screen. My name is Jacqueline Dunkley-Bent. I'm the Chief Midwifery Officer for the NHS in England.
So this is what's called a hybrid event. There are people in the room, there are people watching in groups around the country, and there are people still watching in their pyjamas at home. Good morning, Sue, how are you?
Good morning, I'm fine, Neil, thank you very much. It's fantastic to be here.
My argument is that the solution is health optimization. Prevention is far better than cure.
And I think there is a real risk that services that are lost or reduced during the time of COVID are not restored.
And I hope that you can take valuable insights from today. And if you're listening tonight, or if you're listening next week or next month, take valuable insights from the speakers from today and share the word, share the positive messages with your colleagues, because in these dark times, in these challenging times, everybody needs a green shoot and a pearl of wisdom. Thank you very much, and we are in this together. We stand united together.
And welcome to everybody who's come this evening. I think we've got an interesting evening. I hope you're going to enjoy it.
I remember another patient who we both looked after, who, you know, was in a relationship with a chap, getting serious, thinking about starting a family. And I remember her bringing him to clinic, him getting tested, them coming back to get the results. He was trait. This was one of our patients who had sickle cell disease, and she dumped him in the room.
Yes, she did.
Dumped him in the room in front of
us.
I
remember. And I said, Mummy, I would never let you get a vaccine that is not safe. So I'll be the first one there, and then once I've had it, you can have it. And I remember this text message coming back to me while I was at work, well, you'll be the first to die. For every touch point, be talking to women about the importance about having the vaccine. And if you don't have information, say that to somebody. I don't have the information. Can I pass it on to the person that can?
Some women are saying that they're actually having a really positive breastfeeding experience because their situation of having to stay at home and not having lots of visitors around and not feeling they have to rush about everywhere means they've actually got the excuse almost to sit on the sofa and just breastfeed their baby.
So Black and brown women and birthing people are not treated with equity, leading to unacceptable levels of morbidity and mortality. They then become marginalised communities that become mistrusting of maternity services, and they might be reluctant to engage because their initial experience has been negative. We then label them as difficult and unwilling to engage, and the cycle of substandard care continues.
It's really difficult to describe really what makes continuity happen, but there is some real magic in the depth of relationship that you have with a woman and her family, and it's really beyond articulation. We know it works. It definitely works for our women and our families, and if you always put them in the very centre of what you do and how you work, that is when the magic happens.
Are you a midwife, maternity worker, or having a baby? Then we've got something for you.
To stay informed, exchange ideas and receive support, come and join our growing online community at allformaternity.com.
All for Maternity is an online platform offering areas to support your learning, sharing and caring needs. In our learning zone, we provide dynamic and informative e-learn modules, access to regular webinars and online workshops that address current maternity care issues, perfect for your professional development.
Our sharing zone provides repositories of information, bringing you evidence to inform your everyday practice and care. Access to support in the form of blogs, forums, podcasts and peer mentoring networks will be included in our caring zone.
We have so much to offer. Subscribing to All for Maternity will give you access to the Practicing Midwife Journal free of charge.
As the first midwifery publishers of the Practicing Midwife, we are delighted to have an opportunity to sustain, curate and nurture this important midwifery journal.
For us, the Practicing Midwife represents you, students, midwives and maternity carers.
As mother and daughter midwives, we've always wanted the opportunity to work together. We share the same philosophy that mothers and babies need the best possible maternity care. All for Maternity helps us to realise this dream.
Through All for Maternity, we will offer opportunities and encouragement to others, providing a springboard for personal growth and positive exposure.
Extending our support globally is important to us. Your membership will support you whilst helping others. For every subscription from a high-income country, one will be gifted to a maternity carer in a low-income country. Joining All for Maternity will give you access to all this and more.
So if you're ready to learn, share and care with us,
we look forward to connecting with you at allformaternity.com.
So good afternoon, everybody. I hope you've had an exciting morning. I've been watching and reading the comments, so some very interesting comments out there. I'm your chair for this next session, which is called Evidence-Based Maternity Care, Cochrane Resources to Help Your Studies and Practice. And I'm very pleased to introduce, as a combined presentation, Linda Ware, who's Senior Fellow in General Practice, and Selina Ryan-Vig, who is Knowledge Broker for Cochrane UK. So as we always say, the screen is yours, and thank you very much for joining us.
Hello, thank you very much. It's lovely to be speaking with you today. We'd like to say just right at the very start of this talk that you're going to hear us talking about evidence-based medicine, but we really should stress that in talking about evidence-based medicine, we're really talking about principles that apply to all healthcare, including maternity care. And we've developed this session especially for you as student midwives, using some examples that are relevant to midwifery and maternity care. So my name is Selina, I'm a knowledge broker at Cochrane UK, and a big part of my role is helping to share evidence and resources in ways that can be quickly and easily accessed and understood by busy students and practitioners. But we'll tell you a bit more about that a little bit later on, but I'll let my colleague Linda introduce herself first.
Good afternoon, everyone. It's lovely to be able to speak with you today. I'm a former GP. I retired 7 years ago after 31 years in general practice, and I'm now Senior Fellow in General Practice with Cochrane UK, and I work alongside Selina.
Really quick overview of what we're going to talk about today. We're going to be looking at what evidence-based medicine is and why it's important when making health decisions, how we can find out if treatments are effective and safe, and where we can find reliable evidence-based health information.
So probably the logical place to start is with a definition of what is evidence-based medicine. Now, its name suggests that evidence is a very important part, and I would agree, but in fact, it's not the whole story. In fact, there are three components to evidence-based medicine. Yes, best research evidence, and that's where organisations such as Cochrane come in. But it also includes the clinical experience and knowledge of health advisors, anyone we go to get health and well-being information. But a third component, which is equally important to the other two, is what we consider to be important for our health. Let me show you that a different way. Here's a Venn diagram that shows those three elements. As you can see, each is in an equally sized ellipse there, indicating that each is of equal importance. So that yellow ellipse, best research evidence, that's where Cochrane and others feed in. Now, if there is some high certainty evidence behind a treatment, then we can feel very confident that we can actually give advice and help decision making by using this to formulate our argument as to why perhaps a particular treatment is better than another. But if I've learned anything in my 7 years with Cochrane, is that I'm afraid research isn't always high certainty and of high quality. So then we need to look to other elements to dovetail with that. So clinical expertise. Now, Selina and I will always argue that evidence-based medicine is for everybody. So whenever we want to make maybe an everyday health decision, what do we take if we've got a cold, for example, or something perhaps rather more impactful, maybe we need to consider surgery or some important treatment for a condition we have, then using evidence-based medicine to help facilitate that decision is incredibly important. So yes, we've got research, but we've also got the clinical expertise of anybody who's helping us make those decisions. And of course, in midwifery, it's as evident as anywhere else. You have with you, in fact, you have two or possibly more patients sitting in front of you. You have a mother and her unborn baby or babies. You will be advising her as midwives, helping her come to a decision as to how she wishes to proceed with her pregnancy and her delivery, and what she wants to happen after the delivery has occurred. And that brings me on to that top ellipse there, the orange one, patient values. This is what we, or in the case of you as midwives, will be considering the patient, the woman, feels is important for her care. Sitting in front of you, you have a pregnant woman. You have an unborn fetus or fetuses. You have her family. You have her expectations and desires, her anxieties. So all of that will feed into this equation as to the best practice of evidence-based medicine. And that occurs where those three elements overlap, as you can see from this Venn diagram. So why do we need evidence? I'd like to tell you two stories now, which I hope will give you some very graphic examples as to why we need evidence. These two examples, in one case, there was no evidence behind a treatment that was being suggested, and in the other, there was inadequate evidence. But in both cases, tragedies ensued. So the first one is the example of Dr. Benjamin Spock and cot death. Dr. Benjamin Spock was an eminent American pediatrician, and he wrote a book which was first published in the 1940s on child and baby care. Now, why is he linked with cot death? First of all, just to make sure we all know what that is, cot death is a indescribably tragic occurrence when a baby, usually under 12 months, dies inexplicably, normally at night. There are occasions when we have no idea why it's happened, but the story with Benjamin Spock is that we possibly do know something that is actually associated with an increased risk of cot death. And that, I'm afraid, was Benjamin Spock's advice. In his book published in the late 1950s, he advocated that babies should be put to sleep on their fronts. Now, why did he think that that was sensible advice? Because when a baby has had their last feed and is put down to sleep, quite often they vomit a little, they posset a bit of their feed. And what he was worried about was that if they were on their backs, they could inhale that into their lungs with potentially fatal consequences. So he decided it was eminently sensible to give the advice that babies should be put to sleep on their fronts. He had no evidence behind this, just his own experience, expertise, and clinical hunch that this was the right thing to do. Now, that was in the late 1950s. 30 years later, in 1989, a researcher in Bristol called Peter Fleming looked into various aspects of cot death. He worked in Bristol and he recruited several general practices and in particular health visitors to help him with this. So with the family's permission, he interviewed families that had suffered a cot death. And then he interviewed families who had had a baby at the same time, but the baby had survived. And very quickly, he noticed that there was a correlation between the baby being put to sleep on the front and the increased risk of cot death. Now, he wrote up his findings in the British Medical Journal, but nothing happened. And it took 2 more years when a well-known television presenter called Anne Diamond lost a baby to cot death, that she and Peter Fleming got together to start the Back to Sleep campaign. This was now advocating that babies were actually put to sleep on their backs. Now, what Peter Fleming did was what we call an observational study. So he observed what was happening in a cohort of patients and made a correlation, a link. He didn't prove that there was a causal link, but he could see that there was quite likely to be a correlation between the position the baby had been put to sleep and cot death. But if we look at the figures as to numbers of cot deaths, in 1989, there were over 1,500 cot deaths per year in the UK. Now there are around 300. They still happen. There are other factors that are thought to be related, but the big thing that has changed in that time is the advice as to how babies should be positioned at night. There was no evidence behind what Benjamin Spock talked about. It was entirely his opinion. The second example I'd like to tell you about is thalidomide, which I'm sure you've heard of. Thalidomide was developed in Germany in 1953 as a sedative, a drug that would help people sleep. But it was discovered that it was very effective at treating morning sickness, so the sickness that women experience it usually in early pregnancy, usually in the first 3 months, although it can go on longer. It's often, as you know, a bit of a nuisance, but it can be very intrusive and distressing. It can even lead to women, such as Kate Middleton, being admitted to hospital because the vomiting is so severe. Well, thalidomide was found to be very effective at treating it. And in 1956, women in Germany could buy it over the counter. They didn't need a doctor's prescription. And in 1958 in the UK, women could get it on doctor's prescription. In 1961, it was abruptly withdrawn because it became apparent that the drug was extremely toxic to the developing fetus. You can see in these photographs some fairly typical deformities that happened as a result of thalidomide, these limb shortening abnormalities. But in fact, it was toxic to just about every system within the developing fetus. And it's thought that around 2,000 babies worldwide died, and of the order of 10,000 were born with abnormalities. It's not easy to know the precise numbers, but that's the sort of order of magnitude. Why was it not known that this might happen? Because at the animal study stage of the testing of thalidomide, it was never tested on pregnant lab animals. There was a criminal court case after this tragedy occurred in order to get compensation for the sufferers and their families. And the only silver lining out of all of this is that from this experience, described as the darkest moment of pharmaceutical research, is that now there are very stringent licensing regulations which determine when a drug can be available, either over the counter or on prescription. And there are several phases which a drug has to go through and pass before it's made available to the public. So 2 examples where there either was no evidence or the evidence was insufficient, but tragedies ensued.
So 2 key questions then to ask about any treatment. Is it effective? So does it work? And is it safe? And we need to understand the evidence that can tell us the answers to these questions. So a little bit about Cochrane then, the organisation that we're a part of. It's a global charity, and its mission is to provide trustworthy information for anyone making healthcare decisions. So healthcare workers, patients, carers, researchers, and so on. Mainly, Cochrane produces and shares Cochrane Reviews, and we'll tell you a little bit about what that is now. So Cochrane Reviews are systematic reviews. You may be familiar with these already, but essentially systematic reviews bring together and summarise the best available evidence on the effects of treatments and other healthcare interventions to inform decisions about health. And it's perhaps easiest to explain with an example. So the authors of a review will start with an important question. For example, is vitamin D supplementation beneficial or harmful for women during pregnancy? And the authors will then search for and identify all of the relevant individual studies which have looked at that question in order to bring all of the existing data together. And that could be anything from 1 or 2 studies, but a review might include many studies if lots of research has been done on a particular topic. When the review authors bring all of the data together, they also make a judgment about how certain or how reliable or trustworthy that evidence is. And they're then able to draw conclusions. They can say, overall, when we look at all of the available data, what can we conclude? Is the treatment safe? Is it effective? And how certain or confident can we be in those conclusions? Cochrane systematic reviews are regularly updated, and that's really important so that they are able to incorporate any new research so that people can always base treatment decisions on the most up-to-date and reliable information. And Cochrane's logo, shown here, is a representation of one of Cochrane's very first systematic reviews, looking at how effective and safe a particular treatment is. And this was the question that the review looked at. Do corticosteroids given to women in premature labour help prevent newborn deaths? So as you'll likely know, when babies are born prematurely, their lungs might not be fully developed, and this can lead to respiratory distress syndrome, a life-threatening condition. It was thought that giving corticosteroids to women in premature labour could help speed up the process of maturing the baby's lungs. So, if it were the case that this treatment is effective and safe, it could have the potential to save many premature babies' lives. And it was a really important question to look at, because although many individual studies had looked into this question and had shown some beneficial effects, the results were slightly mixed. And it wasn't until all of the data from all of the individual studies were brought together in a systematic review that the picture became much clearer. But in order to be able to answer this question, the review authors had to decide exactly what they were going to include in their review. So when they were deciding which studies they would look at and include, they had to think about who was going to be tested. In other words, who were the participants in these studies going to be? What was the treatment they were looking at? And what was that going to be compared to? And what were they going to measure in order to be able to say whether this treatment is safe and whether it works?
The trials that the Cochrane Review selected had these particular elements to them. So first of all the trials recruited women at risk of premature labour. The treatment they were testing were corticosteroids. And what was it compared to? It was compared to a dummy, a placebo injection, or no treatment at all. And what did they measure? In terms of efficacy, they looked at the number of babies dying at birth, the incidence of neonatal lung complications, and any other serious health problems associated with prematurity. And for safety, they looked at minor and serious adverse effects to the mother or the baby. What did the review find? Let's come back to the Cochrane logo again. That purple diagram in the middle of the blue circle actually represents the Cochrane systematic review looking at whether giving corticosteroids before premature birth help prevent neonatal newborn mortality. Each of the horizontal lines represents a clinical trial that was included in the systematic review. As you can see, the first one was in 1972, and there were 7 altogether. The last included in this particular review was in 1991. The vertical line represents where there is no difference between the treatment, which is corticosteroids, and the placebo that it was compared to. So to the left of the line, giving corticosteroids is beneficial. To the right of the line, giving placebo is beneficial. Now, as you can see, not all of the lines, all of the clinical trials lie convincingly to the left of that vertical line. Some of them do just spill over that vertical line of no effect. But as Selina has explained to you, doing a systematic review and bringing all of the data together can then make the picture clearer. And that diamond at the bottom is actually the summary effect of putting all that data together. And as you can see, it lies convincingly to the left of that vertical line. In other words, indicating that giving corticosteroids antenatally before delivery, when a baby is due to be born prematurely, actually saves lives. And it's estimated that actually doing this decreases the incidence of early neonatal death by somewhere between 30 and 50%. And it's clear that thousands of babies' lives have actually been saved by this treatment. Until 1991, when that final trial was completed, and when the Cochrane Review was then published shortly after, it wasn't standard treatment. But after the Cochrane Review was published, it became standard treatment in this country. But nothing is ever quite straightforward. And just to put things in context, literally, I thought I'd just show you and talk to you about a paper that was written by Ian Chalmers. Now, Ian Chalmers was one of the founding fathers of Cochrane. And in fact, he commissioned that logo that we've been showing you and is up there, the top left-hand corner of this slide. He wrote a paper in response to a piece of research published in 2015. And what this research looked at is giving corticosteroids to women in premature labour in low-income countries. all the research that was brought together in the Cochrane Review was in high income countries. So the question was, well, what happens if this is now extrapolated to those with far poorer health infrastructure? You might not be surprised to hear that actually the results weren't the same. What was found is, in fact, there were more neonatal deaths, estimated something like between 3 and 4 excess neonatal deaths per 1,000, and a significant increase in maternal infection. Why did this happen? Well, the health infrastructure just isn't there as it is in high income countries. Access to antibiotics is much more difficult. The likelihood of having an intensive neonatal care unit is probably pretty limited. As a result of the paper that was published, the WHO actually put together guidelines as to, in these circumstances, whether or not steroids should be given, because it may be that they are more harmful than beneficial. An example, if you like, that context is really important in anything that we look at and any treatment we suggest.
We would like to share with you some sources of reliable health information, as we appreciate it can be difficult trying to keep up to date with all the research that's out there. So a few things to mention. Every couple of months at Cochrane UK, we publish a roundup of the latest Cochrane evidence and resources relevant to maternity care. These cover a range of topics from antenatal to postnatal care and care of the newborn. We include a variety of resources in different formats, so blogs, podcasts, graphics, and so on. And we always include links to the full resources. So you'll find a brief summary on this page, but you'll also be able to go on to find further details should you wish. And you can find these roundups on our blog site, which is evidently cochrane.net. You can see that highlighted in red at the top of the screen there. We also have a series called Evidence for Maternity Care, which features blogs on topics relevant to you. We update these blogs as and when new evidence becomes available, so you can always go to them feeling confident that you are reading the latest Cochrane evidence, so they stay relevant, stay current, and you can see a number of examples on the screen here. Our blogs might be written in-house by our team or by researchers, midwives, for example, and occasionally they're written by those with personal experience. For example, we recently had a blog by a lady with diabetes who wrote about her pregnancy journey. We also have blogs that are very much pitched at pregnant women and their families. So that's also something that might be helpful to you. You could point women in your care to those blogs if they're interested in reading more for themselves. We also produce and share these graphics. This is just one example here. They basically summarize the key findings from a Cochrane review. These graphics include various different things. You can broadly see that they're split into 3 different text boxes there. The top one will tell you about the effects of the interventions. That's whether or not it's working. And then the second text box will talk to you about the potential harm, so minor or severe side effects, or if there was a lack of information about potential harms. And the third and final text box will tell you what that information is based on. So in this case, it's based on a Cochrane review published in January 2021, including 10 studies with around 1,300 women, and it will tell you exactly what that review looked at. You will also see that we talk about the certainty of the evidence. So for instance, if you are eagle-eyed, you might spot there that there's lots of low certainty evidence. So really not too high quality. We can't be too sure, but there's some indication that this may be the case. And you'll see that reflected in the language that we use there as well, saying that this may reduce the need for additional pain relief, for example. We share these using the hashtag that you can see there, Evidence for Maternity Care, on Twitter. So it's a good place to quickly and easily keep up to date with the latest. Here's some more links to evidence-based sources of information, some interesting reading as well. A quick mention as well of Students for Best Evidence, which you will see there on the left-hand side about halfway down. This is a blogging site for and by students interested in evidence-based healthcare. And if any of you would like to blog, they'd be very happy to welcome more midwifery students. If not, you're very welcome to just browse the resources on there. There's lots of information and tutorials to help you get to grips with research-based topics. And you might also like to find us on Twitter. That's where we share all of our blogs and our graphics and so on. So you can see our handle there is @Cochrane UK, but the one beneath that is for the Cochrane Pregnancy and Childbirth Group, and the general account as well as Students Best Evidence. And I'm sure you're following them, but we midwives as well, we would recommend following them if not. I hope that we can share this list with the organisers afterwards, so don't worry about trying to scribble those all down now.
So finally, our take-home messages. Evidence-based medicine is all about informed decision-making, and it brings together best research evidence, the clinical experience and knowledge of anyone we go to have advice on our health and well-being, and what we, as patients, as people who wish to improve our health, what we consider important for us. Whenever you look at evidence about treatment, there are questions that you should be asking. Is it effective and is it safe? And then, how certain is the evidence? Is it of good quality? Is the certainty such that we feel confident that it is giving us a truthful, accurate answer to the question that we want answered? Thank you, everyone. Hope this has been helpful, and we'd be delighted to answer any questions you might have.
Thank you very much. It was absolutely fascinating. I was sitting here making notes and just waiting to see if anyone else has got any questions. Hopefully, while I'm waiting for those, we have a few moments. Can I just ask, I mean, I know it's such high profile at the moment, but with COVID and with pregnant women obviously being encouraged to have the vaccine, and your final take-home messages probably summarise how many pregnant women, I think, feel at the moment. You know, is it effective and is it safe? Where does Cochrane, and how have you, worked over the last 18 months or so on particularly the vaccine for pregnant women? Because I suspect the evidence is fairly low effectiveness that you would be looking at normally.
I'm not aware that we've got a published review on the COVID vaccine in pregnancy, and that may well be something in the pipeline. Cochrane has done a lot of work since the pandemic started and has produced what are called rapid reviews. Ordinarily, a review takes of the order of 12 months, and these reviews have been turned around in a matter of weeks and a few months rather than the normal length of time. And as I say, I'm not aware. I'm looking at Selena. I don't think you were shaking your head. We certainly haven't seen one. And the particular, we have a meeting once a week that looks at all the reviews that are coming through, and that hasn't been one that's featured yet. But yes, watch this space. I'm sure that is a topic that Cochrane will be particularly interested in looking at.
Yeah, I do. As I understand it, there is a forthcoming Cochrane review looking at the vaccines, but not as I know, focusing specifically on pregnant women, although that might be an analysis within that review. But yeah, we're looking forward to seeing that as well. I think it's the question on everybody's minds really at the moment, isn't it? Pregnant or not.
And it is indeed, it's one of the questions that's come through. I know so many pregnant individuals who are against having the vaccine due to the lack of evidence. That's a real challenge, I think, I'm a midwife, as a practitioner, trying to balance up what we would normally be doing, looking at that evidence and giving the best information and the best resources to women. That's an interesting dilemma that certainly in my career, I've been a midwife nearly 40 years, I have I'm really trying to think if that's ever happened before. My closest analogy I would be with the whole issue about vitamin K many years ago. Linda, I mean, you're obviously a practitioner as well, have been a practitioner. Have you ever known anything like this before in your career?
No, nothing that compares with this. I suppose in terms of vaccination, the flu vaccine for pregnant women was something that is sort of similar, but there was so much more information at the time the decision was made as to safety and efficacy, that I think pregnant women could be much more readily confident that they were being given information that they could trust. With pregnant women, as I mentioned, you're not just dealing with one person. But if you look just at the COVID vaccine for the moment, something that we're frequently asked about is how was it that the vaccination was licensed so quickly? When, you know, we give the thalidomide example and say how very difficult and lengthy the process is now to get a drug licensed. Well, COVID is a time of extreme danger, and things had to happen fast. And various stages, I won't go into detail because I'm sure you've got lots of other questions, but various stages of the normal process could actually be concertinaed and could actually run in parallel rather than in sequence. And so without compromising the process to determine that the vaccine is safe and effective, it did happen much more quickly. You know, we locked down, didn't we, in March? It was deemed to be very much with us in February, and by Christmas time, the first vaccines were being rolled out, which is an extraordinary feat. But I can understand it makes people terribly anxious when normally that process would take 5 to 10 years. So giving it to pregnant women is yet another step of, well, it's a leap of faith, isn't it? And as time goes on, this is the other thing to say with any treatment, we aim to give enough time to pick up common side effects, but there will be some that don't manifest themselves for many, many years. And I'm afraid that's the situation that we're in. But life is a risk, and it's a balance between where we are, which is COVID, which is a potential killer, and having what would seem to be an extremely effective and so far safe vaccination available to us.
Thank you very much. Would you believe our time has gone by? It's been fascinating to hear you both speak and to put into some perspective the whole issue of Cochrane, and it would have been wrong on us not to have mentioned somewhere. There's text coming in with lots of people thanking you. I won't go through because there's lots. Another one about COVID, but those comments will be there, so you may have the opportunity, if you have time, to be able to comment back. So Selena, Linda, thank you very much again, and to the rest of you, enjoy the rest of your day. Thank you very much.
Thank you.
Bye-bye.
Bye.
Midwife working in 2030 is going to have to be adaptable, flexible, knowledgeable.
A lot more skills around kind of negotiating and advocacy for women.
It's multidisciplinary, it's working with students, doctors, partners.
In 2030, I hope very much that women, when they come into maternity services, receive a named midwife who is present for as much of that full journey as possible.
One of the benefits, I think, of a platform like this is that if you are busy clinically, or if you can't watch or listen or engage real time, you can do this at other times. So that is fabulous for such a time as this. So delighted to be with you all, albeit virtually on the screen. My name is Jacqueline Dunkley-Bent. I'm the Chief Midwifery Officer for the NHS in England.
So this is what's called a hybrid event. There are people in the room, there are people watching in groups around the country, and there are people still watching in their pajamas at home. Good morning, Sue, how are you?
Good morning. I'm fine, Neil. Thank you very much. It's fantastic to be here.
My argument is that the solution is health optimization. Prevention is far better than cure.
And I think there is a real risk that services that are lost or reduced during the time of COVID are not restored.
And I hope that you can take valuable insights from today. And if you're listening tonight, or if you're listening next week or next month, take valuable insights from the speakers from today and share the word, share the positive messages with your colleagues, because in these dark times, in these challenging times, everybody needs a green shoot and a pearl of wisdom. Thank you very much, and we are in this together. We stand united together.
So welcome back to this next joint session between the Student Midwife Festival and the Educating Midwives Conference. This is the session where we will hear from Jackie Dunkley-Bent in a moment, the Chief Midwife for England. But first of all, let's go and have a look at some of the polls and things that you took this morning. So the first one was a word cloud about what did you like best about being midwifery education. And if you can see that on your screen now, you can see that the placements and clinical skills, empowerment, support from tutors, holistic experience. So quite interesting that placement is right at the center, because that was also the topic that we got a lot of the comments on about problems that people were having and how they felt about it. But that's also the bit that they clearly like the best. Looking around to see if there's any entertainment. Okay, let's see the results of the next poll. How likely are you to work abroad at some time? Now, we think this poll may have been distorted by the fact that we took it immediately after Fran McConville's rallying cry, but not likely, only a dream. Well, 23% have it as part of their career plan, 14% would do it temporarily, and some would do it as a volunteer. But for 28%, it's only a dream, and for another 28%, it's not likely. Well, interestingly, perhaps what Fran had to say will change some of those figures later on. Next, let's have a look at the next poll, please. Has your online experience been effective on a scale of 1 to 10, where 10 is excellent? So it looked like only 9% were giving it excellent. So a lot of people have liked it, but the numbers begin to go, percentages begin to go down. 9% said it was really poor. Another 9% were giving it 3s. So the spread of some of that looks quite, obviously a lot of people have had difficult experiences with online experiences. But, you know, 7 and 8 is quite good. So I think a lot of people have adapted, but the problem is it's not even, and that's been discussed amongst a lot of the educators as well. How can they support people in this, not just the COVID environment, but the new online environment? Let's have a look at the next one. Have your placement arrangements been affected or changed due to lack of qualified staff? So, yeah, 34% saying yes, it has too often, 26%. So that's more than half have had it often or too often, occasionally not at all, and so again, placement's really a big issue for people there. Okay, quite an interesting little poll, not entirely obviously self-selecting from this audience, but given the numbers we've got, I think quite interesting. So let's move on to our next speaker, and really one of the highlights of the day. I'm extremely pleased and delighted, I'm sure on behalf of all of you, to be joined by Jackie Dunkley-Bent, who is the Chief Midwifery Officer for England, and as Fran McConville was saying this morning, a role model for many senior midwifery leaders around the world, and who has been leading all of midwifery through this extremely difficult period over the past 18, 20 months now. And like the rest of us, I'm sure, is looking forward to something back to normal, except that Jackie has to try and plan as to what on earth normal will be, because she was in the middle of her transformation plan when all this broke out and is aiming to get that back up to speed. So it's with really great pleasure that I welcome Jackie Dunkley-Bent. And Jackie, the screen is yours.
Thank you very much. And I'm so excited to be here. I wished it could be in person. I have such a heart for student midwives and all those that are developing and growing within our midwifery family, for those who are in schools thinking about a career in midwifery, for those who are on the journey, for those who have completed the journey. What we do, what we absolutely do, will ripple through generations. Our contact, our narrative counts. And I'm sure many student midwives have heard your midwifery lecturers talk about the fact that what you do will ripple through generations. There are not many professions that can say that. So hello, good afternoon to you all. My name's Jacqueline Dunkley-Bent, and I'm the Chief Midwifery Officer for the NHS in England. So I'm going to move on to the next slide. I just want to say, first of all, before I do anything, I'd like to say thank you. Thank you to you. Thank you to your universities, to the lecturers, to the clinical academics, all those people that are supporting you in this space. Your growth is significant. We need you to graduate, to join the qualified midwifery family. So a huge thank you. It hasn't been easy during the pandemic. I know it hasn't. For some of you, your year 2 may well have been disrupted. Your year 3 may well have been disrupted in terms of the pandemic. So I just want to say a huge thank you. We have moved forward against a backdrop of fear, against a backdrop of being anxious, being worried, all manner of feelings culminating in one. I just wanted to show this slide because I just wanted to show you that as the Chief Midwifery Officer, whilst I'm advising at lofty heights and supporting policy and everything else and being a leader for our services in England, I also work clinically. So this is me donned on a clinical shift, starting at the beginning and going way beyond the end, because this particular shift was a water birth in PPE. So I just want you to know that I truly believe that to be an authentic leader, I have to walk and step in your shoes. And that's why I frequent clinical practice to do that. So thank you. Thank you for everything that you have done, that you're doing now, and that you will continue to do going forward. On to the next slide. So I just want to share with you a few items about my ambition as a Chief Midwifery Officer. And the overriding ambition is that England is the safest place in the world to be pregnant, birth, and transition into parenthood. Also, to have a workforce that feels valued, so important, respected, and invested in. So that's my overall ambition for maternity care provision in England. And those tables at the bottom, how are we going to achieve that ambition? And it's a dynamic process, I think. But first of all, I will say that we need to build capacity within midwifery leadership at a national level, regional level, and local level. What I will say, despite all the challenges of the past 2 years, and we're still in the challenge because we have winter to come, we have gained momentum with developing a career framework for you so that you might one day aspire to be. So we have at the moment, I have 2 deputy chief midwifery officers. There are 7 regional chief midwives. So for those of you that don't know, England is split into 7 NHS regions. And we have a regional chief midwife in each region who has a deputy chief midwife. They've just come on board in recent weeks. And there is a regional obstetrician that will contribute to that portfolio, not full-time, but part-time. So at a regional level, there's a regional chief midwife, a deputy, and a regional obstetrician. And so that's just a little example of how we've been growing the infrastructure to provide good leadership for our services. In my office at a national level, we have a researcher, a midwife called, well, she needs no introduction, Professor Jane Sandel, who is the head of midwifery and maternity research at NHS England Improvement. We also have Wendy Oleyawola, who is the National Inequality Lead for NHS England, leading on maternity from a woman's perspective, a user's perspective, women and people perspective, and also a staff perspective. And of course, we have Jules Gudgeon, who is a joint appointment between my office and NHS Digital to lead on digital maternity. So that's just a little example of building an infrastructure, but we also are in the place of supporting heads and directors of midwifery and other aspirant leaders. And I'm going to tell you a little bit more about them later. But the second building block is about improving perceptions. And don't we need to improve the perceptions of our amazing profession, least of all to the public and the press? I get a little bit tired of negative headlines about maternity when I can see the amazing work that's being done to care for and to support women and their families on their birthing journey. And naturally, it goes without saying, quality and safety. Everything that we're doing is predicated by that quality and safety agenda. So moving on to the next slide. Now that is still my ambition, of course it is, but who would have thought that on the 30th of January 2020, this was going to land on our doorsteps, and on the 11th of March, we enter into territory that nobody has, well, I've never entered that kind of territory in the course of my lifetime and my working life in the NHS, and you have felt it like I have too. And sadly, we've lost some midwives along the way, and we've lost women pregnant women and people along the way too. Everybody gets scared some of the times. I've been scared too, but together it creates a different picture. So on to the next slide, on to the challenges. So we've had many challenges, and I've shared a few of them already with you. That the pandemic was announced, and that meant that we had sickness because of the pandemic. We had people that were shielding. We had, and still are having, death, the fear. We had to suspend some of our services. Home birth services were suspended. Midwifery-led services were suspended, and some freestanding midwifery units temporarily closed their doors. And that meant that, sadly, many women lost choice of place of birth. But the overwhelming ambition was to keep people safe. So we had to pull staff together. It was the only way, and I trust our leaders implicitly with how they've managed that process. We had to deal with the headlines of the visiting restrictions. Some of you may well remember the Mail on Sunday, 7 weeks of negative press about us not allowing visitors in maternity services. And actually the truth is that every woman was able to have their partner or their husband or everybody, regardless of whether they were female or identified as female or not, were allowed to have their partners with them during established labour. And then in more recent times, visiting restrictions have been lifted, but the headlines were not kind. We had to suspend and change our trajectories for the MTP, which is the Maternity Transformation Programme, the vehicle that's delivering the Better Births report. We had to change some of our ambitions with regard to the long-term plan, particularly the mental health provision and the pelvic health provision. They're two key items that I lead on that will really help in terms of women's health and perinatal mental health. Many of us were working clinically. In the middle of all that, I had to give evidence along with Matthew Jolly, the National Clinical Director, to the Health and Social Care Committee, who were undertaking an inquiry into maternity safety. We had to give evidence twice, and then a third time to their specialist committee against the backdrop of the Afghanistan resettlement program, where we had pregnant women from Afghanistan that we had to support and continue to support. It's the right thing to do. We had the fuel crises where community midwives were struggling with diesel, and that's against the backdrop of the vaccine hesitancy, the conspiracy theories, etc., etc. I could go on, and I'll speak to you a little bit about vaccinations as we progress. And we have winter and flu. But despite all that, you are doing a phenomenal job at supporting women, people, babies and their families right now in this space. On to the next slide. We have challenges in relation to inequality, and this is no news to many of you. So if we can just point to the fact that maternal mortality, yes, we are doing better. However, rates are high for Black, mixed ethnicity and Asian women. Stillbirths, we're doing well in terms of our reduction to meet the 2025 ambition, but we need to work harder for these groups that you can see here. Neonatal mortality, we're doing well, but rates are high and increasing for Black and Asian babies. So we have much to do, and we are doing much in this space despite the pandemic. On to the next slide. And just a moment of pause. You may well have seen this already, but it's really, really important to know the difference between the two. And with regard to equity, that's the space that we want to be in. We want everybody to have the same outcomes as those who have the best outcomes and experiences. So to achieve that, we need to do something a little bit differently. And look at that little one in the purple jersey on the right. We are doing something differently in England for women who experience the worst outcomes. And I'll share a little bit more shortly. Next slide. So this is taken directly from UCOS. You can find this on the Embrace website. Just have a look at the figure of the woman on the right. So first wave, we had 9 women that died as a result of COVID. Second wave, it increased to 11, and we continue to increase. We only had the JCVI authorised vaccinations for pregnant women in spring this year. So we are catching up and we have a lot to do. But we know that the Delta variant is quite challenging for pregnant women particularly in the 3rd trimester. And we have evidence from the UCOS that shows that in a cohort sample of 171 women at one point, all were 171 women pregnant in hospital, sick with the Delta variant. All but 3 had not been vaccinated. And of the 3 that were vaccinated, they'd only received a single vaccine. So the point we're making is the majority of women in hospital pregnant on ECMO have not had a vaccine, which gives some credence to the fact that the vaccine provides protective effect for pregnant mums and their babies and people. And therefore, we are encouraging women to have an informed conversation about vaccine uptake so that they can make an informed decision following the JCVI guidance and indeed the Royal College of Obstetrics and Gynecology guidance. On to the next slide. Globally, again, I'm cantering around the world here in the pandemic. Globally, of course, we have much to do. And I just want you as students just to be mindful that for every challenge and problem we have here, just have a look at the global picture. Progress has been uneven to many, and they're still being left behind. We have on circa 810 maternal deaths every day and 1 stillbirth every 16 seconds. 2.4 million newborn deaths each year. And 1 in 5 women give birth without one of you. So I know this is relative, but every life, wherever they happen to be, is significant, is absolutely significant. So we have much to do, not just here, but globally. Are we challenged here? Yes, we are. And I've shown you data with regards to the inequality piece. Have a look further afield. We have much to do. And on to the next slide. This is really a moment of pause and reflection. And all of you, as you're forging your way in terms of your student midwifery career, thinking about what you'd like to do when you qualify, some of you may well end up in other countries supporting. I frequent international travel. This is at a conference in Abuja. in West Africa, and I was supporting qualified midwives on their CPD journey. And I know that quote from Mariangelo, absolutely. There's something about how we make people feel. The stuff that you do every day, every time you make contact with a woman, with a person, with babies and their families. There is something about how you make them feel that is remembered. So on to the next slide. What are we doing with all of the above? What have we done? You know, I could spend an awful lot of time going into detail, but you can see here we have been responsive to women in their families. One of the most challenging things about the pandemic for me as CMIDO was the negative narrative about maternity and women staying away because they were fearful. So that meant that when they engaged with maternity services, sometimes, you know, there was fetal demise, it was too late, and the outcomes were not what one would have expected. So really, really important to step in that space of engaging with women, encouraging them to join with us and receive maternity care. The 4-point plan that you can see there, I think it's bullet point number 5 or 6. This 4-point plan was really to try and reach out to those who have the worst outcomes and encourage them through their healthcare professionals, through you, through the midwives, to support them in a different way, lower the threshold for referral and treatment. So moving on to the next slide. What are we doing in this space for you, for us, for our people, for our family at this challenging time, despite the negativity, despite the concerns and complaints from every single platform I can imagine and think of? My Viber, my WhatsApp, my LinkedIn direct message, Twitter direct message, ordinary message, email, voicemail, all full with concerns, challenges. And I will say to you that this is a snapshot of what we are doing for our family, for our services, and of course the previous slide for women, people, babies and their families. So funding has been distributed now. We put in a bid, £95 million bid, and we to NHS England, and that bought us 1,200 more midwives that are currently being recruited, 100 obstetricians, backfill for MDT training, £52 million. That wasn't a part of the bid, but we've got an additional monies, £52 million for digital maturity. The international recruitment is going well. We have 400 applications being processed, and I think 18 offers have been made, but 400 applications are being processed. This takes time. There is a moral challenge, I know there is, about going into other countries and inviting midwives to work here, but many of these midwives have not got jobs and cannot provide for their families. We're working on retention, looking at preceptorship for you. So when you qualify, is there consistency in preceptorship across our maternity services? We're also working with partners to address morale concerns in midwifery. We have to raise the morale as leaders. For those leaders that are listening today, we cannot join in, and I know you know this, and you'd stand with me in solidarity. We cannot walk around being all morose, saying this is dreadful. Leading people means that we have to lead with passion and authenticity and do what's right. And doing what's right means that we are working with partners to raise that morale. The March for Midwives, the closed Facebook pages, the change.org petition, all these people are now supporting us, supporting me in that attrition piece, where also funding, we have funded services with Band 7 midwives to help provide some pastoral support for newly qualified midwives and also help with the attrition piece, also supporting the return to practice midwives. So I've asked services, find out where your retirees are and invite them back. Let's not rob Peter to pay Paul by finding a Band 7 within your service. Let's go externally and see if our retirees will come back and provide some pastoral support. In recent times, we've worked up a spec. This will be going out to NHS services any day soon to provide additional PMO program management support for our heads directors of midwifery, so they have time to think and be. Also, we are supporting recruitment of maternity support workers. We're going to be funding that. That letter's going to be going out soon, and also supporting their orientation and induction. And lastly, for all the professional midwifery advocates out in our system, we've got 800 in England and we need more, I know. Thank you to them, because they are really working hard to raise the morale. They're deploying restorative clinical supervision to really help in that psychological space. And in turn, we are training more, and we are offering a psychological boost to all our 800 PMAs in England so that they can offer it to you. And that's just the start of a 10. But moving on very quickly, we have to stay focused, of course we do. And for that reason, we are looking at how we can continue with our national ambitions. We published continuity of care guidance a few weeks ago, and we have listened to what everybody has said about the unintended consequences. So this guidance starts by saying we cannot have further rollout of continuity of care until we have safe staffing in place, engagement with staff, and education of staff. They're three key building blocks. So for everybody that's worried and concerned, these are the building blocks that need to be in place before further rollout. But this ambition will not go away. Why? Because it saves lives and it's the right thing to do. On to the next slide. So, that was on to the next slide. So I just would like to say to you, and I'm nearly finishing, and I'm just going to take a moment to pause. This quote I have remembered most days in the last 2 years. You know that Kamala Harris was the 49th vice president of the United States. She says, and I resonate on this most days, my daily challenge to myself is to be part of the solution, to be a joyful warrior in the battle for the soul of the country. And I add the battle for the soul of our profession, our midwifery profession. The battle will not stop. My challenge to you is to join that effort. Let's not throw up our hands. And there are many throwing up of hands at the moment, when it's time to roll up our sleeves. Because years from now, this moment will pass. It has to pass. And our children, our grandchildren, if you haven't got them and you don't want to ever have them, your friends' children, your family's children, grandchildren, they will ask us where we were when the stakes were so high. They will ask us what it was like. And I don't just want to tell them how we felt. I want to tell them what we did. Really important. Let's not throw up our hands. Let's join and roll up our sleeves. So my final slide to you. My final slide to you. This is our time. I started by saying what we do ripples through generations. The environment in the womb now will influence whether that person, when they're an adult, will have coronary artery disease. Look up Barker's work if you don't know that work. What we do and say will ripple through generations. So it's our time now. And for every student midwife that's listening, junior or senior, do we do nothing? Do we do little? Do we do our best or do what's right? And from where I'm sitting, I think that we are being our best, we are doing our best, and we are absolutely doing what's right. Thank you.
Thank you very much, Jackie. Tremendous sort of rallying cry for people in a week when, as you mentioned, you know, headlines and things have continued to be pessimistic, and sometimes the narrative has been negative. But nonetheless, when you look at the achievements of keeping the service going, keeping people safe and delivering. It really has been a monumental effort over the past 20 months. So now we're joined by our panel, and if I can remind people that put their questions into the chat, questions for Jackie Dunkley-Bent. And let's start off with Nikki Clark. So I'm going to go to you first and just say, what's your reflection on what you've heard from Jackie this morning? What would you pick out in 1 minute?
What a journey is what I would say. What a journey we have had. If only we knew that we could actually change programs, how we have done, how we've adapted, how we've changed, excuse me, placements around, how programs haven't run, how we expected to. I've been in education some time, and I've never known a time like this. Exactly like Jackie says, we will look back on this, and one thing that will always, I think, resonate with me is how we pulled together. The partnership working.
Prableen, what's your reflection?
Sorry, it's just on mute. First, I want to say thank you so much for that presentation. I think that last quote that you gave us was really inspirational. And also what you spoke about right at the start about you want the workforce to feel valued, respected and invested in. And I think as a fourth year midwife, a student midwife now qualifying, hopefully by the end of the year, and then embarking on a new career, I think it's really helpful to know that, you know, this is what's being done for us. And I feel like as a student, sometimes you're quite restricted. And if you don't feel valued and if you don't feel like you're invested in, there's not so much scope and there's not a lot you can do with that. But if you do feel valued in, there's a lot more you can do with that. So thank you so much for that.
Okay. Jane, your 1 minute reflection on.
Yeah, excuse me. Yes, I would echo what's being said, but what really resonated with me was the passion that came out in Jackie's presentation. Because excuse me, I think, you know, there's been quite a lot of negativity between practice and education, that we have probably lost sight of what we really are about. And we're here for women and for families and babies ultimately. And I think students, you know, you've heard from Jackie now, that this is really what has inspired you to come into the profession. We've got our job to keep you, you know, to graduate and become part of the workforce. We don't want to lose you, and we have got to rally together. The whole purpose of it is working together. We are working together, but I think sometimes the negativity that is shown on social media particularly can actually take place of all the goodness. And we probably need to publicise more of the goodness rather than the negativity. And thank you, Jackie, for reinforcing that, because that's really re-infused my passion and why I'm actually in education, like Nikki, been in it for goodness knows how many years.
So Wendy, your reflection, and have you got a question for Jackie?
Yeah, I just wanted to say I really appreciate the focus and the appreciation for student and developing midwives. It's really inspiring that as a leader, you're authentic and you have a really positive outlook. Like you said in the beginning, you're walking in our shoes, you're sharing that experience, and that's what we look for in a leader, and that's why students, we feel so confident to walk in your stride and to contribute towards a common a joint goal and ambition, as you said, to transform midwifery. So, and I guess my question to you is, recently in our lectures, we've been having a conversation and discussion about like new guidelines, for example, and I thought it'd be interesting to ask you, as your chief officer midwifery, there was a draft new guideline about, obviously because the statistics about the BAME women having a higher chance to die, probability, like morbidity to die. There was a new draft in the guidelines about them being induced earlier. I was wondering if you can enlighten us on your opinion on inducing a specific group of women earlier because of the statistics.
Jackie, that's been one of the big issues really emerged through the COVID period. So over to you.
Thank you, and thank you for that really good question. NHS England are stakeholders to responding to NICE guidance, draft guidance, and we sent our response as a stakeholder back to NICE. And my message would be, so that the guidance, the feedback has gone back to NICE. My message would be, I think every woman needs to be treated individually. Her care, if it's a person that's not recognizing themselves as a woman, so I'm speaking about women and people, care needs to be individualized. It needs to be personalized. So everybody's situation is different. Blanket policies do not always work in this space, and so that would be my overriding message back to services.
I agree. Thank you.
We've got an online question here which picks up on that point about everybody's personal care. It says they're anonymous, but they say that I am a huge advocate of continuity of care. But they say they're really glad to hear it's being postponed until it's safe for both women and midwives. I'm not sure that that is entirely the position, but we've certainly had a lot of feedback about continuity of care and rolling it out in these difficult circumstances. Where do you think we are on that at the moment, Jackie?
Yeah, thank you. And thank you for that person being so honest. It's the elephant in the room and it needs to be looked at. It needs to be deconstructed and dealt with, because we haven't got time to hide things. We've got to talk about them. So we have 1/6 of women in England that are receiving true continuity of care during the antenatal, intrapartum, postpartum period. During the pandemic, people have pushed forward with continuity of care for those who are more likely to experience the worst outcomes. Continuity of care, as we know, reduces preterm birth by 24%. Black women, South Asian women are more likely to have preterm birth. If you have a preterm birth, you're more likely to have a stillbirth and neonatal death. We know the sequelae of that situation. However, because of the challenges, we have listened to what everybody has said. We have listened, we've run round tables, we've listened to all the concerns of most people representing different groups. And that's why we have developed new continuity of care guidance that starts with the building blocks. These 3 building blocks, safe staffing, engagement with staff, education, must be in place prior to further rollout. The target still remains. If you can't meet the building blocks, you can't meet the target. So it's a meeting of minds, and it's trying to get an understanding of where people are at so that we can move forward safely. But we cannot obliterate continuity of care because we are an evidence-based profession, and the evidence says if you deploy this model, you improve outcomes. So it's like having the magic formula and never using it. And there's a moral challenge with that. So nationally, the ambition continues. What has changed is the time frame for achieving that ambition will be different depending on where people are at.
Okay, another question here on negativity is not just on social media. They say every shift I'm on placement, I'm faced with negativity from qualified midwives. Now, there's been a lot of talk about the stress that people are under. How should heads of midwifery and leaders, working on the ground, try and keep morale up? I'm not advocating community singing, but it's clear that keeping a positive atmosphere is proving very challenging at the moment.
Absolutely, and this is why we have that £95 million business case that will buy us more midwives. I think, I have challenges on, rather messages on Twitter at CMIDO, there is no water on the labour ward. At CMIDO, I haven't had a break. There is something about organisations being able to support and nurture their people. I know peak activity means that things are challenged, but even when peak activity occurs, if you have happy staff, somebody's making the toast, somebody's ordering the pizza, you're a family and you work through those peaks together. I do think that if staff are valued and respected, they feel better even at peak activity. But we are supporting our heads and directors of midwifery with education, with programs that are supporting aspiring heads and directors of midwifery to accelerate them into those posts. So we need to get the staffing right. And I think that slide I showed you with all those boxes on, I hope that you will use that and circulate that, because that has got many, many interventions that we are doing to raise the morale, support our leaders, our managers, and indeed to support junior midwives, senior midwives, and student midwives. There is so much happening, but nobody focuses on the things that are happening that are positive, which is disappointing. But I say to students, have a think about when you were preparing for your interview to become a student midwife and you were going off to your university. You were chosen, you were chosen out of thousands of applications. I remember when I was LME, we had 1,800 applications for 100 places. And those 100 midwives, I would say students, I would say to them, you are here because you have a unique and significant contribution to the midwifery family. You've been chosen out of all these people. Remember, try and remember what that felt like when the going gets tough.
Jane, a question to you. So just as some of the transformation work and continuity of care is being rolled out, how do you feel restoring the education process is going as we hopefully come out of COVID? And what would you ask of Jackie? What would be the one thing you would want to be speeded up?
I personally feel it's going really back to the continuity of carer model, continuity of care. And I know we can't speed it up until the service is able to support it. We do have student midwives who caseload during their training anyway. And I think certainly by the time that they graduate, they ought to be, we could actually utilise those new graduates to influence a change in the culture. Because there are midwives who, it will be a total change in culture, that they've never worked in a continuity of care model. But I think our students are the lifeline really for the future, to be able to influence that. It's not going to work overnight. It will, take some time, but certainly the students could be utilised more effectively.
Okay. Praveen, question from you. What from the discussion, what are you going to go and do afterwards with your mates? What are you going to get your society and others to do?
I think it's very interesting with the whole conversation on continuity of care, because it's something that we do talk about a lot, and we have had a lot of midwives from other trusts coming to us and talking us through the continuity of care teams. And also in Leicester, we had a team who's not now effective because of the stress and the workload, so they haven't been working as they should be working. But I think as there's a lot of things I do want to do, in the future. And I think we spoke about earlier about, global midwifery, leading, but I think continuity of care is something that you can incorporate all those things into. So you can do that whilst being in the UK and also being abroad as well. So that is a model that I'd love to adapt. And, hopefully in the next few years when it does become more effective, that is something that I'd love to do.
And Jackie, lastly, can you just return to the very topical question about the vaccinations and persuasion and the role of the midwife, and the dilemmas that people are obviously feeling, some of which are clearly held amongst midwives themselves, not just amongst mothers. Just talk, you did mention that, just address that question again.
Yes, well, we have, the positive thing is we have 93% of midwives that are vaccinated. So I think that's really, really positive. And I think, it was announced that vaccinations will be mandated amongst all NHS workers. Many would say that's a good thing. Some are reticent about it. What I say, and I will always say, is to help people to do the right thing, we must listen, understand, and then act. That's the only way to affect good change. People are reticent for reasons, so we need to understand and work with them so that they can do the right thing. I think with regard to the women having vaccinations, what we've done from a national perspective is encourage the vaccination cells to frequent antenatal clinics so that women aren't being sent off to vaccination centres, because they are more likely to, having had an informed conversation with their health professional, take the vaccine if it is within the maternity environment. It is a challenging thing to do and to ask women to do. I have been trolled by the anti-vaxxers. I will share this with you. I have had the Nuremberg Code thrown at me. I've had needles in my neck. I've had pictures of thalidomide babies presented to me. I've had blood on my hands pictures and many, many other things. I think as a leader in tough times, one has to accept that these things will happen. But we stand forward, standing on the evidence and thinking about what is right for people, and that is informed conversations so people can make an informed decision.
Okay, thank you very much on that very strong note. I think that's answered the question that one person asked about, how many could we lose if we don't have vaccinations? But I think the 93% vaccinated already shows the success of what Jackie and her colleagues have been doing. I'd like to thank all the panel who've taken part in this afternoon's discussion. Nikki and Jane and Prableen and Wendy. And I'd like to thank all of you. I think there's quite a mission has been set out for everybody, but an optimistic belief that it can be achieved. And in the comments that we're getting in, a lot of people and a lot of the groups have found it very inspiring and has cheered them up after quite a lot of negative coverage. So the session is now going to take a break, and then it'll be back on again at 1500. He says, looking carefully at his, 1545, sorry. So I will get off, and those of you that are in the lecturers forum, if you can go back, then we'll take it from there. So thank you to everybody.
Thank you. Bye-bye.
Thank you. Thank you, Neil.
Good afternoon, everybody. I hope you've had an interesting afternoon. I've certainly been listening in and watching the comments that have come through. So we're going to make this a very positive session this afternoon. We have groups of speakers. Nicole, first of all, Rajan Brown, who's a student midwife at University of Salford. And her topic is Leadership in Action, Finding Your Voice. So as we always say, the screen is yours.
Thank you very much. Thanks, Diane. So like Diane said, my name's Nicole. I'm a student midwife in my third year up in not so sunny Greater Manchester. And with my other hat on, I'm also editor-in-chief of the Student Midwife Journal. And today I wanted to talk to you about leadership and finding your voice, because I think it's something that students find quite difficult. I think many students find that leadership is a skill that seems kind of far away from what they would be doing as a student. And I'm really passionate about the fact that every student has the ability to lead and the ability to develop their skills throughout their student journey. So today I just wanted to talk to you a bit about how we can do that, how we can make steps forward and become leaders within midwifery as students. So I wanted to start with this phrase because it's a phrase that I hear bandied about so much. I'm just a student, only, simply, no more than. How many times have you said it? I'm going to guess that most of you have either said it, heard it said it to somebody, or felt it at some point in your midwifery journey as a student. I know I have. And this is kind of what got me thinking, really. How can we widen the perceptions of what leadership means in student midwifery? So I'm hoping that in the 15 minutes that I've got today, I know it's a bit of a big ask, but I can challenge some of these perceptions, that we can start to understand some of the responsibilities that we have as students to be leaders and to develop these leadership skills, and how we can make some steps forward in each of our leadership journeys, no matter where we are on that journey. And hopefully bust some myths about leadership along the way as well. I think a lot of us, when we think about the word leadership as students, think it's something for the future. It's a future student, future problem for future me, and not something that I need to be thinking about now. But actually, as we've seen today through a lot of the talks that we've had already, including from the two NMC representatives, Rena and Jackie, this morning, leadership does form an important part of the basis of what we're doing as student midwives. Both in the code and in the future midwife standards, it does mention leadership as a really important part of developing our skills as student midwives. And this is alongside kind of safe practice, effective midwifery practice. And I love in the code that it puts leadership alongside well-being and experiences. We've all come into midwifery because we care about the well-being of the families that we're looking after, and we care about improving their experiences. And the fact that the code puts leadership alongside these two things just shows that actually all of us have come into midwifery to be leaders for that exact reason, that we've got these the kind of person-centered approach that all midwives want, really. So it is something for now. It's a reason that we've kind of come into midwifery, like I said. It's kind of creating those foundations of care and transforming care, like Verena was talking about this morning. If we want to make a difference to those families that we're looking after, we need to strengthen and use this power that we have as students, as well as kind of qualified midwives, to develop and support the families that we're caring for in the here and now as students. The other way I suspect you've looked at leadership is a bit like this. You know, leadership is for something that when you're wearing your dark navy blue uniform, for your supervisors, for those who are kind of further up your band sevens, your heads of midwifery. But leadership doesn't have to look like that. And I think quite often there's a conflation between the word leader and the concept of leadership. It's more than just kind of being in that dark navy blue uniform. It's more than just a banding, and it's not just hierarchical. It's about promoting positive change, and that's what transformational leadership is all about. It's an approach that looks towards using the way that you act, the way that you are, what you do, to cause changes in the environment around you, the individuals that you're interacting with. And if we just look at this kind of little list of ways that we can be transformational leaders, these are all things that we do as student midwives. These are our core competencies that we're working on all the time, promoting best practice, basing our care in those important personal values, promoting relationship, communication, ethics, trust. They're all things that we have to be developing as students, and bringing these all together, we can be leaders and create transformation as students within our the areas in which we're working. So what does transformational leadership mean kind of in practice? I think it's all about creating ripples, and I know that when we've just been hearing from Jackie Dunkley-Bent, she's been talking about ripples as well, but I think it's a lovely way of thinking about it. You only need one small drop to make a ripple, and if you act in a certain way, if you behave in a certain way, if you do something, it causes reactions amongst others and the environments that you're in, and it creates that ripple effect, where that domino effect, where it kind of works outwards, and it creates an impact amongst other people through the way that they reflect on how you've acted or behaved in a certain situation. Now, because I've only got 15 minutes to talk to you, I've kind of boiled it down to the two ways that I feel that as students we can create ripples, and that's by being and doing. So the first one is being, and I think this is such a powerful thing. And in some of the comments that we've seen come back this afternoon about how other students have found the negativity within midwifery at the minute, particularly from older students, this is something that really important that we need to be considering as student midwives. But by being our values, our behaviours, our attributes, people notice how you are as a student midwife. People notice what you do, how you behave, the words you use. And I know that the phrase kind of be the change you want to see is super cheesy, but it is so true. Because people will notice a difference in you if you're kind of bucking the trend and not following that culture, that staff room culture. You're not following those cultural norms that you don't agree with. People will notice, and it does make a difference. And I think this is one of the hardest things to do, because it is really hard to move away from those cultural norms. And something I hear so often from student midwives that I speak to is that I really don't want to get dragged into those institutional norms. I don't want to become that kind of midwife. And it is really hard to do when you're on the ground and you're working and you want to maintain those relationships with those around you. And at the end of the day, that's not anything any midwife goes into midwifery to do. They don't go in to be pulled into those cultural and institutional norms. So it's really important that we consciously work to embody leadership through these values. And if we see it in this context of it being an action of leadership and an action of those ripples around us, I think it shows just how important it is that the way we value things, the way we behave, and the attributes that we have, how important they are within our practice, but also how we all have a role in this, because every single interaction you have, whether that's with a colleague, a peer, a mentor, or a family, it will make a difference. And secondly, by doing. Doing's a bit of an easier one to explain, I guess, and I just wanted to share a few ways that I've been inspired by people around me who are kind of demonstrating leadership skills, and a few ideas of how you guys can get involved as well. So I've put kind of the National Maternity Voices Partnership logo on there. National Maternity Voices are amazing groups which are kind of an interface between service users and maternity trusts, to create improvements within maternity services. Students have a voice, students have a say, students have a valuable thing to say. So I'd strongly encourage you to get involved with your local MVP. At the bottom here, I've got a wonderful picture of my midwifery society back home who are watching today. So shout out to all of my colleagues at the University of Salford. Every one of them is being a leader by being involved in the Midwifery Society. And if you've got a Midwifery Society at your university, I'd really recommend you get involved, whether that's organising events or just developing your own personal training, because in developing your own skills, that is a form of leadership. You're developing those behaviours, those attributes, and kind of building up that midwife that you want to be, that I was talking about just before. So get involved in your midwifery societies. And I know that the University of Derby have just set up their own midwifery society over the past couple of weeks. So if you've not got one, set one up. But But it doesn't have to be complicated. In the middle here, I've got a tweet by a lovely midwife, student midwife called Deepa, and she created a conversation online about midwives and their ability to access water whilst they're on shift. And this created a massive conversation from a couple of tweets, and the RCM got involved. And starting those conversations is such a kind of a powerful thing to do. And we've got Twitter, we've got Instagram, we've got Facebook. We can use these forums to link in with others who have similar ideas and similar experiences to us. On the left here, I've got an article by a lovely student nurse midwife in Malawi called Martin. Martin did something incredible during lockdown with simply a bucket of water and half a bottle of soap that he had at home. And through this, he created a hand washing station in his community, supporting those around him to understand about the importance of hand washing during the pandemic. And I think this is such a powerful thing, because it just shows with so little resource, you can make such a big impact. And he had a massive impact on his community with just a bucket and half a bottle of soap that he had left at home. So no matter who you are, where you are, or what you've got at your disposal, you can make a difference and you can be a leader. I've included Blood to Baby on here. I'm sure it's a campaign that many of you have heard of, but Hannah Tizard actually set it up as a student. And I think that's a massive inspiration, because, you know, we can make a big impact and a big difference as students. There is the scope there to do that, and you do have something important to say. And obviously I couldn't end without including the Student Midwife Journal, the wonderful editorial board that I get the chance to work with, and our authors are all leaders, supporting those around them to promote their own knowledge and working, and to raise voices of student midwives all over the world. So I hope that's given you some inspiration. You have the skills to transform services. You have the skills to be a student midwife who makes a difference. Commitment, empowerment, communication, emotional intelligence. These are all skills that you have, that you can use to influence those around you, and that you can use to make those ripples. You wouldn't be a student midwife on a midwifery program if you didn't have these skills at a basic level. Yes, they'll need development. Yes, they'll need honing, but you absolutely have these skills. And I know it's been mentioned today already that so many student midwives bring talent and skills from elsewhere as well. They bring kind of previous experience in, and those skills you can use for developing your leadership within student midwifery. Don't see yourself as starting again from the beginning because you're new in kind of the midwifery profession. You bring so much value in what you have already. So bring those skills in and use them as a foundation from which you can work on. So going back to this phrase that we started off with at the beginning, I'm just a student, only, simply, no more than. I hope that I've managed to change your mind a little bit, and it's a phrase that you won't use much anymore, and we'll change it to I am a student, that you have a position, you have a quality, you have an identity, and there is such a power in being a student. Use the opportunities you have, use the special time that this is to develop your leadership journey, because it is a real privilege to be able to have that chance and that time to be able to explore and expand on leadership skills. So I just want to end with a few steps on how you can move forward on your leadership journey, and how we all can. It's a journey I'm still very much walking on. I think it's important to say one step at a time. I think it's very easy seeing how what kind of others are doing within their own journeys and the achievements that others are making and the ripples that they're causing, to be a bit daunted by it and think that you have to go from 0 to 100 miles an hour all at once. It's very much a step-by-step journey. You don't need to do it all at once. Use your time as a student to develop the skills that you have, because studentship is a real gift for your leadership development. So just take it one step at a time, one drop, one ripple at a time. Reflection, it's something we're constantly talking about within student midwifery and midwifery in general, but it's still important within your leadership journey and developing these skills. Use, you know, discussions that you've had with people, interactions that you've had. Reflect on how you could use those to move forward in your journey, how you might act differently in a scenario, developing your emotional intelligence for understanding how your being and how you're doing that we talked about impacts on a situation, and how you can develop your skills further through reflection. And finally, you're not alone. You have other people to support you along this journey. We're all on it together. Use your midwifery societies, use your peers, your professional midwifery advocates who you'll find in your placement areas, practice supervisors and assessors, academic supervisors in university, and your online communities. Find those who have a similar passion to you, a similar voice, who want to create similar ripples and work together, because it is really important to find the people who can support you and the people kind of build that community around you to support your development in your leadership. So I hope that you will be going off and creating your own ripples, and I'd be more than happy to talk to anybody who has an interest in exploring it further. Thank you.
Thank you very much, Nicole. Fantastic start. We've got some questions coming in, but if I may, I'm going to save them till the end of the presentations because I think there'll be some maybe, I don't know yet, some crossover. So again, thank you very much. So it's my great pleasure now to introduce three colleagues, student midwives at the Robert Gordon University. We have Lauren Kennedy, Pia Caprioli and Charlotte Bevan. And Pia, I'm sorry if I've pronounced your surname wrong, but I hope I haven't. So the title of their presentation is Developing Sensitive and Compassionate Midwifery Knowledge and Skills for Women with Complex Social Needs, Learning in an Authentic and Meaningful Way. So again, the screen is yours.
Hi, so hello everyone. I'm Charlotte. Unfortunately, our amazing lecturer Emily isn't able to join us today, so it's my job to introduce our presentations from the Robert Gordon University. With me today are Lauren and Pia, and we want to share some knowledge that we gained through a module we studied as second year students in spring 2021. So this module was based on a caseload of 8 fictional women, of which we were able to choose one to be the named midwife for. These women had a range of social complexities, including surviving childhood sexual abuse, domestic violence, FGM, substance misuse, being deaf, and learning difficulties. We worked in groups with weekly caseload meetings to share and discuss our ideas and management plans for this caseload. The highlight of the module was the fantastic array of external speakers Emily and the module team were able to organise for us. Their names are on the side of the screen now. We'd especially like to thank Michelle Wright, Hannah James, Jenny Smith and Tracy Scorgie. Their valuable experience added to our presentations, our own presentations today. COVID-19 has impacted many things, university assessment obviously being one of them. Previously, this module had been assessed as a live presentation in front of the class, but obviously this year that wasn't possible. So we gained valuable technology experience learning to operate the recording software Panopto, and instead submitted a 15-minute miniature lecture and accompanying resource leaflet to help other students and midwives understand the additional care requirements of these women that had similar social complexities to the women on our caseload. Our following presentations are an overview of these additional care considerations that we learned about.
So hi, I'm Lauren, and today Charlotte and I are going to be discussing our presentation, which was based around discussing care for women and pregnant people with experience of childhood sexual abuse. So a bit of background: childhood sexual abuse is any act involving a child for the sexual gratification of another person, often in a position of power by age or maturity. Sexual abuse therefore covers touch, so physical acts of penetration, and non-touch abuse such as sexual language towards children and encouraging sexual behaviours. It's estimated that 1 in 20 children in the UK have been sexually abused. And from this figure, this is non-touch abuse. So touch-based abuse, they estimate 16.5% of children across the UK by the age of 18 have had some form of experience in sexual abuse. Over 1/3 of all reported sexual offences against children to the police are against children, and most of whom girls, and 90% of perpetrators are known to the child. So from these figures, we know that women, pregnant people are more likely to have experienced CSA, and this is why it's important to discuss among maternity colleagues. Approximately 20% of all women have this experience, and few will disclose this, meaning midwives will likely care for these people without knowing.
So some factors that influence the disclosure of sexual abuse can be grouped around 3 closely related themes. So societal judgment, lack of support from caregivers and peers, and the paralysing fear of the consequences of disclosure. Survivors may face prejudice within society, which can often discourage disclosure and prevent survivors from accessing support services. They may face stereotyping, such as the abuse that they experience was somehow encouraged or that they're overtly sexually promiscuous. Survivors can also feel that they would never be believed upon disclosing abuse. This can be especially relevant if the perpetrator is a close family relative of this child, which is often the case. Survivors can also fear unsupportive, angry, or scornful reactions from those they disclose to, as well as the fear of being disbelieved entirely. Some perpetrators will use intimidation to dissuade survivors from disclosing the abuse that they suffered. This paralyzing fear can last well into adulthood and far beyond the duration of the physical abuse. Additionally, fear of processes following disclosure, such as criminal investigations, court proceedings, and law enforcement, can inhibit the disclosure of abuse. So it's vital for midwives to keep in mind that for many women, their maternity care experience may be their first disclosure of abuse that's happened in childhood. Survivors often identify never being directly asked about abuse specifically in childhood. This leaves them feeling vulnerable from the outset of maternity care. In view of the prevalence of childhood sexual abuse, it is essential that midwives are reminded to ask all people specifically about abuse that may have occurred in childhood. People who are survivors of childhood sexual abuse are also at risk of increase of poor outcomes, both psychosocially and biomedically. It's important that midwife makes a holistic assessment of the woman's needs in order to provide care that adequately addresses all aspects of a survivor's health. Triggers are events or sensations that evoke emotionally distressing memories. For survivors of CSA, these can be things like medical examinations, such as VE, palpation, and even blood pressure monitoring, torches or dim lights, hushed voices or whispering, nakedness, and as well as being around unfamiliar environments or a lot of people. The triggers can be things that midwives would unfortunately ordinarily employ to aid relaxation, such as hushed voices and dim lights. So it's essential that all professionals involved in the care of a survivor are aware of their triggers. It may be beneficial for midwives to book longer appointments so survivors have the chance to fully address and discuss all potential triggers and to help them prepare for birth more effectively. Something identified by survivors as being almost universally re-traumatizing is having to retell their story multiple times to multiple professionals. The midwife is responsible for accurate and clear documentation that ensures all professionals involved in the care of a survivor of childhood sexual abuse are aware of their history. Survivors also report that potentially having antenatal education groups made up of other survivors of adverse childhood experiences can be beneficial to them as they'd feel less like outsiders. In addition to making care accessible, midwives may consider seeing survivors at home or in an environment more familiar to them, such as a local GP surgery rather than an antenatal clinic. Unfortunately, the production line that modern tertiary obstetric care has become is in many ways cold and insensitive. This is not appropriate for the care of survivors who require safety, warmth, reliability, and compassion from their caregivers at all times. Informed choice when choosing place of birth is essential to support survivors to avoid experiencing birth as re-traumatizing. The children of abused mothers are also up to 5 times more likely to be abused themselves when compared with children from non-abused mothers. There are several reasons posited for this, among them being disclosure resulting in social ostracization, lack of warm and nurturing familial relationships, and congruent social stress facilitating the continued cycle of abuse. Midwives are therefore optimally placed to aid in breaking this intergenerational cycle, with care being provided right at the start of the next generation.
I think it's really important to note that the presence of trauma doesn't inevitably cause bad outcomes, but the presence of trauma, like CSA, does increase the chance of physical and mental ill health. So you can see them here on the screen, things such as unexplained medical problems, obesity, poor mental health, externalizing behaviours such as substance use, and poor socioeconomic standing. As survivors often present with these complex physical and mental health histories and are at greater risk of adverse obstetric outcomes, midwife really has to work as part of the team and with part of the wider team in the MDT. These can include the GP, social work, specialist perinatal mental health teams, specialist midwives, and then any other medical care for pre-existing medical conditions. So the midwife is responsible for coordinating and organising these services on behalf of and in partnership with the woman or birthing person. But with the impact of these experiences on a pregnant person, it can be really varying. I'd particularly like to discuss now just the impact on confidence in and around parenthood. So society's role of a mother is centred around protecting and nurturing, and a person's own experience of being mothered can be really conflicting. Some survivors fear they won't be good mothers and feel no attachment or let down by their own. Societal expectation can then lead survivors to overprotecting due to fears the child will be harmed, and conversely, the child could be avoided, or there could be poor attachment to the baby. Midwives should support transition to parenthood by helping build confidence through a strengths-based approach with the whole family. This is existing and building on existing strengths and can be supported through the use of apps such as the Baby Buddy app with the shown here in the slide. Planning joint appointments with the MDT is really beneficial for survivors. They have more of a feeling of preparedness and support for them and their baby, and this should include the health visitor as they take on the care. As mentioned, the midwife should be responsible for coordinating care in partnership with pregnant people, and this is beneficial to feelings of control and high quality care. Continuity of care also helps eliminate the possibility of women seeing multiple different professionals. It provides women with stability and consistency, allowing for strong, trusting bonds between the midwife and the parent, fostering an emotionally safe environment where vulnerability is met with empathy and understanding. In order to foster this relationship, this therapeutic and strong relationship with the woman, midwife really has to work in a trauma-skilled way. Midwives need to be able to create a compassionate environment which is emotionally safe, and they can do this through active listening, validation, and sensitivity to facilitate these open conversations that are required with survivors. Working in a trauma-skilled way helps provide the best outcomes for survivors and their babies, and a positive birth experience can help support healing and recovery from traumatic sexual abuse. However, with increased pressure on midwives, complex needs require support, which is not always available. Third sector organisations can help reduce the strain on the health service, and we as students and soon-to-be midwives must be able to refer people to support which is specific to their needs. We know women and people with experience of CSA are more likely to be socially isolated and have difficulty forming friendships or relationships, and signposting to these local third sector organisations can provide them with the social support, reduce that loneliness, and these organisations often also provide self-help services so people can empower themselves, take control and learn in a way that's useful for them. Referral for the provision of care through these organisations will support the current and long-term contact past the perinatal period and drastically improve a family's quality of life. So you can see on the screen, the Survivors Trust is mentioned here. They have a really brilliant e-learning package available, NAPAC, and also some more local charities here, such as one for Dundee and Angus.
Perfect. So here we've used what we've learned about the care needs of survivors of CSA and applied it to infant feeding to illustrate the importance of supporting and prioritising people's choice within midwifery. Exclusive breastfeeding, of course, we know promotes a range of health benefits for both mother and child, as well as supporting intuitive bonding. However, in cases where the mother has been sexually abused as a child, it can actually prevent a range of challenges. Touching of their breasts, feeling exposed, as well as the sensations of breastfeeding can be deeply traumatizing to a survivor. And survivors report having privacy and one-to-one specialised breastfeeding support with a known midwife can help them overcome the challenging nature of breastfeeding. Some survivors, in fact, report that a successful breastfeeding journey, when handled sensitively, can be profoundly healing and help them to normalise their body and empower themselves to feel confident in their ability to parent their baby. So it's really vital that we as students know the impact that we can provide to women. However, survivors, like all people, are unique individuals, and some will choose to bottle feed. Their reasons for this may or may not be related to the experiences they had as children, and it's vital they are supported to make this informed choice to avoid compounding feelings of being out of control and furthering a negative self-perception. A trusting and reciprocal midwife-mother bond is optimal for facilitating these potentially difficult and emotional conversations. The promotion of self-efficacy and the prioritisation of women's choice is essential to them experiencing the perinatal period as positive and healing.
So we do have kind of these sources of e-learning here that we really encourage you to use, expand your own knowledge and be able to empower those you work with. And then we'll pass on to Pia. So thank you for listening to us.
Thank you. Pia, you just need to unmute when you're ready. Thank you.
So hi, my name is Pia, and my presentation today will discuss midwifery care for women who experience perinatal domestic abuse. So the Royal College of Midwives define domestic abuse as an incident or pattern of incidents of controlling, coercive, threatening behavior, also including sexual violence. And this can be perpetrated by partner or ex-partner or even family member or carers. So for the purposes of this presentation, the words woman, women intend to refer to all female victims and is inclusive of all gender identities. And unless specified otherwise, the words partner or perpetrator refer to male abusers. This is in line with the well-documented overwhelming prevalence of domestic abuse incidents, where the majority of victims is female, with 4 in 5 perpetrators being male. So in the UK, 1 in 4 women will experience domestic abuse or violence in their lifetime, and 2 women each week are killed by a partner or ex-partner. And also 1 in 5 children have been exposed to domestic abuse in the UK, either by witnessing the abuse or by being harmed by the perpetrator, which is also a form of child abuse. So domestic abuse tends to be generally underreported. However, Women's Aid found COVID-19 has significantly intensified it. So nearly 60% of survivors using domestic abuse services in the UK have children, and 1 in 15 are pregnant. And this is because pregnancy is a trigger for male violence, with 30% of domestic abuse starting in pregnancy, according to the RCM. So perinatal domestic abuse, of course, is associated with poor perinatal outcomes, such as twice the chance of preterm birth and low birth weight. And in particular, the well-known toxic trio associates domestic abuse with maternal substance misuse and mental ill health, with long-term adverse consequences on the general well-being of both mom and babies. So a bit about the social context. Domestic abuse is a form of gender-based violence deeply rooted into the systemic inequality between men and women, which is typical of patriarchal societies, and where the woman is still considered as a subordinate. So conjugal duties and domestic responsibility are usually the main sources of conflict, because pregnancy and postnatal period can be very demanding for women, so can trigger the partner's jealousy and need to maintain their authority. So also, social stigma is associated with disclosure and is very common. So domestic abuse is often hidden by women, because women feel ashamed, fear to lose their children, and to be blamed as unsuitable mothers. Also, stereotype can influence identification of domestic abuse. Typical assumption about minority ethnic women who would not want to live free from abuse, or how an abused woman should appear, should be avoided, because women of all ages, religion, gender identities, socioeconomic background, anyone can be a victim of domestic abuse. So in the next few slides, I will often use the pronouns we, us, to refer to both midwives and students, so just as continuous learners and future midwives. About our role and responsibilities. As midwives and students, our presence in such critical time for a woman means we are in a unique position to identify perinatal domestic abuse. And since the booking appointment, continuous assessment should be part of every antenatal and postnatal discussion, because onset or escalation of domestic abuse can happen at any time during the childbearing continuum. In addition, considering the woman's medical and obstetric history, but also observing her body language and also couple dynamics can help us spot warning signs. And this could be, for example, many terminations of pregnancy, many visits to the hospitals, even like preterm births, or even a partner that is always present and try to answer all the questions and diminishing her with jokes. And for this reason, if an interpreter is needed, we should ensure that the role is not filled by partners or family members, as it might affect disclosure, but also put her life at risk. However, in order to tackle domestic abuse effectively, an integrated approach is crucial to offer individualized continuity of care, and also allows everyone involved to be aware of the woman's history of abuse, as continuously repeating her story can increase the risk of re-traumatization. So Although we have to practice within legal and ethical boundaries, we are in the privileged position to advocate for her safety as well. One way to help a woman to escape her isolation and start breaking the cycle of abuse is providing helpful information and contacts, also involving third sector agencies such as Women's Aid. And also because leaving the relationship is the time where both the woman and her children are most at risk. Therefore, we should discuss with her a personal safety plan so that she can leave if she wants or if the violence escalates. So the woman should have always like an emergency bag packed with the essential clothes, money, documents, and also a safe place to stay that should be kept as a secret. Another important responsibility of the midwife is to assess the woman's level of risk for herself, her unborn baby, and her previous child or children. And if the risk of serious harm or murder is high, child and adult protection measures must be considered. So the experience of an abusive relationship makes it difficult for women to trust people and feel safe. And for that purpose, continuity of care is critical to encourage development of a trusting relationship and also create a safe space for disclosure, because it's likely to happen over time. However, research shows that women will only disclose if they are asked directly and repeatedly, but we should feel confident ourselves to be able to ask those intimate questions. It has also been demonstrated that women do not feel offended by being asked as long as a comfortable and private environment is provided. So framing the question sensitively and explaining how common domestic abuse is in pregnancy might also encourage disclosure. Furthermore, we must respond in a compassionate and empathetic manner, acknowledging and validating the abuse, because these women want to be heard and want to be believed. We should also kindly reassure the woman that it is her right to feel safe and that the abuse is not actually her fault. Also, we might need to be creative and arrange situation where the partner does not need to be present. For example, accompany the woman to the toilet for a urine sample, or even offer extra or longer appointment where he is specifically not invited, so we can spend time with the woman, more time with the woman, to get to know her as a person. And this flexibility of care and the regular support available can help the woman feel more empowered and self-confident. So overall, providing continuity of care for this group of women has the potential to nurture and educate them about their rights, encouraging changes in their lives, and helping them gain confidence as parents. In regarding to confidence, do we feel confident enough? So the RCM suggests that the vast majority of survivors tends to seek help from healthcare professionals instead of going to the police directly. However, evidence shows that midwives and student midwives do not feel prepared enough in screening and appropriately responding to disclosure of domestic abuse. This becomes a vicious cycle when then students cannot receive role modeling support in practice due to midwives' own lack of confidence in this area, and then with an ongoing impact on future midwives, on future students, and on the wider society. Therefore, university may play a key role in finding innovative ways within the university setting to prepare students to respond effectively to highly emotional situations. And this is what RGU aimed to do throughout this model, where we had a chance to meet guest speakers who had an experience of those complex needs, either as service users or professionals. So it definitely was an emotional learning approach in line with the nature of midwifery, because midwifery is well recognized as an emotional work. In conclusion, through ongoing assessment, early identification, and appropriate intervention, midwives and students can raise awareness and help break the intergenerational cycle of abuse, reducing gender and health inequalities, and fulfilling their powerful role of public health practitioners. So I would just like to express our gratitude to our fantastic lecturer, Emily Mishasha, for supporting our learning throughout this module and the past years. And also thanks to our special guest speakers, Hannah James, Jenny Smith, Tracy Scorgi, and Michelle Wright. So thank you for listening, and if you have any question about the topic or the presentation, we are here. And these are just further slides with resources for women and midwives that could be useful. Thank you very much.
Thank you very much. Some fantastic information and speakers there, and I do thank you. We are very pushed on time because I want to give you a chance to have a stretch, and also there'll be a poll after this group of presentations. And just to remind you that Sheena Byron will be back on live at 3:45. Couple of comments and one question have come in, so maybe if it's okay, just Nicole quickly. Really important message for the 2019 cohorts. I know a lot commented earlier who felt they were being undervalued by being removed from placement, but this shows how much we can add and how important we are and can be. We are not just students, so thank you for that. And the question is, how can we set up a midwifery society? We're the first cohort at the university and there's only 9 of us, exclamation mark. I'm sure you'll help them with that.
Yes, 9 is an absolutely great place to start, and it's such a legacy that you can leave to your university by setting one up. I have 2 tips. Firstly, get in touch with your student union because they will have all of the details on how to kind of formally set it up as a society at your university. But my second tip would be talk to your lecturers, get their support, use them as a support and advice. They are such a wealth of knowledge, and they can definitely help and support you through setting one up. Get on your social media, rally everyone round together and use other midwifery societies up and down the country to support kind of your development, because there's some that are very much established now who will be more than happy to support you in setting up your midwifery society, and I'm more than happy to chat with anybody who's interested about setting up a midwifery society.
Superb, thank you. Comment as well, please, if I may, for Lauren and Charlotte. Pia, I'm sure there's one coming, it's just getting it through. So thank you very much for this presentation. This is so interesting, especially when you said that hushed voices could be a trigger. You're right in saying that this may be something we do need to consider, although never thought it could be a trigger. This has made me think wider, thank you. And I have to say, I've been a midwife for 40 years and it was something that I'd never thought of either. So we all learn from each other, even if you're been around a little bit more longer than some of you. I would say, I think we have some fantastic leaders in front of us. Your enlightened way of looking at how you've had to work through the pandemic, the things that you've been doing are an absolute justification of why you've become midwives, and will do, I know, for some of you a little bit longer. We've got about 4 minutes. There haven't been any other questions or comments come through. Is there one final from all of you, one final take-home message? Let's start in reverse order. I'm going to be a chair and make that. Pia, one take-home message, if you would. Oh, just unmute yourself, Pia.
Just always try and put yourself forward. I'm going to be honest, for me, this is the first time of me speaking in public, and I am a very shy person. I get shy even when I have to raise my hand in class online. But I push myself because I have to, and so just try and do that. It's a huge effort behind that, but it's rewarding.
Thank you, Pia. Charlotte, Lauren, whoever wants to go first. Again, please. Yep, thank you.
So I think my biggest take-home message across this whole festival, and combining that with the knowledge we gained through our module specifically at RGU, is the difference that we can make as students. Touching on what Nicole said as well, you're never just a student, you're an integral part of that women's care team, and be empowered to make that change.
Lovely, yeah. Thank you.
Going on the back of that, like, we all have so many great ideas, and we can actually, by one person doing something, we currently are working on quality improvement that one of us is going to then put into practice before we even qualify. Like, we have so many ideas, we have the ability to reach out to this wonderful network of people, and we should use it because we are powerful in our own way, and we should go with it.
Thank you. Nicole.
Well, going on from that, that's exactly what I was going to say. I wanted to give everyone a challenge, never to say I'm just a student, and instead to use that power and say I am a student, and see what you can do from that kind of place of power. That's my challenge to everybody.
That's fantastic. And thank you. And Pia, just to say, a comment just came in. A colleague very kindly said, yes, I'm a survivor. I'm very passionate about these topics. The things included are so valuable and something I would have appreciated while on my own pregnancy and birth journey. So I think you've really, really raised these issues. Thank you very much. Please do the poll, have a break, come back, and maybe in the future, some of us will all meet in other ways. Stay safe. Thank you very much, everyone. Have a good afternoon.
Welcome back, everybody, to this final session. My name is Neil Stewart. I'm Editorial Director at the Maternity and Midwifery Forum. Well, we've had a very challenging day in many ways. For those of you who've just watched the Robert Gordon students and the presentation about abuse and triggers, I think that was an extraordinary piece, which I hope is shared widely around. Now, we've done a couple of polls, so we'll just put up the results of them. And I had to say, I chuckled when I saw this. Do you think you should be paid for the work you provide in hospitals? And the result is 80% yes, and only 20% no. This is one of the struggle issues that always comes back. And I think we had one other poll that we've taken since the last time that we showed them. And this one is, have you experienced assessment problems due to the number of midwifery qualified staff on your placement? And there you are, occasionally 34, too often 28%. And I think that reflects what was being said in lots of the comments, where people were being very supportive to their supervisory and other staff, that they themselves are run off their feet. But it does show that there are still. And then the tricky one for universities and others. Do you feel you've had value for money from your second or third year that's been impacted by COVID, when people have had to change the balance of their education and clinical placement and do so much online? And have you had value for money? 85% saying no. And I suspect that's reflected in other areas. But 15% saying yes. It's clear that a lot of people have adapted quite well to this environment. And so to our final session, which is designed to bring a bit of light and happiness to you. And our speaker, who some of you will know, is Sheena Byron, OBE, who's a director at All for Maternity and is one of our partners on the festivals. We do a tremendous amount of work with Sheena. Her daughter is currently speaking at the Education Lecturers session, running in parallel to this. So they have complete control of the airwaves at the moment. Sheena, the screen is yours, and I'll be back to join people at the end. Over to you, Sheena.
Thank you very much, Neil. Hello, everybody. I'm just going to get my slides properly working, just if you bear with me for one moment. There we go. Can you see that, Catherine? Is that great? So hello, everybody. I'm absolutely delighted to be here with you as the last speaker today. I hope there's some of you have stayed on. I'm sat here with my self-care candle burning beautifully, and I've got lots of things around me to help me to deliver this session, because like Neil said, thank you, Neil, like Neil said, I just wanted you to end the day on something that was hopeful and positive, and to give you some inspiration and encouragement, because I do believe that student midwives, whilst it sounds like a cliche, are the future. You are the future. And I think that you hold in the palms of your hands, such enormous opportunity for change, for positive change, even though at the moment we're seeing a lot of darkness and a lot of trauma. But there is light at the end of the tunnel, and you're actually going to be around to experience that light if you stay with us. And I'm just so grateful to you, like Jackie said, so grateful and thankful for what you're contributing to maternity services right now. It means so much to me. And I'm just going to move to show you this slide. In 1970, I was a student midwife. And I've been at lots of different roles over the years. I've worked as clinical midwife, as a manager, and latterly as a consultant. And the thing is, I just think that, I just want to share what I've learned over those 40 years with you, to pass it on so that what I've learned isn't wasted. And so I hope it helps. Like Neil said, at the moment, I'm working with my daughter, Anna, which is an amazing opportunity. We run the Practicing Midwife, the Student Midwife Journal, and All for Maternity. It's our business. And I don't like to call it a business, it's our organisation. And we are a platform that bases our fundamental values on kindness and compassion and mutual respect. and shared learning. So you've heard from our editor of our Student Midwife Journal. I was so impressed with Nicole's talk today, and I hope you were too, about leadership. Nicole is certainly a phenomenal leader, student midwife leader. So just a quick reflection. You've heard about all this today, so I'm not going to spend a lot of time because I want to spend time really on what we can do about the current situation. But just to show you that I'm not kind of talking with my head in the clouds, that I actually know that there are serious issues at the moment in the world. So what with climate change, with gender issues, both with women's gender issues and also the transgender issues, with racism and with the pandemic, we're facing all these serious issues, and it's impacting on maternity services. Every single one of these global situations is impacting on what we do on a daily basis. We have the situation where we have too little, too late intervention in some countries and too much too soon. And in many situations, we have the both running parallel together. Both are unacceptable, both are causing enormous amounts of harm. And from that harm, we see that women are, continually telling us that they're traumatized by the care that they get. But this is, whilst this looks like an old reference, it's still around this number. But I think this is underreported. The research that's been done doesn't reflect all the women who don't tell us how they feel. And I've got a particular passion for birth trauma, because I just feel that it's a reflection on what we're delivering in maternity care. And very often it's not down to what individuals are intending to do, but it's the systems and processes that we're working in. And these are the words that keep coming up time and time again, fear being the central point, where everybody's afraid, and that fear is directing what we do. So student midwives are you're feeling it because you're surrounded by midwives who are under pressure. And you're you're absorbing that, and you're feeling this trauma yourselves, and not feeling like you're having the right opportunities. And I can kind of get that because I'm consistently listening to student midwives and hearing what they say and trying to support them in practice. So I hear you, what you're saying. The Royal College of Midwives have just put out these statistics, which are beyond shocking as to what they're, reflecting of what's going on. And on the other hand, we've got gynecologists and obstetricians who are telling us the same thing. And actually, what in this paper, what it also tells us is that because they're feeling burnt out and stressed, they're more likely to intervene with a natural processes, physiological processes. So that's kind of worrying. Well, it's very worrying, and it's kind of is making the situation of too much too soon even worse. So we have to have a call for action, and in that call for action, we have to have courage, because sometimes, we feel that we feel so bombarded with what's going on that we forget, or we feel fearful to be courageous. And courage is part of being compassionate. And I'm going to share my reflections on that and some evidence around that right now. And this courage to be persistent is part of the compassionate leadership theory, where we have to have that as well as and alongside the courage to support and nurture each other and ourselves. I do believe that the humanisation of childbirth is the answer, because what this does is help us to think about how services are delivered, whether a woman has a caesarean section or whether she has a normal physiological birth. These are the things we should be focusing on, that we should have that we should move from a depersonalized, fragmented care, which we currently feel part of at the moment, to more a respectful relationship-based care. And that's what Jackie was talking about in relation to continuity of carer. We know that there's huge constraints around it at the moment, but it is the way that we should be working, and the way that doulas work and midwives really in the past have worked. And I certainly have provided continuity and know that the benefits that brings for both me and the women that we're caring for. That we very often think of the mother and baby as separate identities, and we should be keeping them together. That we have a mistrust of normal physiology and we focus on pathology and risk. And that we think that safety is all around medical intervention and unnecessary intervention and technology, that the environment is designed for clinicians, and that we focus on institutions instead of the woman at the centre of the care or person, and the eradication or limitation of mistrust in midwifery. But if we move towards the humanised care, then you can see that the things that we're striving for will be just normal and everyday practice. And this is at all levels. So right from the government right down to the touch we give to each woman or birthing person, this is everybody's business. It's not just what we do when we've got direct contact with women and families. This is about the politicians as well. So we have to keep lobbying for this type of care. And in the Practicing Midwife Journal, we've collated the evidence into a series of articles that were curated by Liz Newnham, who is the guru of humanisation, together with Leslie Page. And she actually wrote a book, Liz wrote a book called The Humanisation of Childbirth, based on her PhD. And we've collated all these articles together into a book. So if you're not a member of the Practicing Midwife Journal, then you can actually go on Orphan Maternity and buy these articles in a book for £2 and an ebook that will give you all the information you need. And so you can see that, this type of care, this connected care, trauma-informed care, where we treat everybody with dignity and respect, and that includes ourselves and each other, then that's when we're going to get better results. That's when services will be at the safest they can be. Just to tell you that beautiful cesarean section image, that isn't the anaesthetist, it's actually the partner. That's just a little thing to make you smile. So when we have this type of care, these are the words that come up: love, reciprocity, personalised care, sharing vulnerabilities, building relationships, compassion and kindness. And all these things together help us to feel sustained, they help us to continue doing what we're doing. And they certainly have with me in my career. Even now, when I'm challenging systems and challenging care, these are the things that I keep kind of going over and keep reminding myself about. These are the things that are important. And love forms the central point of all that. I don't know whether you've seen the documentary, It's Time, It's Birth Time. I saw it not last night, the night before, at the cinema in Preston. And actually they talked a lot about love, and I do too, because we have to love ourselves, our colleagues and each other, and I'll come on to that shortly. So courage and compassion for me are interlinked. They're just one goes alongside with the other. And this beautiful photograph by Dr. James Kent of his wife and his baby just after the birth of their baby. He missed the actual birth, unfortunately, but here he is, right slap bang in the middle of the pandemic. Such a profound image, because you see the midwife who has been told not to do this contact with birthing people and women is actually there loving someone. She's loving her. And that's what, when I've been sick just recently, it was the nurses that loved me, that gave me that type of care that helped me to get better. So when we think about compassion, what is it? Well, compassion isn't just about kindness and softness, and it's certainly not a weakness, but it's one of the most important declarations of strength and courage known to humanity. It is difficult and powerful, infectious and influential, and crucially, and perhaps the only universally recognized language with the ability to change the world. And when you think about the challenges we have at the moment with these global issues, if we can connect with our compassionate selves and really kind of think about how we practice compassionately, then we can make a difference. And that means to ourselves as well, because it comes back to us. Everything just comes back. So compassion in healthcare improves health outcomes, saves time, builds relationships, helps us to manage difficulties, promotes a sense of belonging and connects us. And it builds a sense of trust and loyalty. So when you think of the struggle that we're having at the moment, these are the things that could help us to maintain our work. And actually that's Michael West's works, and I've put the link there. If you Google Michael West and have a look at some of his YouTube clips and his books, you will find the references for this evidence. So already Nicole has mentioned about the ripple effect of when we do something positive, or when we support someone, or when we just give one slight kind of sign of kindness, whether we smile at someone, do you know, it ripples out. Just watch it happen. And I've tried to practice this. I've not always been successful all my career, and seen how it does ripple out. And I see it even now. And sometimes it's hard for me to be kind because someone's unkind to me. I've just had a tweet just right now before I came online that was where someone was being very unkind to me, and I just try to respond with kindness. And even though that doesn't always work, it just helps me to feel better. So watch it ripple out. But the very first step before we do anything is to think about ourselves, is to think, and this is again from Michael West's work on compassionate leadership, that we have to attend to ourselves, we have to pay attention and listen to ourselves with fascination. We have to understand the challenges we face, and we have to care for ourselves and take intelligent action to help ourselves. So like me with my self-care candle, when I saw the tweet, I just took a big, deep breath and thought about how to look after myself. And we have some practical things now that can help us that I never had when I was a young midwife or even a head of midwifery. I didn't have these amazing resources. So the first one I want to mention is Jan Smith's book. And Jan Smith, you've probably heard about her. She's a clinical psychologist, and she's done a lot of work with victims of birth trauma and of the carers, the trauma that they've experienced as well. And Jan has written this amazing book, and I've got a copy here. I have a couple of copies, and some I've written in everywhere in it. And what she does, Jan, is she helps us to understand the things that can make us make work sustainable, and how we can stay well whilst we're delivering care under stressful situations. And some of the tips that she gives us are just like 30 minutes. Some are 90 seconds. You can see here 30 to 90 seconds. Amazing book that can help to sustain us while we're working. So I have a lot of time for this book. It's really, really amazing. And she talks about, you know, looking after yourself. And in this, she also mentions caring for each other, which is absolutely crucial. Do you know, we really do need to love each other and support each other in practice. And Jan mentions the term reaching in rather than reaching out. So in that, she talks about rather than saying, how are you, as a greeting, ask it in a meaningful way, once, twice, 3 times, and make space to listen. Check in with someone by text, making a colleague a drink, seeking out a colleague and acknowledge their contribution to the team, normalizing that working in maternity is challenging and difficult, sending someone a card in the post. All these things are reaching in, and that really does help to sustain us at work. And another strategy that I've used a lot since I learned about it when I was working in clinical practice, I actually was fortunate enough to learn how to do this, and it really does work. So this is the ACT mnemonic. And when you see someone doing something that's really making a difference, it doesn't matter how small or how big. It could be how someone approaches a person on a corridor, for example, that's lost. It could be how someone dims the lights or how someone makes someone a cup of tea. Acknowledge that what they're doing is making a difference. Tell them that you've seen it and commend them. So acknowledge that you've seen it, commend them to others. So when you're around others, say, did you see what such and such a body did? It was brilliant and it really made a difference. And then ask that person to teach others. So just to give you an example, I heard a story about where a midwife heard a student midwife telling a mother who was about to go home all the things she needed for discharge. And she did it in such a way that it didn't take her long, but she got across all the information in a really compassionate way. And the midwife was so impressed with this that she acknowledged to the student, what I heard you doing behind that screen was quite phenomenal. And I'd really like to tell everybody about it. Is that okay? And the student said yes. So the midwife went out to the nurse's station and told everyone in front of the student. This student midwife did an amazing discharge conversation. And then she turned to the student and said, next time you do it, would you let others listen to what you do? And then you're passing it on. And this is this has a ripple effect as well. And if I had enough time, I would give you some more examples of where this is actually, we've seen the effect that it's had. It lifts the culture, either on the shift that you're working on, or the department, or the organisation. Authentic, positive feedback absolutely works. And really, it's, you know, when we think about this compassionate way of working, you know, and being courageous and standing up for the rights of women and birthing people and the rights of your colleagues, it's not always easy, or the rights for yourself. It's not easy at all. Like, for example, this March for Midwives hasn't been easy to organise. It's not easy to say that you're in with it because you're fearful, but we have to be courageous and we have to speak up, as well as being compassionate, and sometimes to have courageous conversations that, you know, that when we are feeling vulnerable or someone is being unkind to us, that we can actually stick up for ourselves or our colleagues. How many times do you hear people being criticised in public? What do you do about it? Do you stand by and let it happen? Or do you actually say, did you really mean to say that? Actually, I'm just going to show, no, it's not there. Sorry for flicking through. I didn't really mean to do that. I've actually got a slide missing, a slide that kind of shows where you can, the things that you can say when you want to be courageous and you want to speak up. This is an example of what happens when we deliver compassionate care. And this is just showing how it can be a very small thing. And when I asked this question on Twitter, when I asked when I asked out there sort of in public, give me an example of when someone's been compassionate to you and what you felt like. And this person responded to say this student midwife made a difference to her because she held her hand and she asked her to focus on her. And she didn't think her son would have been born healthy without the influence. Think of that impact that student midwife has had on that birth. And do you know, it was interesting because the response to this tweet was absolutely amazing. And others were saying, wouldn't it be great if we could connect this student with this mother who said this? And so it just shows, you know, one small thing that you do can really make a difference to someone's life, massive difference, which is just what Jackie was talking about in her talk. So even a smile, do you know, I can remember being, when I was sick and vulnerable just recently, going into a space and looking for the person who was smiling, because it's that person that reassures you, that makes you feel safer. And you know yourself, when you're working on a shift, if someone smiles at you as a student midwife, you will warm to them and automatically want to go to them, ask for help of that person. And also if something goes wrong, that you can go to that person because you feel that you've got a connection with them. So it really has a massive effect, smiling. So from me to you, these are just a few messages. Remember who you are. Remember why you came into midwifery, again, which is what Jackie mentioned. Take out the application that you made when you wanted to be a midwife and keep that at the central focus of your work. Keep it next to your heart, keep looking at it. And that will help you to be courageous too, because it's that type of care that you want to give, that you articulated, that got you into doing a midwifery. So remember who you are. Don't fit in with negative culture. So when you hear all this negativity going on, try to keep yourself separate from it, which is really hard sometimes because you want to fit in. I've been there. I've been in that situation myself all throughout my career. And I tried to distance myself from it, find someone who isn't being negative and stick to them like glue, a positive role model who you feel can help you through those times when it's challenging and when you feel like you're being pulled into that culture. Love your colleagues without expectation. So that means don't expect something back. Just give them your love, give them it and share it, and you see it will come back, but don't expect it. Find your tribe. And this isn't about being exclusive. This isn't about, you know, trying to find someone, but sort of being a clique and making, gathering people in and criticizing others. sort of in a negative way. I've seen that happening too. This is about being an inclusive tribe. This is about inviting others to join you and always saying everybody's welcome. I know that Nicole, who has just spoken previously, as talks about her midwifery society, and I can imagine the way Nicole works. She's very inclusive, and I just love the way that you gather people in and say, you can be part too. This is for you as well. And we try to do that at All for Maternity. Anyone can be part of our tribe. Nobody is excluded, and you can guarantee that if you join us, you will be loved. So that's the way we try to work. Start a book club. Now, this might sound really fluffy and bizarre, but it isn't, because actually I've got 2 books here. So one I've already mentioned, Jan's book, Nurturing Maternity Staff, but also this other wonderful book, which I've just discovered and I've been reading online, by Matt Haig. I don't know whether you've heard of Matt Haig, but he's a guy who's an author. He wrote Midnight Library, which is a fabulous book. But this book it's got small little quotes of inspiration, but they're meaningful. Do you know, they're not hairy fairy. They're just deeply meaningful, because Matt Haig was been depressed in his life, and he's also been suicidal. And a lot of the work that he writes is about how to combat anxiety and how to look after yourself. So what you could do in a book club, you could choose a book and then everybody read it. You can borrow it from the library or buy your own copy. And then, each take a chapter and feedback. That's what you can do in your tribe. And it might be a book that helps you to change practice, or that gives you ideas on how you can do that in your practice. What you say as student midwives and what you do absolutely can have a massive impact. And Nicole talked about some of the successes already. But you can be the spark that lights the flame. And I always say that you as student midwives are like the litmus paper, or you're like the mystery shopper. So you can go into an organisation and into a shift, and you can see firsthand what's going on, and you can feed back. And if you do it in a way, and you build your tribe, and you have a book club, and you get all these things together, you can do it with more confidence because you've got the support network around you. So just as a last kind of mention, I just wanted to say that, if we focus on safety and not on risk, on relationship-based care and not on system-based care, we could make maternity safer for everyone, women, health professionals and organisations. And I truly believe that is humanised care. Just to mention the practicing midwife, as I've already said, this is what we base our values on. We have all the resources that student midwives need. If you want to join us at the moment, you actually can get Jan Smith's book free of charge. And it's all on our Instagram page or on our Facebook page or our website too. It's all there. And just to finish off, I'd like to share a clip that's taken from women's voices and the voices of obstetricians and midwives. It was published, this film, this short film was created by NHS England, and it was published online, and you can still find it. It's called In Whose Shoes? And this is just a short clip from it. And what it does, it actually demonstrates the impact that midwives have, and that you can see the connection, even though this mother is deaf, you can see the connection between the mother and the midwife, bearing in mind it was before COVID, so the midwife hasn't got a mask on. But remember the smile, remember the smize, and remember that the connection is much more than seeing your mouth. It's kind of your whole demeanor. And I just love this, because I think this kind of just really helps us to understand that we have got a phenomenal job. We've got a phenomenal profession, and it really does not only save lives, but it changes lives too. So this is my last slide, and I'll just hopefully that this will work. So turn your sound up and listen to what is being said.
I've looked after a lady in labour who was hard of hearing, and she communicated by lip reading. I had to remember to keep looking up and using my thumbs and saying, yeah, the baby's coming. And just facial expressions. And when she delivered the baby, I just looked up at her, and she was crying, her partner was crying, and then I started crying. It was just lovely. after my son was born, they transfer you to the postnatal ward. Everybody who saw me said, congratulations, well done. And it made me feel like a queen, because it was kind of, I'd done the best thing that my body could do. I was encouraged to breastfeed, and for me, I did find it quite challenging. I was told a lot of different things, and I just wish the advice I'd been given by the midwives had been consistent. I've done antenatal, I've done labour ward for years, and I've done the community, and just the whole lot of it. I love the job.
Thank you. I don't know why that stopped, but thank you so much for listening. And just remember that I'm on each social media channel. You can, I'm just going to stop sharing now. You can contact me on any of those platforms, and I'd love to hear from you. So good luck. And again, thank you so much for everything that you're doing.
Okay, thank you very much. Sheena, we're getting lots of comments and things from people thanking you, saying that you always make them tear up when they're listening. How important it is to feel that kind of support. Amazing advice to avoid the negative culture. I think you always have that effect on people. I think it's very important, Sheena, don't you agree? It's very important at the moment that people actually invest time in being together and supporting one another. That's what we hope people are doing today. And a lot of midwives and student midwives have come together in watch parties. And I hope that afterwards they'll just take a little time to plan out how to do things together to support one another and to pick up some of the lessons. How important do you feel it is that people have, if you like, group time with peers, even in a busy schedule?
Yeah, I think it's important. And, you know, even human connection is crucial. And you can actually find all the scientific evidence around the importance of that. It's as important as getting outside. You know, we're human beings, and that's what we, you know, that's how we've survived, is by forming connections and relationships. And it's really important that even if you can't see each other face to face, that you stay connected via WhatsApp or via Zoom or Teams or however you do it. But, you know, as time goes on, we are going to be able to see each other. I mean, of course, I've been able to see you, Neil, at the conference in Wales, and we're going to Edinburgh as well. And I think that, you know, this message that I've been giving today, if each person that's listened to it could share that message as well, even during the hard times. Anna, my daughter, has been doing a program called One Thought, and she's worked really hard to do this program. And the person who established this program was actually a victim of serious trauma and has survived working in a crisis, and the way that he's functioned and been able to deliver care in a meaningful way has been using this kind of one thought element to his life, is a way you think about things. And I think we all have to kind of pass this information on, you know, like the books we read, the tips that we have so that we can help to look after each other. We don't always get it right, Neil. But yeah, getting together with each other and making that time to support someone. I sometimes get a little message from a student midwife that I met quite a long time ago, and she just says, "How are you?" And I think, oh wow, it pops up on my phone, and she really is thinking about me. And just that little message really does make a difference. The way you answer the phone, the way you respond to an email, all of those things can help us to sustain us, to help us to live a more positive life, and to keep us going during hard times. you know. So yeah, is that answering your question?
It certainly does.
Sorry.
It certainly does. Okay, well, I think, I mean, there's lots of messages from Rachel Cole, from Sam, from other people, Sheena, saying, thank you very much, it was great. There was one question that came in about, that they don't, doesn't say who it is from, but they don't feel that the system supports their role as a gatekeeper of normal birth. They're a third year, and they've cared for only a handful of women who have had intermittent actuation. How can I gain confidence in basic skills like this when I just don't see it due to medicalisation?
As a vacuum cleaner just gone off. No, I just heard a little noise. It might. No, so yeah, that's a really good question, and I'm so glad that you've asked it, because I was at an event on Saturday for the Radical Midwives Conference, and I would actually say it's potentially catastrophic. And what we're seeing is that everybody's being gathered up. It's almost like a super trawler of risk. Hannah Darlan once described it as that, and it seems to be getting worse, that we're gathering women into this, into the fold of risk and complications, when sometimes it's something very, very small, because we're fearful of what might happen if we don't do something. And what the consequences of that aren't just shocking for the individual woman or person, but what we're seeing is, because of the over-intervention of individuals who don't need it, the ones who do need it are potentially not getting it. And so that's when we see maternity services overburdened with too many inductions of labour, for example. And some of those women don't need an induction. They potentially don't need it. I say potentially, it's very important I use that word, because there's a fine line, and it's what that fine line is that's the issue. But we do know that we're intervening when we don't need to, because actually the latest statistics is that based on certain criteria, there's only the latest evaluation of what's going on in terms of the mode of birth, that in 2017 only 36% of women are having a birth without any intervention. So what does that say about our bodies? Are they not working properly now? I don't think so. I just think that we are intervening way too much, and the consequences are, as I say, dire. So I'm sorry that you're experiencing that. People like me and others are trying really hard. You asked the question about practical skills. Well, you will find someone within your maternity unit who is like-minded, and I would talk to them about it. Ask if you can go along. If you find out if there's any home births in your maternity service or birth centre births, ask if you can go, even on your time off, to observe. Have a look at some books. So there's plenty of books out there that you can look at and read. And if you want to message me afterwards, because I've not got them to hand, but there's books that kind of give you the practical skills around supporting physiology. There's one by Nikki Leap and Billy Hunter called Supporting Women in Labour. And that's got loads of tips in there, but there are plenty, and I can give you some more ideas if you want to message me afterwards. I hope that's answered your question.
I think that's a pretty comprehensive answer.
Challenge.
Okay, so I just want to thank Sheena and sort of bring some of this to a conclusion today. Can I thank everybody who's taken part and contributed? I hope you've had a very stimulating period. On the agenda now, there's 15 or 20 minutes for those of you that are meeting as groups or societies in lectures, theatres or seminars to debate what you've heard today, decide what you're going to do about it, plan your next meeting, your next get-together. These videos will be available afterwards. I particularly recommend that if you want to revisit Fran McConville's video and work through it slowly. It has some fantastic statistics and things in it. If you need an evaluation, if you can fill in the evaluation online, we'd be very grateful, especially with any suggestions for future topics that we need to cover. It's always good to get a poll. They always bring out things that we haven't thought about. If you need certificates, etc., just check on the website and in the chat, and we can arrange for those. And finally, to say thank you to all our speakers. And I think we've got some photographs that people have sent in from around the country. Do we have something to play us out on that, Catherine, at the end of today? Yep, so let's just leave everybody with some of the images of what's been going on amongst the 1,200 people who've been signed up around the country. And we won't get always from people internationally, but anyway, here we go. So thanks very much, and here's the pictures.